starting the session. May I request the chairpersons to please start the proceedings?
So
Thank you.
So good morning, everybody. So welcome all of you to the morning session. So in this morning session, the opening batsmen are Dr. B.K. Singh and Dr. Mrityunjay Singh. So the first talk is by Dr. B.K. Singh. He is on an interesting topic, that is the secondary diabetes. So Dr. B.K. Singh is the chairman API Bihar chapter, immediate past chairman RSSDI Bihar chapter, governing council member National API, regional and national faculty. He has papers and publication in Index Journal of national and international repute. So over to Dr. B.K. Singh sir for the talk on secondary diabetes.
Thank you, chairpersons, Dr. Arvinda and Soumya Sen Gupta. And good morning to all of you. First of all, I really thanks organizing team, particularly Dr. A.K. Birmani, Dr. A.K. Arya, and Dr. Ramkumar, Dr. Umesh Khan, and Dr. V.K. Mundra also, to giving me opportunity to speak on secondary diabetes in this prestigious conference of Japicon. I must, whenever any talk given by Dr. A.K. Birmani, he usually try to give me some topic which is very unrelated or very difficult to explain it. I once, when one of the topic he has given me in the last CCDSI is the mitochondrial diabetes. That is a very rare condition. Now it is secondary diabetes. This is not moving. Not moving.
Audio visual, this is not moving.
Yes. Thank you. क्या प्रॉब्लम हो रहा है? This one. First, the secondary diabetes can be defined as a diabetic condition that develops after the destruction of beta cell in the pancreatic island and or induction of insulin resistant via an acquired disease. So it is different from the primary diabetes. This secondary diabetes is a condition developed due to the secondary cause of that there is some other cause of this particular. And it is very less commonly seen, and it is nearly to 2 to 3% of all cases of diabetes. As per the CDC prevalence of diabetes in America, the type 2 diabetes is 90.9%, the type 1 diabetes is 5.8%, and other type of diabetes is nearly 3.3%. The Indian data are lacking, but it is nearly around 2 to 5% of the patient may have this secondary diabetes in nature. If you can see the WHO classification of different type of diabetes, there is type 1 diabetes, the type 2 diabetes, other specific type of diabetes, which is mainly the secondary diabetes, and the hyperglycemia first detected during pregnancy, there is the gestational diabetes, and another form is the hybrid form of diabetes and the unclassified diabetes. So my concern in this is the third number, the other specific type of diabetes, that is maybe initially known as the secondary diabetes. In other type of diabetes than secondary diabetes, there are many monogenic diabetes, the diabetes of exocrine pancreas, endocrine disorders, drug or chemical induced diabetes, infection related diabetes, uncommon form of immune-mediated diabetes, and other genetic syndrome associated with this diabetes. I will go one by one. If you can see that first is the monogenic diabetes. This monogenic diabetes is caused by the mutation or variation of single gene. As you know that the type 2 diabetes or type 1 diabetes may have this polygenic in nature, but monogenic diabetes is a mutation or variation of the single gene. Initially misdiagnosed in majority of cases, which lead to the inappropriate treatment, and the parents and grandparents usually have diabetes, means 3 generations of diabetes may be present in monogenic form of diabetes. The autoantibodies are negative, lack of feature of insulin resistance, that is the acanthosis nigricans and skin tag and other feature of insulin resistance, and the presence of C-peptides. The genetic test is confirmatory to diagnose this monogenic form of diabetes, and if you are able to diagnose this or you can suspect the monogenic diabetes, the insulin treatment, many of the patients of monogenic diabetes, insulin treatment may be avoided in that particular group of the patient. The second group is most important in the secondary form of diabetes is the diabetes of exocrine pancreas, also called the pancreatic diabetes. It includes both the structural and functional loss of exocrine as well as endocrine disease. It is also termed as the type 3 diabetes by the ADA. And there are many forms of this exocrine pancreas diabetes. The one is acute pancreatitis that may lead to the transient hyperglycemia. There is very chronic pancreatitis, mostly alcohol, gallstone, systemic disease, and all types of pancreatitis can lead to the permanent damage related to the diabetes. The third most important point, which is very common, which is not uncommon in our part of the world, is the FCPD, the fibrocalculous pancreatic diabetes. Unique form of diabetes, primarily limited to the tropics, and characterized by the pancreatic calcification, recurrent abdominal pain, steatorrhea, and diabetes mellitus. But these all patients may not develop the ketosis. This means ketosis is not a feature in the FCPD because there is some amount of insulin is present in the beta cells. The fourth important in the exocrine pancreas is the trauma or the surgical removal. The cystic fibrosis related disorders may be have, and the hemochromatosis, that is a bronze disease, may cause this exocrine pancreatic diabetes. The most important part in this secondary diabetes is the endocrine disorder, and the insulin antagonism is the mechanism behind certain disorder producing excess GH, growth hormone, that is cortisol, the glucagon, excess glucagon, or epinephrine and thyroxine may cause this secondary diabetes. The first is the acromegaly, and this acromegaly you can know that's caused by the GH secreting pituitary cell edema is the most common form of the acromegaly, resulting in the increased GH and the increased insulin growth factor 1 production in the liver that counteracts the action of insulin in liver and tissue, results in the increased hepatic glucose output mainly by glycogenolysis and partially by the gluconeogenesis and cause diabetes mellitus. So in 19 to 56% of the patient of this acromegaly may have the insulin intolerance or diabetes in this particular. The second is the Cushing syndrome that is caused by the chronic excessive glucocorticoids exposure, either exogenous or endogenous. The mechanism of hyperglycemia is hepatic gluconeogenesis, that is increased insulin resistance, decreased uptake of glucose in the muscles and the deposed tissue, and the decreased insulin secretions from the beta cells may have this Cushing syndrome may be associated with the diabetes mellitus. The third is the glucagonoma. Glucagon is the hormone involved in the maintaining blood glucose level in hunger and after high protein intake. In glucagonoma, glucose intolerance is seen in 100%, and main mechanism is the increased hepatic glycogenolysis and gluconeogenesis, not the insulin resistance. The pheochromocytoma is another endocrine disorder or the tumor of the adrenal glands associated with the constant or intermittent production of the catecholamines and have many may have a metabolic effect like the muscle glycogenolysis, lipolysis in the adipocytes, hepatic glycogenolysis, and gluconeogenesis. All are just antagonistic to the action of the insulin, resulting in the hyperglycemia in about 25 to 75% of the cases of pheochromocytoma may be associated with some form of insulin intolerance. The hyperthyroidism effect of thyroid hormone on glucose homeostasis are increased insulin degradation, enhanced secretions of biologically inactive insulin precursors, and increased intestinal absorption of glucose, increased hepatic glucose output via the increase in the glucose transporter 2 or increased lipolysis, glucogenolysis, and there is an increase in the counter-regulatory hormones also, that is the GH, glucagon and catecholamines. The third important point in this secondary diabetes is the drug or the chemical induced diabetes. The drug induced diabetes or diabetogenic drugs, many drugs are used for various medical conditions, sometimes cause transient glucose intolerance in individuals without prior diabetes or worsening of the glycemic status in the pre-existing diabetes, and sometimes can precipitate in the new onset diabetes. All individuals will not affected by these diabetogenic drugs, but following groups are the very high risk patient may develop diabetes mellitus or insulin intolerance. That is the first degree relatives of the diabetes. There is a high risk or ethnicity like African, Indian, Asians, and the Pacific Islanders, and those patients having PCOS or the prior gestational diabetes may have the high risk of developing drug-induced diabetes. The hypertension and the dyslipidemia like decreased SDL and the increased TG, the A1C more than 5.7 or the impaired glucose tolerance and impaired farting glucose or the insulin resistance are the patient having the patients may develop secondary diabetes if exposed to the chemical or drug. There are many drugs which are associated with this, but the few very important is the atypical antipsychotic drugs after receptor binding characteristics leading to the increase here, like clonazepine, olanzapine, or quetiapine, or risperidone, that is usually used by the psychiatrist or for the psychiatric patient may have this effect on this drug-induced chemical. Beta blocker, not exactly causing, but may some form of be associated with this diabetes. The second is the corticosteroid. This is very important and used in many of the rheumatic conditions and other conditions may have this glucose intolerance in this particular period. The fluorochlonicons, like the insulin secretion by blocking the ATP syndrome, phenothiazines, thiazides is the diuretics used in the hypertension is also associated with this decreased insulin secretions. And the protease inhibitors, niacin, calcium inhibitors, and the motor inhibitors are few drugs which is associated with this diabetes mellitus or the insulin intolerance. The infection which is may cause the secondary diabetes, the viruses are associated with the beta cell destruction and triggering of the type 1 diabetes mellitus. The diabetes occurs in some people with this congenital rubella, coccic B virus, cytomegalovirus, and adenovirus. Recently the coronavirus are associated with the new onset diabetes mellitus, or the patient having the previous history of the diabetes may aggravated by this coronavirus times. There is maybe uncommon form of immune-mediated diabetes, that is the insulin autoimmune syndrome, that is the autoantibodies against the insulin, the anti-insulin receptor antibodies, and the stiff man syndrome, which was discussed the stiff man syndrome may have the features of diabetes mellitus. The other genetic syndrome associated with diabetes are the many genetics who are associated with the increased diabetes, like the genetic syndrome with early onset obesity are the Prader-Willi syndrome, the Elstrom syndrome, the chromosomal abnormality like Down syndrome, Klinefelter syndrome and Turner syndromes, and the group of other neurological conditions, that is Friedreich ataxia, Huntington chorea, and myotonic dystonia, may have this insulin resistant or diabetes mellitus. So these are the conditions which is associated with secondary form of diabetes. But when you are able to suspect these cases of diabetes mellitus, it must be remembered that the secondary diabetes constitute only the 1, 2, or 3% of the total cases of diabetes. But when hyperglycemia is found in association with some other primary disease, where the feature of primary disease are more evident and the hyperglycemia is found in routine testing, or when blood control is not achieved in spite of the intensive reason, then there is a cause to suspect the secondary form of diabetes. So hyperglycemia in cases of exocrine pancreatitis, certain endocrinopathy, and when the patient is receiving diabetogenic medications are most important candidate whom should be evaluated first. And the successful treatment of primary disease can result in the reversal of diabetes mellitus in many of the cases. So it is important to suspect the cases of secondary diabetes, and if you diagnose or able to diagnose the secondary form of diabetes, you can reverse the diabetes if the primary treatment is given. So the approach of the patient is that the proper history is very important and itself will point toward the possible cause of secondary diabetes. Acute onset of severe can suggest a recently acquired causes. The recurrent abdominal pain, steroidea, and history of abdominal trauma or pancreatic surgery, all these points toward the pancreatic origin of the pathogenic mechanism. So you can suspect that the pancreatitis and the pancreatic disorder can have secondary diabetes. Some specific feature like headache, oily skin, asthenia, and increase in the ring size or shoe size will suggest the diagnosis of the acromegaly or increased GH production. And other endocrinopathy like Cushing syndrome, the weight gain, hyperpigmentation of the skin, proximal weakness, and the presence of stria may point towards the Cushing syndrome. The pheochromocytoma, that is the bouts of headache, palpitation, flushing, and resistant and episodic hypertension may point toward the pheochromocytoma, and this type of patient may misdiagnosed and as panic disorder and may be treated in by the psychiatrist. The hyperthyroidism, the tremor, exophthalmos, enlarged thyroid, warm moist skin, weight loss with increased appetite, these all point towards hyperthyroidism. Glucagonoma, there is a necrotic migratory arrhythmia, diarrhea, and weight loss. And the most important to ask about the history, which is responsible for transient and sometimes diabetic diabetes mellitus. So coming to the management part, the treatment of secondary diabetes vary depending upon the cause of the patient. The main treatment is the primary cause which is responsible for the secondary diabetes, but management of hyperglycemia due to secondary diabetes is same as the primary diabetes. So insulin, if your insulin resistance is present, then lifestyle factor like the dietary and the exercises and other form of lifestyle modification is necessary. If the patient is obese, the obesity management is required, or if the patient is having insulin resistant, then menopause and other oral medicine may be there. So the hormonal antagonism, if the glucagonoma or if the loss of pancreatic tissue or type 3 diabetes, the metformin insulin replacement is daily, but the primary is the management of pancreatic exocrine insufficiency also. So if you are suspecting the pancreatic diabetes, then the pancreatic exocrine insufficiency should be corrected also with the diabetes management. If they are diabetic, there is any drug, the monitoring is required in the change of medications. So to conclude this secondary diabetes, the first important point is thinking beyond the conventional type of diabetes is very important, and definitely that improve our skill to manage the secondary diagnosis if you are able to diagnose this secondary form of diabetes. Treatment is of primary condition may sometimes reverse diabetes if your primary condition when controlled. The selection of medication other than anti-diabetic in a diabetic patient is very, very, very important. And the good and frequent monitoring is important when the patient is receiving diabetogenic drug. So this all about the secondary diabetes. You need a very high index of suspicion to diagnose or to suspect the cases of secondary diabetes. And if you are able to diagnose the primary treatment, primary cause of this diabetes mellitus can reverse the diabetes mellitus. That is the most important point. Thank you very much for your patient hearing.
Thank you, sir. That was an excellent talk. So now we can take one or two questions. To start with, sir, last 2 to 3 years, because of COVID, there is an increased incidence of secondary diabetes. So like because of the steroid use and all those things. Do you, in your clinical practice, have you noticed this change, or whether they have become permanent or they were only transient?
No, in my clinical practice, I have seen that many of the diabetic patients who are new onset diabetes mellitus after COVID, they are usually permanent. They are usually permanent and they require the medications I see in my clinical practice. But you may got this transient phenomena also, or if in acute infective condition, the transient rise of hypoglycemia may be there. Or if the patient is already having diabetes, may develop thus the increased level of, or there is maybe uncontrolled diabetes during this infection procedures.
One thing, sir, as you rightly pointed out, the most of the patient, whenever they come with uncontrolled diabetes, you will always think what is happening. They say most of the time, doctor, I am doing whatever you are saying. I am doing diet, I am exercise, and I am taking the medications also properly. So why is my sugar is not under control? But once you take that history, most of the time, as you showed in your presentation, they'll be on other medications, like especially the psychiatric medication. Some psychiatric issues is there, they'll be on olanzapine, clonazepam and all. So that will be causing the rise in blood sugar. So as you rightly pointed out, this is one of the common issue which will tend to neglect.
Actually, Dr. Arvind, one is the important point is that many of the diabetic patients are suffering from depression also. And they usually take antidepressant drug because of the many factor. Depression is a different issue, or it is very much common and associated with diabetes also. So if you can take history properly, then you can find that many of the patients may not have able to say that I am taking this anti-depressant drug because of some social problems. So if you can carefully take a history, then you will able to get that the patient is having some drug which is causing this diabetic, uncontrolled diabetes in that particular group of patient.
Any questions from the audience, please? One question is there, sir.
Okay.
Thank you, Dr. B.K. Singh, for your brilliant presentation. As the doctor asked the question, I also found that many of the patients after COVID develops permanent diabetes. And when I asked the history, family history and other supportive evidence, it was clear that those were the patients who are susceptible to be diabetes, maybe 1 year or 2 years or 3 years later, but due to steroid or stress of the disease itself has precipitated it earlier, and most of them become permanent.
Sir, one thing why I want to express this is that there are many, in this AIMS data, probably from Patna, they before treating this corona patient with this corticosteroid, many of the patients develop diabetes. That is immunological reason for this diabetes mellitus is also there. Yesterday it was being dealt by some other person. So that is maybe the take home.
Thank you, sir. Thank you for a wonderful presentation.
Thank you. Thank you very much, sir. Thank you.
Thank you, Dr. B.K. Singh. It was a very brilliant presentation. Our next speaker is a very eminent speaker, Dr. Mrityunjay Kumar Singh from Gaya. He will be talking about risk factor evaluation for CKD. This is one of the very neglected part of the treatment, oftenly missed in the earlier stage, where it can be prevented and thereby preventing future complications. And Dr. Mrityunjay Kumar Singh is the Secretary API Bihar Chapter, Chairman API Magad Division, Secretary CC DSI, Organizing Secretary of Annual CC Japicon 2017-18 and 2022, and Faculty Japicon 2017, 19, 20, 21, 22. Over to you, sir.
Respected Chairperson, sir, at the outset, I would like to thank the organizers of Japicon 2023, especially Dr. Birmani, sir, for calling me here. My topic is risk factor evaluation for CKD. So, okay. So, what is chronic kidney disease? Abnormalities of the kidney function or structure present for more than 3 months with implication for health. And precisely, if you will tell that the markers of kidney damage and those with a glomerular filtration rate of less than 60 on at least 2 occasions separated by a period of at least 90 days with or without markers of kidney damage. So this is all about chronic kidney disease. So why we are focusing on chronic kidney disease? Why this topic has been given? Because the recent trend has shown that the prevalence, incidence, and mortality due to chronic kidney disease has increased manifold. If you compare the data from 1990 to 2016, you will find that it has increased almost 90%. And above that, these diseases in the earliest form are underdiagnosed, go unnoticed, many a time go unnoticed. And the disease is associated with cardiovascular risk. And most of the CKD stage 3 or 5 patients die due to this cardiovascular disease rather than this chronic kidney disease. And it also increases hospitalization and medical expenditure, and it has impact on the life. So that's why this is very important to discuss this issue. And I have already told you that the incidence, prevalence, and death due to CKD has increased manifold, and the global toll of CKD is significant, rising and unevenly distributed, and it has been shown that in the lower income group societies, it is increasing more. It is a silent disease and go unnoticed in the earliest phase, and the main culprits are we the doctors or the these healthcare workers, because we don't know how to screen the CKD patient, who are the patient who are at the risk. So we will discuss how we will screen this CKD patient. So if we say the CKD बीमारी ठीक नहीं होती है, so treatment का जरूरी है क्या? Yes, there is need to treatment because it prevent or delay progression to dialysis and transplant, prevent progression of other complication of diabetes, prevent cardiovascular events, improve quality of life, and reduces cost of care of ESRD. If you will see this slide, you can see that small changes make a big difference. Say a patient of 25 years of age had CKD, and his eGFR is decreasing every year by 3 ml, then he will land into end-stage renal disease and he will require dialysis at the age of 55. But somehow, if we can decrease the eGFR reduction per year by 2 ml, then he can have 20 years of life without dialysis. So it is the beauty of this retardation of CKD. So let us take a case, a 68-year-old male with type 2 diabetes for 10 years, weight 135 kilogram, BMI 31.8, early diabetic retinopathy, BP was 155 by 95. He was on these drugs, HbA1c 7.5. So this patient require evaluation for CKD or not. So we will know who are the patient who should be tested for CKD. Of course, diabetes patient, hypertension patient, cardiac patient, a structural renal tract disease or recurrent renal calculi, multi-system disease like SLE patient, family history of end-stage renal disease, or hereditary kidney disease like autosomal polycystic kidney disease, or incidental detection of hematuria and proteinuria. These are the patients who should be tested for CKD. Another set of patients, in adult gout, they should be tested for CKD, and children and young people should also be tested for CKD if they have premature birth and low birth weight. Another set of patients who should be tested for CKD are who are on calcineurin inhibitors for long, lithium, or non-steroidal anti-inflammatory drug for long. Again, the patient who have any episode of AKI in his lifetime, although his eGFR has returned to normal, should be tested for CKD, and the follow-up should continue for at least 3 years. And person who has solitary functioning kidney should also be tested for CKD, but this solitary functioning kidney should not be due to kidney donation. Now, who should not be tested for CKD? We should not test patient on the basis of age, gender, ethnicity, or obesity in the absence of metabolic syndrome like diabetes or hypertension. Now, what are the kidney health checkup? We have eGFR, we have albumin creatinine ratio, and blood pressure. This is the complete test for CKD. So, how we will estimate the kidney function? We have various calculator for eGFR, and CKD EPI is the most important, and most of the guidelines recommend this. So, how will you interpret eGFR? So, let us say if first test find that eGFR is less than 60. So, what you will do? You will perform second test within 7 days and see whether eGFR is declining more or eGFR is stable in the range of 20%. If eGFR is declining more, then it is AKI. But if it is in the range of 20%, then it is stable, and then you have to do a next eGFR within 3 months, and if it is also in the same range, then CKD is confirmed. Again, we have to keep in mind that eGFR creatinine based is less reliable in certain conditions like acute kidney injury. You cannot do eGFR creatinine based this estimation. Pregnancy, edematous state, muscle wasting disorders, and patients who are malnourished or who have higher muscle mass or use protein supplements. So, in nutshell, reduced muscle mass will lead to overestimation of eGFR, and increased muscle mass will lead to underestimation of eGFR. And in this case, serum cystatin C has the role. Now, coming to the cautions. Advise your patient not to eat any meat in the 12 hours before having a blood test for eGFR creatinine. Avoid delaying or the dispatch of blood samples to ensure that they are received and processed by the laboratory within 12 hours of any puncture. And when highly accurate measure of GFR needed, then real GFR should be done, and it should be done by inulin clearance or this 51 chromium EDTA, and this is required only when there is drug monitoring for chemotherapy, or if patient had been evaluated for kidney donation. Now coming to the proteinuria. So for proteinuria, do not use reagent strip to identify proteinuria. Always use urine albumin creatinine ratio. And how will you interpret this? So first thing is that first morning wide and midstream samples should be preferable. If first test results showed elevated ACR, male more than 2.5 and female more than 3.5, then perform second test at least 3 months later. And if ACR is still elevated, CKD is confirmed. If ACR is not elevated after second test, perform third test as soon as clinically appropriate. If at least 2 out of 3 ACR tests over the last 3 months shows elevated ACR, CKD is confirmed. Incidental finding of proteinuria, what we will do with reagent strip? If unexplained proteinuria is an incidental finding on a reagent strip, offer testing for CKD using eGFR creatinine and albumin creatinine ratio. So, on the basis of eGFR, urine albumin creatinine ratio, underlying pathology, your CKD diagnosis is complete. In my case, serum creatinine is this, and the eGFR is 66, UACR is 76. So, I will fit this into the KDIGO traffic light guideline, where on the x-axis there is GFR, and y-axis there is albuminuria, A1, A2, and A3, and my patient fit into this G2, A3 group. So, we will see how if you will see this slide, there are green light. Green light means there is low risk or no risk. Yellow light means there is a moderately increased risk. This orange light, this high risk. This red light, highest risk. So we have to accordingly stratify our patient and do accordingly. So let us take a case of 44-year-old male with autosomal dominant polycystic kidney disease. BP is absolutely normal. ACR shows 20, his EGFR is 110 and ACR shows 20 mg per gram of albuminuria. So if we will see this CKD risk map, his CKD can be classified as A1G1 and her risk of progression is low. So we can say our patient that his risk of progression is low and she should be monitored at least once in a year. Again, a patient of history of hypertension and hospitalized for acute kidney injury, his EGFR, initial EGFR is 90, but now after AKI, his EGFR has stabilized to 65 and he has had persistent albuminuria. So based on this CKD risk map, his CKD can be classified as A2, G2 and his risk of progression is moderate and he should be monitored by you at least once per year. Next case, if long-standing hypertension and EGFR is around 50, albuminuria is 50 mg per gram, so this patient is in A2, G3A and risk of progression is high and it should be monitored twice per year. Next case, EGFR is around 40 and he is diabetes and hypertensive and his ACR test shows 380 mg per gram of albuminuria. So his risk is quite high and he should be monitored thrice in a year. So after we have established a case, how we will say that this patient will land into the ESRD or will require dialysis. So for this, we have a equation, Tangri kidney risk failure equation, which has 4 variables, age, sex, estimated glomerular filtration rate, and urine albumin creatinine ratio, by which we can say that this patient will land into this end-stage renal disease in what is the percentage of landing this patient into the end-stage renal disease. So say this is the risk calculator of this Tangri, this kidney failure risk equation, and I have put this value for urine albumin 2, sex male, age 50, and EGFR 56. So this is in stage 3, and he's going into the end-stage renal disease at 2 years is 0.11%, and at 5 years is 0.44%. So we can do this in our patient also. And this risk equation, what is the value of this equation? We can improve our CKD care metrics by using ACE inhibitor ARB, by reducing BP, by using HBV immunity, pneumonia vaccination, and transplant referral if there is a high risk. If patient is high risk, if there is more than 40% risk, then we can send patient for transplant. So how will you reduce this risk factors? So consider RAS inhibitor if urinary albumin creatinine ratio is more than 3 regardless of blood pressure. This is the new guideline. Consider RAS inhibitor if urinary albumin creatinine ratio is more than 3 regardless of blood pressure if patient is diabetic. Second, consider RAS inhibitor in patient where urinary albumin creatinine ratio is more than 30 and hypertension, and RAS inhibitor if USAR is more than 70 regardless of blood pressure if patient is without diabetes. So with diabetes, more than 3 you should start. With diabetes, if hypertension is there, without diabetes, hypertension is there, then more than 30, and without hypertension, if USR is more than 70. Now for SGLT2 inhibitor, if EGFR is less than 60 or urinary albumin creatinine ratio is more than 3, you should give this patient SGLT2 inhibitors. Again, consider SGLT2 inhibitor if UACR is more than 25 in patient who are already established on maximum dose of RAS inhibitor or RAS inhibitor is contraindicated. So these are the 2 molecules very important to retard the progression of CKD. This is the guideline. I have already discussed this. This is about RAS inhibitor and SGLT2 inhibitor. About the statins, you should give statins to your patient if 10-year risk is more than 10% or if GFR is less than 60 and age is more than 40. If GFR is less than 60 and age more than 18 with diabetes or CKD stage 1 and 2 with albuminuria. So these are the patients which we should provide atorvastatin, and the target is that you should reduce non-SGL by 40%. So what are the patients which require renal ultrasound, where have accelerated progression to CKD, have visible or persistent invisible hematuria, have symptoms of urinary tract obstruction, have a family history of polycystic kidney disease and are of older than 20 years, have a EGFR of less than 30 ml, and are considered by nephrologist for a renal biopsy. So how we will define the decline in accelerated progression of CKD? For accelerated progression of CKD, to say a sustained decrease in GFR of 25% or more and a change in GFR category within 12 months. Say a patient is in stage 3 and in 1 year he goes into stage 4, then there is a rapid, we can say that it is accelerated progression of CKD. Or a sustained decrease in GFR of 15 per year. So what are the risk factors associated with CKD progression in adults? Cardiovascular disease, proteinuria, previous episode of AKI, hypertension, diabetes, smoking. These are the ethnic stage, chronic use of NSAID, untreated urinary tract obstruction. And one more important thing is this regional chronic disease among agriculture workers, which is also known as CKD of unknown origin, and which has been shown in many places worldwide. In America, it is Mesoamerican nephropathy. In Sri Lanka, it is Sri Lankan nephropathy. And in India, in certain places, it is known as Uddanam nephropathy, which occurs in central Indian states of Andhra Pradesh, Odisha, Chhattisgarh, and Maharashtra. And the patients are mostly agriculture worker. And the hypothesized causes are increased heat exposure, and there are certain heavy metals which they consume regularly, and less water intake can cause this CKD of unknown origin. So we should also take care of this while we are seeing the patient of CKD, and they are insidious in origin. And once you do the ultrasound, you will find that both the kidney has reduced in size. So this is very important to consider. Another is artificial intelligence and machine learning in CKD. There are several papers over this over the last 2 or 3 years. And what is artificial intelligence? Any technique which enables computers to mimic human behaviors. And there are certain subsets of artificial intelligence, machine learning, deep learning, which can improve the diagnosis of CKD, which can improve the precise treatment to the patient. And one of the studies which have shown that in immunoglobulin A nephropathy, how this patient will land into interstitial renal disease. And this patient has shown that this ANN tool containing risk factor was developed of predicting ESRD in immunoglobulin A nephropathy. But still, this is in the infancy stage. We may get this in the later years. So this is the stages in progression of chronic kidney disease and therapeutic stages. So first, if patient is normal, C for risk factor. Second, if patient is at increased risk, screen for CKD. Third, if diagnosis and if there is damage, then treat the comorbid condition and try to slow the progression. If there is low GFR, estimate progression. See the patient will not rapidly go into the interstitial renal disease. Treat complication, prepare for renal replacement therapy. If there is kidney failure, replacement by dialysis and transplant. This is in the nutshell, and the key points are target screening of people at risk of developing CKD is critical for early detection and timely management of the silent disease. Screening includes a blood test for serum creatinine to calculate estimated GFR, urine albumin creatinine ratio test, and blood pressure check. These 3 components complete a kidney health checkup. A diagnosis of CKD is confirmed if there is a reduction in eGFR less than 60 for more than 3 months or elevated ASER for more than 3 months. After confirming a diagnosis of CKD, further investigation may help to determine the underlying pathology. Complete documentation of a CKD diagnosis require recording of the stages, level of albuminuria, and underlying cause. Timely management reduces both the burden of kidney failure and the associated cardiovascular morbidity and mortality. Thank you very much.
Thank you, sir, for this brilliant presentation. You almost covered all. I have got 1 or 2 questions. In a case established kidney disease, early stages, how often the evaluation to be done in a OPD setup?
So you have to stratify the risk. Stratify the risk according to, you have to stratify the risk according to that KDIGO traffic signal which I have shown you. And if it lands into the green, then you have to once a year, you have to do once a year. If it lands into this yellow range, then you have to twice in a year. If red, then more than 4 in a year.
Sir, another question, the role of diet in a diet. in prevention of CKD.
Okay. So, low protein diet is advised, low salt diet is advised, and but low protein diet, most of the Indian patients are already on low protein diet. So don't advise strict protein restriction. We have to give them protein, 60 mg if 1 mg per kilogram body weight, and most of the diet which are protein, which are plant-based are good. Animal-based proteins are avoided or should be taken in less amount.
And sir, regarding the water intake,
Water intake depending on the status of the body status of the fluid. If patient is in fluid overload, or then you have to restrict water. Otherwise, you can take water.
thank you, sir. Any other questions?
What is your take on role of Finerenone in prevention of...
Finerenone. In diabetic kidney disease, if patient is on the maximum dose of RAS inhibitor or RAS inhibitor, then we can give this Finerenone, and it is doing good. I have seen in 3 or 4 patients in last 4 or 5 months I am using this and getting good results. Thing is that this is very costlier drug. Around 20 mg Finerenone cost around 70 rupees. But you can half it. Like that drug we are doing in SGLT2 inhibitor. We can do it, give it in a half dose, and it is giving good result. But first you have to maximize the dose of RAS inhibitor before starting this Finerenone.
Only the potassium thing has to be monitored.
Yes, of course.
And the recent one more study is coming up, the role of Finerenone in non-diabetic kidney disease.
Okay, so
probably next year or so it is going to come.
though I have not come through that.
Any other questions from the audience? Yeah.
Sir,
Dr.
very good
Mrityunjay,
presentation. I'm Dr. Deepak. I'm nephrologist. Regarding the use of RAS blockade in patients who are not hypertensive but have a moderately increased or severely increased albuminuria, the evidence is not enough to strongly recommend this. It comes from innovation trial in which more than 30% patients were normotensive, and from renal trial where hardly 4% patients were normotensive. So it's an expert opinion to utilize it, but still we don't have evidence. So we have to be careful regarding...
That's why it has written and consider using.
Yes.
Not recommended.
Yes.
Consider.
Yes. It's just an expert opinion. Thank you.
Dr. Mrityunjay, in your experience, what are the incidents of CKD in children?
DKD? CKD?
In children.
Okay.
Because these days all diet and all, misuse of diets.
Actually, sir, there are lacking of data from Indian population on the pediatric CKD.
Okay.
But I have seen recently 2 patients. One is came to me that his serum creatinine is 1.2. His serum creatinine, but you can overlook this. A 4-year boy came to you, serum creatinine of 1.2, and persistently serum creatinine is 1.2. If you will do the EGFR, it will come in the range of somehow 45, 46. So you have to work up. And then when I have done ABG, he is acidotic also. And so these are the patients which we overlook. And when I have taken the history, the patient is prematurely birth, history of premature birth. That's why the patient, young patient, you have to do CKD screening if he has prematurely birth, if there is history of premature birth, or there is a weight less than 2500.
In your case, this child, 4 years, you did serum creatinine, it was 1.2. What was the indication to do serum creatinine in this patient?
No, patient is anemic.
Because we routinely don't do.
Anemic. Patient is anemic. So the routine checkup, in anemia for routine checkup, we have done, not I have done, that has been done outside, and patient has been sent to me. कि serum creatinine persistently high रह रहा है. The EGFR actually आप देखें नहीं. EGFR you will see it is around 40-45.
Dr. Mrityunjay, you have done excellent presentation, so I have no questions to ask to you. Just one observation. I, along with Dr. Wahid Khan and Dr. Jagannath Hemram, we are undergoing a study in rural Jharkhand, particularly in Santhal tribe, and we have come across a lot of CKD cases. In fact, in one village, we did only routine urine, simple dipstick urine, and almost 90% had proteinuria. So we are undergoing this study, and so far the results which are coming, they are showing genetic predilection. Initially we thought that it must be some heavy metal, but it didn't turn out to be heavy metal. So hopefully soon we will complete
These
this.
patients will firstly present with proteinuria only.
And most of these cases are chronic interstitial nephritis.
Yes.
The presentation is totally different.
Yes.
Thin built, no
So
hypertension.
you are doing renal biopsy in those patients.
No, we have, in fact, we are still doing, not completed the study. We are undergoing this. Thank you.
Thank you, sir.
Thank you, sir. And loud round of applause. First session we have completed and an excellent talk by both the speakers. Well done. Now may I request our chairpersons to please hand over memento to our speaker. Can I request Dr. B.K. Singh sir to please come on the dais? क्या हम गर्म जोशी से तालियां बजा सकते हैं सुबह सुबह? Good, very good. So, memento for Dr. B.K. Singh. Memento for Dr. Mrityunjay Singh. Now I request the speakers to please hand over the memento to our chairpersons, Dr. B.K. Singh to present to Dr. Aravinda. And Dr. Mrityunjay to present to Dr. Somya. And a big thank you to all of you.
मैं सबसे पहले एक बीरमानी जी के एक शेर सुनाना चाहता हूँ. That is a wonderful conference he has organized in this जमशेदपुर. हर चुनौती का सामना आपने है किया, हर चुनौती का सामना आपने है किए, आंधियों में भी जलाए हैं बुझते हुए दिए. हर चुनौती का सामना आपने है किए, आंधियों में भी हैं जलाए बुझते हुए दिए. ऐ खालिके हुनर इन्हें इतनी कमाल दे, दुनिया अगर मिसाल दे तो सिर्फ तेरी मिसाल दे. तो थैंक यू वेरी मच. और मैं चाहता हूं कि और जोरदार तालियां बनाई पूरे ऑर्गेनाइजिंग टीम के लिए, और डॉक्टर A.K. आर्या, डॉक्टर D.K. सिंह, डॉक्टर बिरमानी, डॉक्टर उमेश खान एंड ऑल. थैंक यू वेरी मच.
Thank you, Dr. B.K. Singh sir. We would love to listen more from you or Shairi at the end of the conference. Thank you. Okay, friends, now moving to the next session. Actually, the next session was supposed to be held yesterday, but due to some unavoidable circumstances, we could not do it. So we are going to have debate 4, and this session it would be chaired by none other than Dr. A.K. Virmani. There are two speakers, Dr. Purvi Chawla from Mumbai and Dr. Kunal from Jamshedpur. May I request both the speakers to please come on the dais. The topic is technology in medicine. Are we going overboard? Dr. Purvi madam would speak in favor and
Good morning.
Kunal against.
Can I have both the speakers on the dais, please? Yeah. Purvi, Dr. Purvi, and Dr. Kunal. Yeah, please. Good morning to all of you. This is a wonderful debate between two eminent speakers. We all know that technology in medicine is not coming, it is already there. We have been using it for the last few years, unknowingly, but now it is being highlighted so much that everybody is thinking that maybe tomorrow it will be only technology and not doctors. So the topic I had kept was technology and medicine, are we really going overboard? And to speak for the favor is Dr. Puri Chawla from Mumbai. She is going to say, yes, we are losing the human touch. Over to you, please.
Good morning, everyone. It's a great, great honor that Dr. Virmani sir is even chairing this session. And I'm so glad that he has picked this really heart-touching topic. I'm going to try and treat it with the brain so that, you know, at the end of the day, we are all doctors and we listen to scientific evidence and besides everything else. So let's get ahead with it. Yes, indeed, we are losing the human touch and we are going overboard with technology. So where are we currently with technology? In the process of continuous development and evolution with the latest technology, and some of the latest developments are such that they are changing the practice of medicine today and also in the future, essentially allowing it from anywhere, anytime, and from any device. But ideally, technology should only supplement or support human interactions rather than replace them. When they are deployed well, yes, it can alleviate pressure from the system. It can reduce the burden of administrative tasks that we all have to go through. It can allow our skills and resources to be directed more towards places where they will be valued and overall improve the quality of care and offer such benefits not only at the individual patient level, also at the healthcare provider level and the system itself. So it allows us to take better decisions and improved learning through data capture and artificial intelligence applications, also greater efficiencies through streamlining of processes, especially in triage, etc., at least abroad. Better quality of care for patients through flexible and convenient access and tools for self-management, of course, offsets the burden that we all have faced with the COVID pandemic and helps provider care and companionship to the elderly and also helps connecting communities. And look at the whole myriad of technologies available today to just help us do all these things. So we are expected to maintain this balance between the technological advancements and of course the caring human touch. But are we really able to do that? Instead of that, look at this. I don't even need to explain this picture. It is self-explanatory. Look at where we are today. Even dinner conversations are replaced with WhatsApp and the phone and the screen time. It has completely infiltrated our lives, pervaded our lives completely. Leave alone the sacrosanct doctor-patient relationship. So the importance of medical touch, where it can show gentleness and compassion, it can also be carelessness and incompetence, and it's totally lost today. Are we really losing it? This is the biggest taboo of our modern day healthcare, and the laying on of hands, which signifies not only the doctor's identity as a healer, but also a sense of authority and power. And there seemed to be hardened indifference running through all the levels of healthcare, leadership as well as the frontline workers, which is our nursing staff included. So this perceived loss of human touch signifies for many doctors the dehumanization of modern healthcare and the loss of clinical skills and discernment accompanying the emergence of a more industrial, bureaucratic medicine, which we never trained to be. So it's attributed to the spread of medical technology, where speed of diagnosis and precision are the only essentials. But this absence of human touch is felt by everyone, but no one dares to talk about it. And ironically, this is also associated with contagion, intrusion, and violation, but at the same time, we know how to combat that. So we are here where we want to robotize everything. Again, the telehealth and telemedicine have taken center stage since at least the pandemic, and something that we were engaging, only just 1% of us had reached 90 to 95% of us. And this has decreased the need for physicians to engage in physical exams, especially at the primary care level, which can be very, very dangerous. While investigations have replaced traditional exams and have become the primary diagnostic tools for patients. So loss of human relationships and increase in insecurity and apathy with both patients as well as doctors. But you won't believe me. So I have a scientific study here. This was called the iPhone effect, published in 2004 in Environment and Behavior. And they did an experiment with 100-odd couples to see what was the interaction when they were given a meaningful topic to talk about for 10 minutes. In the absence of mobile phones in the hand, those couples engaged in a much more superior conversation than those with the phone in hand, and irrespective of the age, gender, ethnicity, and mood. And there was a more empathetic connection between them. In fact, even those couples that did not know each other were more empathetic when they did not have the device in hand. There's also evidence to say that this internet addictive behavior or the increased screen time is associated with abnormal white brain connections, and also such matter is linked to behavioral abnormalities as well. But again, to substantiate my point, I have two really focused cases from my own practice. This was a case that we published in the RSSDI annual casebook in 2020. And here I just want to talk about this 23-year-old woman who was a type 1 patient, and in the previous 3 years had switched from the MDI or the multiple daily injections to continuous subcutaneous insulin infusion or insulin pump, and kept in touch with us sporadically using teleconsults, no video consults, did not even talk to us about what was happening at the insulin site, at the cannula site. And look at what happened. One day we got a panicked call stating that I have pus oozing out from there, and that's where we rushed her, we asked her to rush to the emergency department of the hospital, and they were found an ulceration which the patient had completely missed. Had the patient come to see us in person, this would not have been missed. There's a second case which is quite horrific as well. In 2020 December, there was an in-person visit. 3 months later, there was a lockdown and the patient continued meeting us on teleconsults. And somewhere down the line, she had a fracture. 65-year-old woman, type 2 diabetes, following up regularly at the clinic, had a fracture, was referred to the orthopedic. She got the initial plaster done with the orthopedic consult, but later on did not follow up and kept on calling the doctor on teleconsults, even following up for her sugars regularly, but only on teleconsults. The result was there was Charcot's arthropathy that developed over time, and that was missed in diagnosis because the patient never went for an examination, just kept complaining, I cannot walk. These are pretty serious. And if you see, again, the patient has followed up through the subsequent year only on teleconsults. And I've even made a note that personally patient distressed about the foot, and this was due to Charcot's arthropathy. So these were some gruesome examples. Well, this is not enough. Kaiser Permanente in California, which is a really superior, which is a first-class tertiary care hospital, and that's where they have e-robots or the robotic medicine in place, and they have robots telerounding, and one of the doctors actually came onto the screen of the robot while the patient was admitted there and disclosed the impending death to the patient on telemedicine or telerobot. This was horrific, and not only was the patient shocked, but so was the family, and so was everyone in Northern California. And the hospital authorities had to issue the statement to the family that in every aspect of our care, especially when communicating difficult information, we do so with compassion in a personal manner. Later on, they even confessed that we, like every healthcare provider, we are continuously learning how best to integrate technology into patient interactions, and patients are accustomed to physicians following up by phone. With new technology, we can extend that to offer video consults, but it can never replace the personal interactions between our patients and their care teams. So this is a massive confession by a really huge, sophisticated tertiary care hospital. Diabetes UK, for example, and I'm a diabetologist, so I will give you some examples from our field as well. Well, this is the official patient information site, and you can see there's home, there's guide to diabetes, there's diabetes technology, but there's an important section there, diabetes technology emotions. And they talk about the patient's feelings about diabetes technology. They talk about technology isn't a quick fix for anything. It's not a means of controlling your blood sugar. It can only support you better. There's a lot of data coming up. There's a whole lot of data. Yesterday, Dr. Manoj spoke about CGM. Just imagine the patients who are engaged in continuous glucose monitoring and the amount of data that's generated. How overwhelmed could they feel? And how overwhelmed would the doctors as well would be. There's also a term called technology burnout, where the patient feels that the amount of information they get from technology is making their diabetes even more relentless, and even is almost equated with diabetes burnout or distress, which we all are again familiar with. And technology can feel like a burden. Instead of helping you, it can really overwhelm you, and it can be like it's a companion that you don't always want. So there is something called as feeling ready for tech, and we need to allow our patients that kind of option. What does Richard Houghton, the editor of Lancet, says? Well, he says that we are no longer indulging in physical exams at all. And in his editorial in the Lancet, he even said that medical literature always equated a clinician's practice of clinical art to the sense of touch and the laying of hands as a proxy for social and emotional connect with the patients. If we are going to replace this with telemedicine and mobile applications, where is this touch really even present? So touch builds trust, reassurance, and sense of communion, he says. It's about fostering a social bond of sympathy, compassion, and a tenderness between two patients. So this is important. Again, in India itself, we have artificial intelligence coming in. This is at the Apollo group of hospitals, and this is very recent, as recent as Feb 23. Again, at the 9th edition of the International Patient Safety Conference and the 10th International Conference on Transforming Healthcare with Information Technology, Sangeeta Reddy, the joint MD of the Apollo hospitals, she also remarked that we need support tools to elevate accuracy of diagnosis, doctor productivity, and patient satisfaction, but nothing that can really replace the human touch needed in healthcare. And that is what is happening today. The importance of caring touch for healthcare professionals, even in the ICU, has been seen. And they've said that caring touch through the healthcare professionals can really communicate well, and it can make the patient feel relaxed, calmed, confirmed, and can ease suffering and increase well-being. If we are going to have robots tele-rounding for us, where is that touch? And they say that the experience of caring touch is also dependent on how we do it, and it should not be negative in any manner. So even in the ICU patients, the importance is well emphasized. Again, this particular study also showed that there are calming effects of touch, and they said that not only it improves parent-child communication as far as health is concerned, but it improves the psychobiological stress levels. Even the biomarkers have been studied with touch, and that also improves with light moving touch. Well, we also have a meta-analysis that reported if modern technology is decreasing the value of humanity in patient care. And the answer was yes. Technology is very useful for aspects like barcoding of medications, reviewing lab results, and allowing the healthcare professional to spend more time with the patients. But instead, it was found that patients had that inappropriate use of technology, in fact, was associated with more patient-related errors in entering the data in the systems, and it was associated with increased noise levels and associated with increased fear and anxiety in our patients. And also this over-reliance on equipment, on electronic equipment, decrease the touching, listening, visualizing the patients for both nurses as well as the physicians. Cyber security risk, and I don't need to elaborate on that because you all are aware how dangerous this can be. And today our data is all out there, even with cloud computing and EMR systems. Nothing is secure as we might want it to be secure. So there are very, very important articles coming up in all kinds of journals and with all kinds of associations. This is an example with CMAJ, which is a Canadian Medical Association journal. Again, they are questioning if the patient-physician discussions, disclosure of a terminal diagnosis should ever occur virtually. So at the doctor level, yes, we are never really taught communication skills. Even our young doctors don't know how to exactly engage in consultations with patients and how to handle dialogue even when it breaks down or it becomes difficult. All our hospitals are not marked on how empathetic they are. Instead, they are marked on the basis of medical excellence, research, and scientific breakthroughs. And soft skills like empathy, openness, identification with patients, compassion are all completely missing. As far as patients are concerned, they are confident that they will be treated with compassion when they are ill, and frequently shocked that there is a complete absence of human touch. In fact, they feel let down by the healthcare system at times. They need to openly talk about it, openly challenge it, and demand that the patients are seen by the doctors themselves and there is the touch which they require at the right time or the vulnerable time in their lives. At the hospital level, we need to set up teams that are more trained for this, who are trained to provide this practical, emotional, psychological, and other guidance to our patients in such situations. And we need to develop these teams, especially with patients who are traumatized at this overuse of technology. We can even draw a parallel from the hospital industry. This may not be a great parallel, but something to learn from, or something to imbibe from this particular industry, because they know really well that human touch is part of friendliness, warmth, and consideration that guests expect to find. And if they don't provide it, they will definitely go to another provider. So they actively recruit staff who are particularly good at people skills or communications, or they like their fellow people, or they even like to help. But the healthcare industry has no such mandate or no such requirement. Patients come in, it's all taken for granted, but we need to actively seek out staff who are good at communicating or test candidates for empathy, which is so readily missing with the use of technology. So, we are in a current technology tsunami, as you can experience it. Whether you love it or hate it, ultimately we all have to figure out how to survive it and how to make it work for us. And that is by maintaining the balance that I was talking about right on my second slide. What we saw today, all the evidence I showed you, is only a tip of the iceberg. And where the loss of human touch and the loss of the human heart is all embedded, it's drowning in the sea of technology. So yes, technological advancements replace or reduce human interaction and come at a price of patient experience. Care implies all aspects of human needs, including compassion, empathy, and the reassuring touch of another human being. It's based on trust and feelings rather than just an anonymous number in the queue. And at times of stress, pain, and anxiety, all humans need warmth and reassurance, which is difficult to access through apps, bots, or a video call. Ethical questions do arise when we want to use technology for our elderly, if we are going to have robots touching them and making them feel warm. And there are concerns if we are dehumanizing care by introducing so much more technology. And a distinct problem is of digital exclusion, where our elderly and unaffording are left out of technological advancements. So in conclusion, would you have liked this, the Zoom screen that we all suffered for 2.5 years, or would you prefer this? This is a picture of this very hall yesterday, completely full and alive with questions, and each of you interacting in person and not through communications. So once again, I appeal that let's not lose the human touch, and thank you very much for that patient hearing.
Thank you, Purvi, for a wonderful talk. You have really emphasized the importance of human touch in clinical medicine. Now let's see how Dr. Kunal defends this. He says, no, forget it. Technology is the need of the hour. Dr. Kunal is from Tata Main Hospital.
Good morning, Chairperson, sir, respected faculties and delegates. My slides are not that much attractive like ma'am, but I will like to emphasize the need of technology, the need of our. Basically, I wanted to be a more interactive session with the audience in this need of technology. So, the need of technology. The big question is whether we are losing the human touch or the technology is needed. The basic thing about this is, should we draw a red line over the technology, or we are going overboard like things? So the beauty of technology lies basically in its ability for innovation and optimization with constant feedback. We can get the technology according to the need, what the person needs, what the doctors need, what the patient needs. We can adapt, and technology can easily adapt to those things. So we can't draw a red line, because if we draw a red line, the innovation stops at that time. I've been giving you an example. When in the back in days in 1990s, when the personal computers came in the use, there was much hue and cry all over the world that people will lose their job, humanity will be diminished, and no one will be getting the jobs, and so and much for the technology things. But look where we stand today. Now, the tech and companies and technology is one of the most biggest employer for the people. And the PCs have developed into the tablets and the mobile phones everyone in the audience are using. So that is the beauty of technology. It has the power of innovation. It has the power of adaptation that will adapt to the needs. So, giving an analogy of the medical field comes to the medicine, I would like to give an analogy for our the humble stethoscope, the biggest companion of the physicians. In the residency years, we used to use the stethoscope and give so much time to diagnose and see with examination the murmurs. Then comes the technology here. The technology is the echocardiography machine. It helps a lot. It gives a diagnosis. Yesterday, I was with one of my seniors in the lunch hour. We were discussing this analogy. the boss told me 90% of times we make a perfect diagnosis with the stethoscope. But what with the echo? We make a diagnosis 100% of times, the accurate diagnosis. Then why settle for the 90 when we get the 100? So use the technology. Has the echo machine replaced the stethoscope? No. Stetho is there. Stetho is the epitome of the human touch. It is there. But why to shun the technology thing? We can't discard the echo machine for the stethoscope. So we can't have the thing. So we have to use that technology to make that thing. So why the tech is needed? We have to very much pragmatic in which country we live. We are living in India with a population of 1.4 billion people scattered across urban and rural centers. The country poses a unique challenge in healthcare. Just last month, we became #1 in this population field in our country. 75% of the healthcare infrastructure and doctors are concentrated in the urban areas, where only 27% of Indian population lives. One of the most pressing challenges for India is to offer world-class healthcare at affordable rates to its citizens. Is the technology the answer? With the country's hospital bed density stood at 0.7 per 1,000, which is significantly lower than WHO guidelines of 3.5 beds per 1,000. Technology is the only tool which has the potential to bridge this gap. If India is to realize its goal of universal health coverage, it is imperative that technology and healthcare talk to each other seamlessly. Technology is all-pervasive and helping to address India's unique challenge in terms of accessibility, affordability, and quality. Technologies in healthcare. Technology will clearly be the backbone of healthcare in industry in upcoming years. The World Health Organization offers some more detailed definition of health technology as the application of organized knowledge and skills in the form of devices, medicines, vaccines, procedures, and systems developed to solve health problems and improve quality of life. Then comes the various technologies. First, the remote monitoring thing. Remote monitoring allows the patient the progress to be monitored at all times without using clunky technology or doctor needing to be present. Not only does this means that doctors and nurses are able to help many patients at time, but patients are able to leave the hospitals earlier and be monitored safely from afar. This creates a more comfortable and cheaper experience for everyone in the world. Then it is the electronic medical records. I used to work previously in all the government setups. First time, it was my experience here in Jamshedpur to work in TMH and get accredited with this electronic medical records. So what is the need of electronic medical records, and the beauty of record is this, that it helps us to stop the error. Many of times when the patient comes to us, the patient doesn't keep the hard copy of the prescriptions. They don't know what drugs are they taking. They don't even know what disease are they suffering from. Patient comes says, "Sir, दवाई खाते हैं क्या? Sir, वो नीली गोटी छोटी वाली." How we know? That comes the technology to help. That with the electronic medical records, we have the soft copy, or we have everything stored if there. We can know what medications they are taking. So if the patient comes with a diabetes and show the reports like that, 400 blood sugar, but we don't know what he's taking. He's taking metformin or sulfonylureas, sitagliptins, anything else, limiters. We don't know. How should we start? Then comes the help of the electronic medical records. We can help. We can know what the patient is taking. Not we. If the records are integrated in the cloud computing, something like that, and when the patient goes and sees, he can help, the doctors can know what the patient was taking, what disease is suffering from, what should we add onto that drugs or no, something like that. So adoption of electronic health records is the key to improve care and reduce error. It brings about cost efficiency by streamlining the clinical care and process to improve outcome. New age cloud-based situation mobile apps, patient interactions will further boost that operations for electronic health records. The data gathered through electronic health records over real time can help in further refine analytic models, improve clinical outcomes. Then comes the talk of the town, the telemedicine thing. I remember when in 2020 I was doing residency, my residency in AIMS. I came to know about the telemedicine. We came to know its importance when the COVID struck in. On the day one, when the COVID was there, the notification of government was there, everything was shut. The OPDs, the elective surgeries, everything was shut. The people was talking about only the COVID, COVID, COVID. Where were the other diseases, whether diabetes, sugar, anything? Everything was went into oblivion. No one was seeing that. Patient doesn't know what to do. They were in the dilemma. Then comes the telemedicine. And I will give you my example how the tech innovates itself and adapts to the better care. On day one of after shutting the physical OPDs and the telemedicine starts, we were given the Nokia 1100 phones for telemedicines. We got to phone, hello sir, patient talk to us, and we say, sir, paracetamol. Sir, kya? Paracetamol. It was a very much problematic thing. Patient doesn't know what was taking, what we're giving. Then the innovation part came into play. In the next week, we got an iPad with WhatsApp, with AIMS app, where we can give e-prescriptions. So we were able to see the patient was able to see us, and we want to assess the patient, we were able to assess the patient, and we gave a soft copy e-prescriptions. That was the innovation. As ma'am mentioned in one of her case reports, that the insulin pump, the ulcer caused it by the insulin pump there, and said that there was no video call over the teleconsult. It was only the phone. If the tech was innovated and we had gone through a video call, this might not happen, and the doctors have seen the scars or the ulcers much before. So that is the telemedicine. Telemedicine consists of remote clinical services where the health providers or doctors communicate virtually with the patients. Example of this includes appointment over video call, therapy over phones, text message that reveals the medical test results. The positive consequences of this are undeniable access to healthcare and being improved for those who are in remote areas or face difficulties attending physical appointments. Then comes the health apps. Most of us are using health apps. I think everyone in this hall must be using that health apps or something. E-health apps refer to the use of technologies to improve healthcare, including health and well-being. Therefore, health apps are mobile applications that tend to target a specific area for healthcare. Since almost everyone has a smartphone these days, e-health apps make looking for your health and well-being feel more accessible and less daunting. Then comes the Internet of Things. The Internet of Things and the future. Expert defines Internet of Things as any set of sensors and actuators embedded in physical objects that are linked through wired or wireless networks. In recent years, there have been plenty of innovations in the health industry that fall under the Internet of Things and that allow patients to take control of their own health. Application of IoT. In healthcare, the Internet of Things is all about unleashing the power of connected devices and sensors that are widely used in this sector. Internet of Things revolution will be a result of replacing disconnected objects with connected ones and making these objects more intelligent and context-aware using sensors. Internet of Things can be used to drive valuable insights from data derived from fetal monitors, electrocardiograms, temperature monitors of blood glucose levels. Smart devices can provide the required health informations remotely and lessen the needs for direct patient interactions. In a world of Internet of Things, different distributed devices will gather, analyze, and communicate real-time medical information to open, private, or hybrid cloud making it possible to collect, store, analyze big data streams in several new forms and activate context-dependent alarms. The personal Internet of Things health-based monitoring device will change the way we track the health of individuals. Technologies like blockchain will soon redefine how we populate and maintain health records and how we link them to other services. Basically, ma'am mentioned the cybersecurity threat for the health records thing. We can say we trust our money with the technology. We are using our money with technology, and we can also trust our health with technology. If we are purchasing the Bitcoins things, they use the very much secure technology of blockchains. We can use that blockchains for the securing the data. And this is chance of cyber theft, but we have to look for that. We can't deny that thing. Then comes the new talk of the town, the artificial intelligence. Artificial intelligence will increase assist physician, healthcare workers, and caregivers in triage, diagnosis, and treatment. Artificial intelligence embedded recommendations engines are helping patients make choices that they never knew they could make. A high degree of personalization and care has been made possible with the use of technology. This is a need of hour since chronic diseases are in rise. As in demand for personalized care depending on the illness and psychological makeup for the patient. Application of AI, the unique power of artificial intelligence is that it not only complements human skills, but significantly expands the scope of human activity. Some of the artificial intelligence related technologies include, among others, natural language processing, intelligent agents, computer visions, machine learning, expert system, chatbots, and recognition. The thing about language processing, I came to know about these things of AI intelligence. India is a diverse country. We have people from all society, all sections, and they speak different languages. As a physician, if we can't understand them, what they're saying, we can't diagnose them. We speak in English here, we speak in Hindi, but when we go to the southern states or eastern states, they speak Bengali, Odia, Telugu, something like that. And from the remote population people, they never speak a single bit of Hindi or English. And we can't understand any single bit of Odia, Hindi, Bengali or Telugu. There comes the use of that artificial intelligence to translate those things. They can help us out to translate, and we can give them prescriptions in their language, and does the counseling in their language. That helps the AI. Data management of health records is one of the most widely used applications of AI in automation. Robots collect, store, reformat, and trace data to provide faster and seamless access to anytime, anywhere. AI is also deployed to perform activities, repetitive tasks like analyzing laboratory tests, X-rays, CT scan, and data entry. AI-based apps can be used to provide medical consultations based on personalized medical history and intelligence gathered through analytics. The process of drug creations can also be supported by AI-powered programs, which can significantly lower the cost of developing the pharmaceuticals through traditional clinical trials. Precision medicines is another application of AI, where AI-powered body scans can spot cancers and vascular diseases early and predict the health issues people might face because of their genetics. Then comes the big question: will artificial intelligence, or you can say the technology, replace the doctors? With technology becoming an integral part of healthcare sectors, the obvious question arises whether machine will eventually take over the doctor's role, and we will lose the human touch in the patient care. One school of thought believes automation could spell the end of doctor-patient relationship in a patient care, while other set argues that fear psychosis is mere hysteria generated due to several misconceptions, largely based on the overestimation of AI's use and abilities. The answer perhaps lies somewhere in between. Machines might never, I say never, replace the doctors entirely, but will surely take over much of his or own work, including some decision-making power. It is never a matter of AI versus doctors. It is always a matter of doctors versus AI plus doctors. So we have to use technology with caution, but you have to use it. The power lies in working in tandem to drive more value. The artificial intelligence, or otherwise known as augmented intelligence, essentially enhance the products and services rather than replace the humans that offer them. In an ideal world, technology or machines and human coexist to create a better and healthy tomorrow. Thank you.
Thank you, Kunal. Dr. Purvi for the rebuttal.
Dr. Kunal, would you rather see a person in, a patient in person or via telemedicine?
Ma'am, I will see in person, but when it's not possible, then we have to use the technology. Because in our country, we can't see every patient. Because in our country, we can't see every patient. We have a, like, I used to work in TMH, we have a slot system. We can see only 60 patients per day because we have to give time. So that comes the technology. If technology helps us out with other things, we can have this.
I'm so glad that Dr. Kunal actually agrees with everything I said, because in theory, in intention, technology may be really good and the intent may be good, but I've shown you live examples of what has gone wrong with the overuse or over-reliance on technology. So I think I rest my case with that, then doesn't need to be said anymore. We are
Any
indeed
rebuttal
losing the
from
touch.
Dr. Kunal?
Ma'am, I can say that isolated incidents can't help the technology, that we can't use the technology. So as earlier said, the technology is always in innovation phase, and it has also the feedback system. So we can use that innovation and feedback to improve the technology. And it's not ever, there's like black and white thing. There's always a gray zone. We have to work in those areas, and we have to make a consensus about these things. Thank you.
Right. I think both the speakers have done a wonderful job, and they almost agreed to this, that technology is really needed, but don't lose the human touch, and use technology as a slave. Don't become slave to technology. How many of you here sitting can live even one day without your smartphone? Hardly anybody, I think. I mean, impossible. Okay. Now, how many of you here have used Chat GPT? I am sure everybody has heard of Chat GPT. Anybody has used Chat GPT? Yes. Manoj, of course, I expected you have used it. Now, I'll give you a very nice this thing. I also use Chat GPT. So, about 3-4 months back, I put in this question to Chat GPT, whether artificial intelligence will replace doctors. And look at the beautiful answer that it has given me. As an AI language model, I cannot predict the future. But it is unlikely that artificial intelligence will completely replace doctors. AI can assist doctors in making diagnosis, providing personalized treatments, but human doctors will still be needed to provide empathy, emotional support, and to make complex decisions based on ethical, cultural, and social factors that are not yet programmable into the AI algorithms. AI cannot replace the human touch and the human ability to think outside the box. What a wonderful answer it has given. And this is what both of them have exactly said. No matter how much science develops, it will be the man behind the science who will be the king. Thank you.
Thank you, sir.
I think
Well, I would now request the chairperson to give mementos to our speakers. First speaker to Madam Purvi. Please come in the center. And next to Dr. Kunal. And now the memento for our chairperson also from the speakers. So thank you so much. Moving ahead with the next session, may I invite Dr. Mundra sir to please come on the dais. I'll join you, okay. So we are moving ahead with the next debate. तो अभी 20 था तो वही रहने दीजिए, काटिएगा मत. तो इसके पहले 20 क्यों दिया? Anyway, you decide. चलो. Okay. So we are moving ahead to the next debate, and that will be moderated by Dr. Mundra sir. There are two speakers. Dr. A.K. Paul sir, please come on the dais. And the another speaker is already on the dais. The topic is, should euthanasia be legalized in India? A social topic. I am speaking for the topic. Dr. Paul is speaking against the topic. Chairperson to please take over.
Hello. I should say good afternoon now. So we are almost coming to the end of Japicon 2023, and this is the last debate, and the topic is, should euthanasia be legalized? It's a burning topic. I'll tell you one thing. In 2018, Supreme Court they gave a verdict in Aruna Schonberg case, and they said that passive euthanasia can be done, and till Parliament passes a rule, that is the rule of the land. So this is a topic which probably Parliament is avoiding. They are still going ahead with the ruling of Supreme Court. So let's see what our Parliament decides. So we have two speakers. On my right hand side, Dr. Arya, who says that it should be legalized, and on my left hand side, Dr. A.K. Paul, who will say that it should not be legalized. So let's go ahead with Dr. Arya. He'll speak for the motion. Dr. Arya, please.
Yes. वो गिर गया यार. वो गिर गया वो. May I have my first slide, please? Well, good morning. A very warm welcome, and I would like to emphasize that today's topic given to me is, should euthanasia be legalized? And I very strongly feel that it should be legalized, and I am going to speak for the topic. Why I say so? We all know that this topic, euthanasia, is not only a medical topic, it is also a social topic, and it is the need of the hour that we run with the technology and we do what is required and what is the need of the hour. I am sure the persons sitting in this hall, there will not be a single person who is not knowing their own known person or anyone who had terminal illness and they had to extend for months and years in the bed, increasing the suffering of the patient, increasing the suffering of the party. So, what I say is, euthanasia is a term where we are standing between life and death here at the crossroad and we don't know what to do. We are really helpless. We cannot take decision and this is where this topic is being coming over, that should it be legalized, and why this is a burning topic today, why we are discussing and why this is a matter of talk today. Just a question. As man has right to live, does he have no right to die? If there is a terminal illness, why he cannot die? I think there is some problem. So, can a physician, if a physician can take a decision how a person can live, I think the physician should also be given a right to take a decision that if nothing could be done and it is a terminal illness and the pain is there, the pain should be reduced. Pain should be reduced for the family, pain should be reduced for the patient. So, I feel euthanasia should be legalized as early as possible. Reasons of euthanasia. People should not be forced to stay alive. Should people be forced to stay alive? No. And neither the law nor medical ethics require that everything be done, keep a person alive. So, what do we mean by euthanasia? See the definition. The term euthanasia comes from the Greek word meaning eu means good and thanatos means death. So, the term definition of euthanasia is good death. So, where there is controversy? The word euthanasia was first used in medical context, so that is the definition we can speak. Classification. It is been classified as either voluntary euthanasia, involuntary euthanasia. What is voluntary euthanasia? It means euthanasia is induced at the will of an individual by his or her own request. Example, a patient suffering from incurable disease requesting doctor to terminate his or her life. This is known as voluntary euthanasia. What is involuntary, or this is also known as non-involuntary euthanasia? It means euthanasia induced person who are unable to express their wishes. Example, a person with irreversible coma or severely defect or infant, they cannot take decision. So the party has to take decision, and this is known as involuntary euthanasia. Active euthanasia or positive euthanasia, it is an act of commission. Death is induced by direct or indirect action. Example, by giving a large dose of drug that hastens death. This is active euthanasia. And what is passive? Passive, it is an act of omission. Here there is no active intervention to end the life, and example, stopping the heart-lung machine and so on. So euthanasia law, these are the countries who has legalized their euthanasia in the world. Netherlands, Belgium, Colombia, Luxembourg, Switzerland, Germany, Japan. So when this euthanasia is legalized in so many countries in the world, why can't India join it? This is my question. India should also join this list and should legalize it. We all know this Aruna Ramchandra case. She was a nurse in a Bombay hospital and she was strangulated by a ward boy, raped, and she went into coma, and then she was in the vegetative state. Do you know for how long? It was not for 1 year, 2 years, or 5 or 10 years. She was in that vegetative state, my friends, for 42 years. and that was the suffering for her. So, Aruna Sehwag, a nurse who was assaulted by a ward boy, went into a vegetative state in 73 and she passed off in 2015. Writ petition was filed by one Pinky Virani claiming that her right to life guaranteed by the constitution has to be violated. The petition was rejected by the court after medical examination. However, later in this case, Supreme Court in March 2021 held that passive euthanasia could be given a nod in case of exceptional circumstances and under strict monitoring of the apex court. So the landmark case of this Aruna Sehwag recognized 2011 passive euthanasia in which it had permitted withdrawal of life-sustaining treatment and from patients not in a position to make the informed decision. The Supreme Court specified that this could be allowed in whom the brain dead for whom the ventricular can be switched off, those in a persistent vegetative state for whom the feet can be tapered out and pain managing palliatives can be added according to the laid down international specification. So, euthanasia law in India in 2018, the Supreme Court of India declared that the government would honor living wills, allowing essential patients to be passively euthanized if the patient suffers from a terminal illness or is a vegetative state. A living will is a written document we all know. The decision made as part of the verdict in case of involving Aruna Sehwag is she was persistent vegetative state and her death till 2015. So the guidelines, the judgment was passed by a 5-judge commission constitution bench stating that strict guidelines to be followed. It should not be misused, but at the same time, this provision should not be, the patient should not also be deprived. So these guidelines include who can execute the will. Guidelines also declaring the medical board would be required to declare that all life-saving medical options have been exhausted. So the judgment was passed, provides relief to extreme pain, relieves physical, mental and psychological pain, provides more facilities and funds for other patients needing medical treatment and attention. So, pros of euthanasia, it provides a way to relieve extreme pain, it provides way to relieve when a person's quality of life is low, frees up medical funds to help other people, and it is another case of freedom of choice. So, arguments for why I say that euthanasia should be legalized in India. Euthanasia provides a way to relieve extreme pain, provides a way to relieve a person's quality of life is low, it frees up medical funds to help other people. It is another case of freedom of choice. People should not be forced to stay alive. People should not be forced to stay alive if there are no options. Speedy termination of physical and emotional suffering and organs can be put to good use. Please note, in this case, we are doing service to the society by putting the organs can be put in good cause and relief. Mental suffering for the patient and his relatives. This is very, very important. Importance of euthanasia, we have all known this, we have seen this. Requirement of euthanasia, the patient's condition must be terminal with no hope of recovery. We are not telling that you can use euthanasia or you can misuse it. There are strict guidelines and that guidelines has to be followed if you are putting the law in India. Euthanasia must be undertaken to relieve suffering. It can only be undertaken at express request by patient, and a qualified physician must carry out procedure, and the method adopted must be ethically acceptable. There was a survey done of Indian doctors. What is their view on euthanasia? See what is the outcome. Extracts from a sample survey of around 200 doctors. 90% stated that the topic in their mind and were concerned. So, everybody is concerned. Everybody is very much sensitized with this case and it has to be taken over. 78% argued that the patient should have the right to choose a case in case of terminal illness. 74% believe that artificial life support should not be extended when death imminent, but only 65% stated that they would withdraw life support. 41% argued that living will should be respected, and 31% had reservations. Considerations involved ethics, mortality law, and I know this is such a topic that a lot of religious ethics are also involved with this. It is a very sensitive issue. So legal validity in India, study was done. Passive euthanasia is legal in India on 7 March 2011. Supreme Court of India legalized passive euthanasia by means of withdrawal of life support. The decision was made, as we have already discussed, Aruna Sabha case. The Supreme Court specified 2 irreversible conditions permit passive euthanasia: the brain dead for whom the ventilator cannot be switched off, and persistent vegetative state. These are the conditions where euthanasia should be encouraged and legalized. The following guidelines were laid down. The decision has to be taken to discontinue the support either by the parents or the spouse or other close relatives. In the absence of any of them, such a decision can be taken even by a person or a body of persons acting as the next friend, and it can also be taken by the doctors attending the patient. However, the decision should be taken bona fide in the best interest of the patient. Even if the decision is taken, it requires approval from the High Court concerned, and the bench should consist at least 2 judges. A committee of 3 reputed doctors to be nominated by the bench who will give report regarding the condition. Before giving the verdict, a notice regarding the report should be given to the close relatives of the state, and after hearing the parties, the High Court can give the verdict. So, friends, you all must be aware that this topic is so sensitized, so burning, that lot of movies have been made on this topic. Kill Me Please, Time of Life, Salam Vinke, and the Indian Gujaris. I am sure at least you might have seen one movie. So this is the topic. This slide is self-explanatory. I don't need to explain. See the condition, a couple, elderly couple, and friends, please note, we are living in a nuclear family. Most of the children are abroad, not bothered, especially if they come to know that they are in the deathbed, they are not bothered to visit or to take care. And time has changed. We also visit temples for the cure of our patient. But for a terminally ill patient who are suffering for months and years, we also visit temple to pray कि भैया इनको relief कर दिलवा दो. So that is where euthanasia comes into picture. And see, this is the condition when lot of people are there. So I conclude, the issues of right to a dignified death and voluntary euthanasia are not a concern of the medical profession only. So society has to have the watchful eye. All sections of the society must be involved, and using knowledge and new power, integrity is better than just adhering to the dogmas and belief of the past. To call ourselves a civilized society, we must understand death and respect it as much as we respect life. And finally, my friends, as per the 2018 ruling, Supreme Court has held that the right to die with dignity is a fundamental right. So, I conclude, euthanasia should be legalized in India, and I speak for the topic and I stick to it. Thank you so much.
Thank you, Dr. Arya. You have spoken for the motion. Now, Dr. A.K. Paul to put his points against the motion.
Good morning, everybody.
Good morning, everybody, and Johar. The August gathering, the senior teachers, my seniors, my young friends, ladies and gentlemen. Today I am honored and privileged to stand in front of you because of none other than the Japicon committee and our beloved Dr. Bhimani Sarji. Salute to you, sir. Now, Dr. Rabin, an excellent talk. Thank you very much. Good talk, good slide, good postures. But indirectly, you said no also. And we have made my slide easy. Thank you, moderator, sir. Thank you, moderator, Dr. Buddha, sir. Thank you, moderator ji. Can you say change slide? Huh? Nobel winner. He said in Kavita Bengali, Morite chahe nami sundor bhubone, manusher mazi ami bachite chai. The English one, I do not want to die in this beautiful world. I want to live among human beings. That is Kavi Guru Rabindranath Tagore. The topic is, should euthanasia be legalized? I will talk against the motion. That is no. My dear friends, in the audience, can you raise your hands? Painkillers, yes or no? Yes. If he doesn't have any kidney disease, other things, any contraindication. So painkiller, yes. Huh? Really? नहीं पीछे बैक करेंगे
I think Palda needed some homework to be done.
हाँ ठीक है So painkillers, yes, and patient killers, no. Are you agree with me? Let's cure, not kill. That is the slogan. My slogan at least. And it should be everybody's slogan. The introduction that Arya has, that Arvind has told everything, meaning of euthanasia, Greek word, that is good death. That is good. That is good death. The practice of internationally ending a life in order to relieve pain and suffering. It is also called the mercy killing. In many countries, there is a decisive public controversy about the moral, the ethical, and the legal issues of euthanasia. See the slides. Artificial heart, artificial lung, artificial liver, artificial kidney, artificial stomach, artificial blood. And he is asking, let me one. What nonsense. You're playing with God? Just think. Types of euthanasia, Dr. Arvind has already mentioned. One is voluntary. Euthanasia conducted with the consent of the patient, that is voluntary. Another voluntary, euthanasia conducted where the consent of the patient unavailable. Involuntary, conducted against the will of the patient's term in, that is called involuntary, and that is a murder. In passive euthanasia, already told by Dr. Arvind Arya, it entails withdrawing of the common treatments, that is all antibiotic, other gadgets, so that necessary for the continuation of the life. That is the passive. And active, the use of lethal substances, such as, forces, such as demonstrating lethal drug to kill, is the most controversial things. In my point of view, Dr. Arvind Arya, you are in hearing class, I think if you have been difficult, you can take binocular also. See this letter. You can see 6, but I see it is 9. You can see 6, but I can see it is 9. Not all deaths are painful. The distinction between the active and passive euthanasia is significant. Legalizing euthanasia will place the society on a slippery slope, which will lead to the unacceptable consequences. Very, very, very dangerous. When you don't have, nobody has the right to kill except Almighty God. The euthanasia weakens the society's respect for the holiness of the life. Yes. Euthanasia must not be in person's best interest. For example, getting old age, patient killed for the property will. That is property will they can kill. Yes. In my point of view, believe in God's miracle of curing the terminally ill patient. Yes. God is there. He can do the miracle. He can do the miracle. Prospect of discovery of the possible cure for the disease in near future. Yes. So many prospects are there. We can do research also. How to improve the life, how to treat the ill patient. Yes. You can't kill like that. It can't be legalized. See the practical aspects. Proper palliative care makes euthanasia unnecessary. Allowing euthanasia will lead to a less good care for the terminally ill patient. Allowing euthanasia determines the commitment of the doctors, of the nurses to save the life. Yes, that is there. Euthanasia may become a cost-effective way to treat the terminally ill patient. And allowing euthanasia will discourage the search of the new cures and treatments for the terminally ill patients. Definitely, it is definitely there. This is my point of view. I think it should be your point of view also. The case legalized in our country, already Dr. Arya Arvind Arya has mentioned. It is only euthanasia in India, passive euthanasia legalized 2011. The Supreme Court of India legalized passive euthanasia by means of withdrawing support, the patient, permanent vision reform, or the brain death. In 2 cases, you can do the passive legalized passive euthanasia, otherwise not allowed. That Aruna Sahaba case, everybody knows that the Supreme Court of India passed a historic judgment law permitting the passive euthanasia in the country. That Dr. Arvind Arya already mentioned. So I think escape. He doesn't mention anything. See the word, the religions, the Hindus, the Muslims, the Catholics, everybody say, the Buddhism, let us say what they say. Buddhism, according to domain known, emeritus professor, Buddhist Ethics Society, College University of London, he says they oppose assisted suicide and euthanasia. The Buddhist leaders, they teach us that it is morally wrong to destroy human life, including one's own. They say, even if the intention is to end the suffering. No. The Buddhists are taught to have a greater respect to the life. That is Buddhism. Let us see. Catholicism. See, the Roman Catholic Church strongly opposes the free-assisted suicide, strongly opposes. My dear friend, you have omitted so many things. I am coming to that. I am showing you how the people are telling, the religion telling. We are the religion in the society. The church teaches the life should not be prematurely shortened because it is a gift from the God. The John Staff Ethics of National Catholic Churches, Philadelphia, we don't have the authority to take into our hands when life will end. No. That is the Creator's decision. Right? Hinduism, yes. What Hinduism says? There is general concern in Hinduism that prematurely ending a person's life person's life could negatively impact their karma, yes, karma. Say Deepak Sharma, a professor, Western University in Cleveland. The concept of karma is centered around the belief that the good and bad occurrences in one's life are caused by the action taken in the past lives. Since Hindus believe in reincarnation, we believe that whatever suffering you experience now is because of something you did in the past. That is the Hinduism, karma. So, if you circumvent karma by taking some action to stop suffering, you will pay for it later, definitely. That is Hinduism. What about Islam? Islam teaching the opposite, the physicians, assist suicide, euthanasia. They believe that life is scarce, it comes from God. Therefore, it is a sin to take life. From the research, they told there is a reluctance to make any kind of decision that would end life prematurely because it is believed that that is the solely in the hands of the God. That is Islam. So, my dear friend, Dr. Arvind, you have forgotten your religion's topic. So, what I will say to summarize or to conclude, legalizing euthanasia will place the society on a slippery slope, which will lead to unacceptable consequences and will be the black day in the Indian history. The black day. It will weaken the society's respect for the holiness of the life. Yes. Zeal for prospect of the discovery of the possible cure for the disease in near future will perish. Yes. The last but not least, it may become the cost-effective way to treat the terminal ill. And against the Hippocratic oath, virus or fundamental medical ethics, no, you can't. Fear of becoming a burden. Yes. Some people may feel pressurized by the family, by the doctor, or by a friend to request euthanasia. So, again, painkillers, yes. Patient killers, no. Let's care, not kill. At the end, this debate, Aravind, my good friend, good brother, so this is mainly involved. Let's destroy the whole wall, because it is we do not need the wall. He all pine, I'm the apple. So destroy the main wall and we become friends after the debate. Okay? Thank you so much.
Thank you, Dr. Pal. Now I invite Dr. Arya. Both of them are AKs. So, Dr. AK Arya, I invite you for rebuttal.
I will compliment my friend Dr. Paul for an excellent talk. Friends, you must have noticed that Dr. Paul's slides were divided into two parts. One part was the slide which he has mentioned that Arya has already shown. This slide he has shown. And the second part was only religion. Hindu, Muslim, my friend Paul sir, we are discussing science and we are not discussing religion. Number one. Number two, Paul sir has mentioned that let God decide death. If we allow God to decide death, then let God decide life also. What is the need of treatment? Where is our role? No, God will not decide. God will assist. God will guide us what best to be done. And he mentioned 6 and 9. It is 6 or 9. Paul sir, it depends. It is 6 or 9 where you stand. So, where you stand, you will decide whether it is 6 or 9. There is no confusion. 6 is 6 and 9 is 9. Again, he mentioned Rabindranath Tagore quote, I want to live. My friend, we all want to live. Here we are discussing terminally ill. And where is the question of painkiller? We are not discussing any particular medicine. We are discussing patient. And we are only discussing the terminally ill patient where all options of treatment has exhausted and there is no option. Then we are giving relief to the patient, we are giving relief to the party, and please note, it is with the consent of the party, it is with the consent of the patient, and so this has to be legalized as early as possible. Thank you.
Thank you, Dr. Arya. Now it's your turn, Dr. Pal.
माइक है क्या चलिए Thank you, Dr. Arvind. You nicely said. But you can't do survey. There is not a vote bank. You will survey these. The survey doctors, 200, very, very minimum size, 200 doctors, they will decide, mercy killing karna hai ki nahi karna hai. What is? No, no, no. You can't say that. Because nobody has the right to kill. Even the street dogs you can't kill. It will be legalized. Yes? Street dogs also you can legalize. So human beings, you are telling you should kill the human beings. But you are telling terminally, yes, two words are there. Supreme Court says, brain death, one thing. Second is consistent vegetative form. In two cases, it can be allowed passive. Otherwise, no. Not, it is no. So it is, you know.
So Paul sir agrees that passive can be allowed.
No,
so he
no,
agrees
no.
with
Wait,
me.
let him finish first.
Two cases. Supreme Court, Honorable Supreme Court, they have said in two irreversible cases, there is brain death allowed and the consistent vegetative state, what you mentioned. In two cases, allowed irreversible cases, otherwise not passive euthanasia, not allowed. Because the case on, nobody has the right to kill. Because this is from the Almighty. Yes, everything is on the Almighty. When you are born, you are from Almighty, yes. So, no mercy killing, provided the two obstructions are there. Irreversible causes, brain death and vegetative form. Thank you so much.
Only 1 minute, sir.
No, Dr. Pal, so we have come to the end of this debate. So I think this should be debated in Parliament at Delhi also. Our Parliament has already discussed. But we are very decent. Like our Parliament in Delhi, we won't stall the proceedings of the event. So we go ahead with next discussions. So I hand over the mic to Dr. Virmani, please.
I will request the chairperson to give the memento to both the speakers. And while he's giving the memento, please give a big clap for both the speakers. Both have done a wonderful job. And I think both of us agree that there are clear-cut guidelines where euthanasia is allowed Otherwise, it cannot be done. But the problem is, my friend Dr. Umesh Khan is very worried. He tells me, those who are drinking, those who are smoking, those who are under tremendous stress are already committing active euthanasia. So is that not legalized? Thank you. Now the speakers to the chairperson. Thank you. Both of the speakers, Dr. Arvind Arya and Dr. Amia Paul, have lived up to the expectations of this debate. We'll go to the next session. The chairpersons are Dr. R.L. Agarwal and Dr. Mrityunjay is left, I think. R.L. Agarwal and Dr. Ashwani Kumar. Is Ashwani Kumar here? Dr. Ashwani Kumar? No? Can I request Dr. Gagan to please join in as chairperson? Oh, you are one of the speakers. Sorry. Dr. Agarwal, the first speaker, Dr. Noni Singha, after his talk, he has to leave for Calcutta. So we'll felicitate him after his talk, and then you can continue with the other two speakers.
Our next speaker is Dr. Noni Singha from Assam, and he will be speaking on clinical approach to chronic anemia. Over to Dr. Noni Singha.
I have got a very important announcement to make. Just 1 minute, sir. Please come. Yesterday, one of our very senior member, Madam B.R. Master, has lost her wallet in this hall. It is a black color wallet, purse है. अगर किसी को मिलता है तो please kindly hand it over to either madam or to us, because madam का एक ही request है कि I want that purse वापस, because उस purse में मेरे husband का photo है. Not bothered about the money or anything, तो उसमें husband का photo है, तो please I request, अगर किसी को वो purse मिलता है, black color का है, please hand it over to us. Thank you.
Respected chairpersons, my seniors, colleagues, ladies and gentlemen. First of all, I'd like to convey my heartfelt thanks to the organizer of Japicon 2023, especially the Virmani sir, for inviting me. I am really privileged. So, I have been given the task to talk on the clinical approach to the chronic anemia, and we all are very much acquainted with the topic. It will be just a revision. And the chronic anemia, you know, that is a very vast subject. I'll touch upon the important salient points in this stipulated 18 minutes time. So this is my disclosure. So definition we all know. And just according to the National Cancer Institute, the severity of anemia can be divided into mild, moderate, severe, and life-threatening. And the mild being the hemoglobin more than 10, then the lower limit of the anemia definition. Moderate is around 8 to 10, and the severe is 6.5 to 7.9, and the life-threatening is below 6.5. According to the duration also, anemia can be divided into acute anemia and the chronic anemia. Acute anemia is predominantly due to the acute blood loss or acute hemolysis. Chronic anemia have been more common and secondary to multiple causes. As my talk is on chronic anemia, I'll stick to chronic anemia. This is the table from the principal text of medicine Harrison. Quite useful. I just, in the initial talk, I'll just touch upon this slide. Just because anemia has a lot of different types and different approaches with there. There are many morphological type and the etiological type. And still the morphological different types is most useful in the clinical practice. And just see from the slide that acute anemia only basis of the CBC and reticulocyte, and we can divide into the hemolysis hemorrhages or red cell morphology. If the reticulocyte index is more than 2.5, is an hemolysis hemorrhages, the causes you can see that blood loss, intravascular hemolysis, metabolic defect, membrane defect like erythrocytosis, spherocytosis, hemoglobinopathies, immune destruction, etc. Once that reticulocyte index is less than 2.5, it depends on the morphology, and depending on the morphology, it can be divided into macro, micro, and the macrocytic anemia, which I'll come in details in next a few of my slides. According to etiology, it can be divided into hypoproliferative and the maturation disorders. And those I'll touch upon in my subsequent my talk slides. The microcytic anemia, when MCV is less than 80 femtoliter, the causes you can see, the iron deficiency, which is the commonest, thalassemia, anemia of chronic disease, sideroblastic anemia, and the microcytic, when the MCV is more than 100, and the commonest cause being the vitamin B12 and folic acid deficiency, alcoholism, liver disease, myelodystrophy syndrome, drug-induced hypothyroidism. Just one thing is that if MCB is more than 110, is likely we are dealing with vitamin B12 and folic acid, which is usually megaloblastic, and the others are usually non-megaloblastic. Normochromic is 80 to 90, causes are anemia of chronic kidney disease and bone marrow suppression. Just touch upon the epidemiology. Iron deficiency is the commonest, affecting 8 to 9% of the world population. Anemia is more prevalent in the developing countries because of the poor, improper medical care and malnutrition. And the women, it is seen chronic anemia seen more commonly because of pregnancy and menstrual bleed. In African American, due to the sickle cell disease, D6PD deficiency, where it is more prevalent. And we all know that in older adults, it is due to multiple comorbidities. Pathophysiologies can be decreased red cell destruction, blood loss, and the RBC destruction, which we call hemolysis. So decreased red blood destruction can be lack of nutrition, bone marrow problems, lack of hormones like erythropoietin CKD, levothyroxine in hypothyroidism. There will be ineffective erythropoiesis. Blood loss can be gastrointestinal, menstrual, surgery, trauma. And the hemolysis can be inherited hemolytic anemia or acquired hemolytic anemia. And I'll just passing hurriedly to cover my main clinical approach, but I'll touch upon the acute anemia disease little bit because it is important to know the management. Anemia of chronic disease common in hospitalized patient is caused by the long-standing disease, infection, inflammation, malignancy. And here the pathophysiology is that there is an increased production of hepcidin by the liver, and the hepcidin binds to the receptor ferroportin, which ultimately decreases the intestinal absorption and decreases the release of iron from the liver and macrophages. There will be decreased ability of iron to erythropoiesis. Apart from this, inflammatory cytokines like TNF, alpha, interferon, gamma, and IL-1 also causes increase in the red cell destruction, suppresses the proliferation of erythroid precursors, and inhibiting the release of erythropoietin from the kidneys. Also, the cytokines, the decreased production from the erythropoietin and the decreased response to erythropoietin, and ultimately red cell decreased half-life, and finally the anemia. This is just the flow chart of what I spoke. The causes of ACD, we all know that I have already spoke. And this is the pathophysiology. I come in details if my time permits. And now next I like to touch upon the chronic kidney disease, and which you will know that nowadays it is quite common and is one of the common causes of chronic anemia, and the incidence of chronic anemia increases as the stage advances. And we all know that in anemia the tissue hypoxia and which stimulates the erythropoietin, but in the CKD progresses, there is the response of erythropoietin to hypoxia decreases. Thereby, the low erythropoietin level in the anemia and the CKD also can cause from the hemolysis. And apart from that, they can have the iron deficiency anemia because of reduced intake and the increased intake, increased blood loss. Clinical manifestation, we all know that. I'll not touch upon this August gathering. And only thing is that I like to mention that there, in the evaluation, they should have the increase, there will be details, medical history, home medication, alcohol use, family history, ethnicity, and country of origin, etc. The main evaluation part, in the evaluation, we need to, basically, we have seen in my initial flow chart that only CBC and reticulocyte we can get the important morphological differentiation of anemia. From simple CBC like hemoglobin hematocrit, we can know the severity of the anemia, and also that from the morphological type MCB, we can know that which type usually we are dealing with, either normo, micro, or macro. And the reticulocyte index will tell us whether undergoing hemolysis is going or not. And we can accordingly, simple from CBC, we can accordingly plan out which way we are going to proceed. So please, while ordering any blood, instead of routine blood, please advise CBC. It gives lot of information, and lot more information we'll get when we'll go through, I'll explain in my next few slides. And we know that the renal and liver function to be tested in suspected patients, iron studies, iron, TIBC, and ferritin, which is very important. We're differentiating the iron deficiency anemia, chronic anemia, and other causes. THS, B12 well, folic acid, stool for occult blood, peripheral blood smear, hemoglobin electrophoresis, bone marrow examination if needed. Gastroenteroscopy, colonoscopy if GI bleed is suspected, imaging study like if malignancy is suspected. Mind it, all this battery of investigation not required in a single patient. You got to proceed according to what the initial your step up you got to do, and you got to do very intelligently, accurately, and you got to see the pocket of the patient also. And if you can get to the diagnosis and the clue, probably you can help the patient in minimizing their expenditure, and they're getting the right treatment and early treatment. So this is again I like to touch upon the diagnostic algorithm. And if you see that in the MCP is less than 80, there is a microcytic. If there is a low iron and there is a low ferritin and high TIBC, likely iron deficiency anemia. But if there is a low iron, high ferritin, and low TIBC, and likely of anemia of chronic disease. And if you look at the CBD, sometimes they give the Menger index. Menger index is less than 12. Right, in thalassemia also we are getting microcytic, probably we are dealing with thalassemia. MCB is normochromic. Then if there is a more than 2% of reticulocyte count, and I said that either hemorrhage or hemolytic anemia. If less than 2%, hypoproliferative like leukemias, aplastic SL aplasia. If MCB is more than 100, like, it is a macrocytic. And if the in the peripheral blood, megalocytes or segmented neutrophils in the peripheral smear, probably we are dealing with megaloblastic anemia. The most common ones are vitamin B12 and folate acid. If it is absent, the other causes like alcohol, liver disease, hypothyroidism, myelodysplastic syndrome. Now you happen to see a patient and in the got a hematological abnormalities. If you see if it is there, so directly one can go for the bone marrow examination to know these causes. And if there is no, then we got to see if there is a reticulocyte count. You can again look for there is an evidence of hemolysis that can be seen if there is an indirect hyperbilirubinemia. There is evidence of LDH, increased LDH, decreased haptoglobulin and hemocysteine in the urine. If these are present, probably you are dealing with hemolysis. So you got to evaluate for the causes of the hemolysis. Indirectly also, if you happen to see sometime a LFT report of a patient, if there is an indirect hyperbilirubinemia, please rule out hemolysis first. If there is no, then hemolysis or hemorrhagic anemia. If there is a less, then if this is not there, evidence of hemolysis, then you got to look for the other morphology and plan accordingly, which I just spoke. The microcytic anemia, I already spoke how to approach, and the TIBC. Only thing is that if there's a normal serum iron, normal TIBC, normal ferritin, we need to work for hemoglobin electrophoresis to rule out the thalassemias. If there is an increased serum iron, normal TIBC, and increased ferritin, probably you are dealing with sideroblastic anemia. And this is a picture. You can see that the MCB 69 below 80 is the microcytic picture. And this is the microcyte hyperchromic picture peripheral you can appreciate. So if we summarize the microcytic anemia based iron based studies, then iron deficiency anemia, there will be low iron, high TIBC, low ferritin. In anemia of chronic disease, low iron, low TIBC, high ferritin. In sideroblastic anemia, high serum iron, normal TIBC, high ferritin. In thalassemia, there will be normal serum iron, normal TIBC, normal ferritin. This is the sideroblast. Now, the approach of macrocytic, I have already touched, and only thing is that if there is an vitamin B deficiency and we go to further, we might do the sealing test to rule out the pernicillin, which is very difficult to do, and now almost it is obsolete. And you can see this picture where the MCB is more than 117. Probably this picture we are likely. I'll just finish in. Finish in 2 minutes time. And probably dealing with megaloblastic anemia. And if happen to see in the, sometime in the peripheral backside, if you happen to see there is a low platelet or WBC, then we look for splenomegaly. If there is a hypersplenism is there, then there could be hypersplenism, liver disease, lymphoma, SLE. If no, probably we are dealing with multiple myeloma, aplastic anemia, or myelodysplasia. If increased platelet or WBC, then probably increased platelet is the inflammation, acute leukemia, chronic leukemia, fibrosis, and the increased platelet we can see in the iron deficiency also. I'll skipping. Apart from this, these morphological types, you go to look for the hemolytic anemia. If there is a suspected hemolytic anemia, you need a good pathologist to look for some type of cells which can give us clue for the disease we are dealing with. If it's spirochetes and there is a direct antiglobulin test positive, probably autoimmune hemolytic anemia. If it is negative, likely spirocytosis. If cystocytes are there, then probably you are dealing with DIC, PPD, etc. If there is a hypochromic microcytic anemia, thalassemia, if the sickle cell anemia, and if in an infection after the drug, if you see some anemia, probably you got to look for G6PD. If with the fever, you got to look for malaria, babesiosis, etc. I'm skipping this slide. Now, treatment part. Usually the chronic anemia managed predominantly the outpatient management. It needs hospitalization if the patient is symptomatic. There is a significant drop in hemoglobin. Transfusion is needed. Extensive investigation are needed. The patient has acute bleeding or hypovolemia, tachycardia, altered mental status, and the presence of pancytopenia. If iron deficiency anemia, either we can go for intravenous or the oral therapy, and the mostly oral therapy serves the purpose. But the IV iron can be required in the situations when the hemolysis is going on, cardiac instability, where the iron is not actually is patient accepted by the people is an allergic to the patient. Probably we need to go for the iron IV therapy. I'm not going details. The oral therapy usually one should prescribe the ideal, the supplemental dose. The elemental iron is actually therapeutic dose 100 milligram per day. And one must choose the molecule which contains 100 milligram elemental iron. And one must please keep in the mind after correction of the anemia, 100% make it 100%, one should follow for at least 3 to 6 months to cover the iron stores. Suppose your hemoglobin is 50%, usually 100 milligram elemental raises the hemoglobin 1% a day. So arbitrarily you need on 50 days more to have 100%, so 50 plus 90 days of minimum iron store 90, so it becomes 140 days. So when iron deficiency anemia is there, you need to prescribe iron for at least 150 days. And next, vitamin B12 folic acid deficiency, we need to supplement, and the August gatherings know very well how to supplement this. EPO injection in the chronic kidney disease, we need erythropoietin. There are erythropoietin, darbepoetin. Darbepoetin is the newer generation having the advantage of giving twice in a month. But before prescribing EPO, one must look at the serum ferritin level, because if there is a iron deficient state, the erythropoietin is not going to help much. So if you look for the ferritin, if ferritin is less than 100, one should prescribe thrice the normal requirement of the daily iron, that is 300 milligram elementary iron. If 100 to, I'll just take 1 minute, sir, if you permit. So if it is 200 to 300, if it's 100 to 200, twice the normal, that is 200 milligram of elementary iron. If 300 to 500, only 100 milligram elementary iron. No doubt after 500, one should be cautious of using the iron. Above 800, one should not use iron. So thyroxine, treatment of the causes, avoiding the culprit medications, regulation materials in the patient with the menorrhagia. So just few lines about the anemia and chronic kidney disease. Apart from treating the cause, omega-3, the polyunsaturated fatty acids have been observed in several clinical scenarios to downregulate the production of TNF-alpha and IL-6. They have also shown promise in treatment of anemia of chronic disease in rheumatoid arthritis and diabetes mellitus, an effect largely mediated via their actions. The polyunsaturated fatty acids have the advantage of being safe, and there is no little side effects. The hepcidin provides the interesting target for the management of ACD due to the central pathogenic role, which I explained. The high level of hepcidin have been found to correlate the failure of ESAs, erythropoietin stimulating agents. So there is a novel anti-hepcidin agent NOX H94 has been produced, been tried in the anemia of treating in the animal models, and the combined treatment of the hepcidin inhibitors with ESA was found to be superior to the ESA alone. And the GDF15 also been proposed as a suitable target due to the central role in mutagenesis, angiogenesis, and metastasis, as well as anemia and chronic disease in various malignancies. The idea of combination therapy has become more appealing since the revelation of a hepcidin-independent pathogenic pathway for the anemia also been explained. So what is my take-home message is that anemia is the most common hematological disorder and one of the most common conditions seen in the clinical practice. Iron deficiency anemia is the most common cause of anemia, while anemia of chronic disease is the second most common in the hospitalized patient, most common cause in the hospitalized patient. Anemia is not a diagnosis, but a presentation of underlying disease. Work for the cause of the anemia can unmark many of the underlying diseases and thereby helping to treat the patient early and appropriately. Comprehensive history taking and physical examination are the very important in diagnosing anemia. If early workup is unrevealing, appropriate consultation by a specialist is important for further workup and treatment. Thank you for the patient wording.
Thank you, Dr. Singha. Any question from the audience? Any question from the audience?
हेलो सर, नमस्ते सर। क्लिनिकल अप्रोच टू क्रॉनिक एनीमिया, हम लोग झारखंड से बिलोंग करते हैं। झारखंड या फिर ऐसे छत्तीसगढ़, उड़ीसा और ऐसे डेवलपिंग स्टेट्स कि जहाँ पर एनीमिया एक अपने आप में बहुत बड़ी डिजीज़ है और वो ग्रास रूट लेवल तक बहुत ही ज़्यादा रूट तक पहुँची हुई है और लोगों को बहुत परेशान करती है। तो एज ए जर्नलिस्ट मैं ये जानना चाह रहा था कि क्या अप्रोच किया जाए, बीइंग ए डॉक्टर, बीइंग ए जर्नलिस्ट, बीइंग ए सोशल एक्टिविस्ट, जिससे एनेमिक पेशेंट को उसको उस परेशानी से बाहर निकाला जाए और उसका रिड्रेसल हो सके। थैंक यू सो मच सर।
Thank you. That's what I explained, Dr. Saab. May I know your good name?
My name is Dr. Anuj from India TV Online, editor, Jharkhand, Bihar or
Thank you, Dr. Anuj. It is simple because in India we know that if you do the incidence is quite common and malnutrition is quite common. So you got to address the malnutrition first. And you got to and one clinician, one clinic, and if the patient comes to the clinics, one should be very aware, and at least before seeing a patient, one should do basic things. One look at the anemia, the lower that eyelid, and the pulse rate. These two diseases can give you a lot of clue. In the simple pulse rate can give you a lot of things. And if there is you are holding a, you are not seeing a palpable pulp, आप आँख में अगर नहीं देख रहे हैं, आप अगर पल्स देख रहे हैं, अगर टेकीकार्डिया तो आप अगर तब जरूर आपको एनीमिया देखना है, because one of the commonest cause of tachycardia is anemia. So, and apart from this, we got to develop the nutrition, we got to develop the hygiene, and most important in the female, where I mentioned that the menstrual loss is one of the important cause of anemia in the young females or the female. Actually, if we see the amount of loss, probably it is supplemented by food, and इसलिए मेरे ख्याल से the any menstruating women को हम लोग actually if you can prescribe iron at least once in 3 months in a year, maybe continuous or maybe intermittent divided monthly wise, that also might somewhat prevent this. And you got to develop the nutrition and the diet, actually whatever diet we can do. Apart from that, and India and the most of people are vegans. So that in the vegans, I think we should, once they come to the patient, and one should always look for the anemia, and they should treat, and they should be supplemented. So these are the basic things. आपको करना है, एक करना है anemia. Apart from that, anemia आपको काफ़ी disease को lead करता है, जो मैंने आपको अभी दिखाया है. So this is a very basic thing. I thank my Abhirmani sir for taking this topic, because I need to talk so many things, because of the time constraint I just go hurriedly and pass each and everything. Anemia of coronary disease itself is a big topic. Anemia, iron deficiency anemia is a big topic. So probably we got a very clinical eye, and the history taking is very important, and improvement the nutrition and hygiene.
Yes. The public awareness and togetherness and approach साथ में हो, तब हम लोग उससे fight को जीत सकते हैं. मतलब ऐसा है.
Sure.
Thank you, sir. Thank you, sir.
Excuse me. Very nice thought.
Thank you, sir.
Which is the best iron for this heme iron or elemental iron or various sort of iron which you are having? Which is best when a palatable sort of thing and to raise the hemoglobin level also?
See, sir, so many preparations are there. As you know, usually the book says the ferrous salt one should choose, and you know that ferrous salt the requirement, and this thing are there, and there is a lot of side effect. And like this, many patients cannot tolerate that black stool are there. So as of now in the market, what is the ferrous ascorbate is clinically is the most acceptable to the patient, and there is a least side effect with the ferrous ascorbate, and it get in the exact dose of elemental iron of 100 milligram of elemental iron. So many things are in the market. If you happen to choose ferrous ascorbate, I think this is accepted. Lot of other type more are there, because they are not actually comparable to how much elemental iron they are equivalent. They say कि hemoglobin rise. Whatever the molecule you use, there should be 1 gram rise in a month. If you use any iron deficiency anemia, if you are not increasing 1 gram in a month, probably you are dealing with not proper medication, or patient either not taking, or there is some iron resistance states are there. Thank you, sir.
Time for blood transfusion, sir? Blood transfusion, when will you require?
So, see, sir, when there is a cardiac instability is there, when there is a life-threatening severe anemia is there, mind it, in the chronic anemia, patient can survive very low hemoglobin. In the clinical practice, you can see that sometimes the patient of hemoglobin 4, they are very much adaptable. In chronic, if there is an acute anemia, there is that adaptability system of mitochondrial, that adaptation is not there. But depends upon the situations. If you are dealing with hemolysis, there is a trauma, blood loss, and there is a cardiac instability, you need iron to be immediately corrected, and you got to decide according to the situation. There is you need to provide the blood transfusion.
And thank you, sir.
One more question. Is anti-hepcidin available in the market?
Sir, it has not already come. It is in the now phase 2 trial. It is not even used, but these are the pathophysiology they are looking after, and this may be in the future, this may be the molecule, what I have said, that molecule.
Thank you, Dr. Singha, for such a nice presentation on clinical approach to chronic anemia.
Well, I step in between because Dr. Noni has to leave now. Thank you so much. Please come. He has come all the way from Assam and he has to catch a flight, so we will release him now before we resume with the other talk. May I request the chairperson to please hand over the memento, and a loud round of applause from all of you. It is very surprising that we could manage speakers from all over India, and that too Jamshedpur minus airport. Thank you, sir. Thank you, Dr. Noni. क्या whispering हो रहा है? Okay. All the best for and happy journey. Dr. Agarwal, please continue.
Our next speaker is Dr. V.K. Mundra. He will be speaking on clinical approach to subclinical hypothyroidism.
Thank you, Chairperson. This is me. I bring greetings from Mundra Hospital. I have nothing to disclose. So my topic is approach to a patient of subclinical hypothyroidism. So many a times you are confused whether to treat this patient or not. So in next 18 minutes or so, I'll tell you when to treat and when not to. Roadmap to my talk will be definition of subclinical hypothyroidism, that is SCH, and epidemiology, back to basics, that is history and clinical examination, most important thing, investigations, then why to treat. Here I will show you some caveats from clinical trials in this evidence-based era, then whom to treat and how to treat, and lastly I will keep these few clinical scenarios. Now definition, all of you know, when TSH is more than upper reference limit, that is above 4.5 milli international unit per liter, and FT4, that is free thyroxine, is normal, that is between 0.7 to 1.8 nanogram per DL. But this is applicable only when thyroid function has been stable for weeks. That means you have to rule out transient increase in TSH. The most common conditions are recent or ongoing non-thyroidal illness, which you call sick euthyroid syndrome. And another important thing is intake of either amiodarone or lithium. This is also very important to elicit the history. And the second thing, when subclinical hypothyroidism is to be established, that hypothalamic pituitary thyroid axis should be normal. Now, in this slide you will see that as all of you know that it is a negative feedback mechanism. As FT4 level goes down, TSH increases. But here you will see that even when there is a slight decrease in FT4, there is disproportionate rise in TSH. So this is the area when FT4 is within the normal limit, but TSH is already high. So we'll discuss this area, because overthyroidism, all of you know, you have to treat it. Now, almost 60% cases of subclinical hypothyroidism, they revert back to euthyroids. That is very important to know, because you should not treat inadvertently all the cases. And of the remaining 40%, 1.5% cases per year go on to develop overt hypothyroidism. Now, epidemiology, this is Indian data. We'll concentrate on Unnikrishnan et al. Because that is the largest series, almost 5,307 persons in the community, and he found that the incidence was as high as 8%, and other authors, they have found even higher incidence in the society, and worldwide it is 4 to 20%. So you see the incidence is quite high, so all of you should be aware whom to treat, whom not to treat. Now this will come later. So back to basics, as already discussed by many of stalwart speakers, that kitna bhi science advance kare, machine aa jaye, but we have to stick to basics, that is good clinical examination and good history. So in the history, it's very important to see the age of the patient, because if the patient is above 70, we have to be a bit careful in deciding the treatment. And in a female, we have to see whether the female is of childbearing age or not. then we should elicit the history suggesting frank hypothyroidism, that is cold intolerance, recent weight gain, easy fatigability, and there are so many things, all of you know. Then history of prolonged illness, atherosclerosis, cardiovascular disease, history of infertility in female, coronary heart disease, cognitive dysfunction. This is very important. Many a time we miss this psychological problem in hypothyroid patient. Then in clinical examination, features of hypothyroidism should be looked for: dry skin, edema, hoarse voice. Then we should look for whether goiter is present or not. And we should look for features of heart failure. Now investigation, since the patient has already come with the report of FT4 and TSH, that is why we label the patient as subclinical hypothyroidism. Now next is antithyroid antibody. There are so many antibodies which you can do, but for clinical purpose, only anti-TPO is good enough, so that will save money of the patient also. Then in few cases, you should go for lipid profile, blood sugar and ECG if needed. Now question is, why to treat? In this evidence-based science, you have to have solid data to prove that you want to treat such cases. So here, this is a meta-analysis for cardiovascular morbidity and mortality, and total mortality also was included in this meta-analysis. Almost 55,000 participants in 11 prospective studies were included. Here you will see in coronary heart disease event, when the level is, TSH level is above 10, the risk increases almost 2.5 times. Similarly, coronary heart disease mortality also increases 1.5 times when TSH is above 10. And total mortality also in most of the studies, it has been shown that if TSH is above 10, the total mortality also increases. So this was published in JAMA 2010. Now another slide which shows that risk of heart failure events were increased with both higher and lower TSH. We are concerned with high TSH here. Again here you will see that when TSH is more than 10, the risk increases many folds. Now subclinical hypothyroidism is associated with adverse prognosis in heart failure patients. So these are established heart failure patients. Here you will see that in a established heart failure patient, if it is subclinical hypothyroidism, cardiac event rate increases as compared to if the patient is euthyroid. Similarly, in a subclinical hypothyroidism, all-cause mortality will increase as compared to euthyroidism. This is another meta-analysis which is showing, covering 16 observational studies, and it is showing that cholesterol level is high in most of the study, and increased all-cause mortality in subclinical hypothyroidism. Again, most of the studies show this. So we see that cardiovascular risk increases in case of subclinical hypothyroidism. The pathophysiology being, it can cause hypertension, it can cause cardiovascular abnormality, and diastolic dysfunction of heart is most common here. It can cause endothelial dysfunction, it can cause increased arterial stiffness, it can cause dyslipidemia, and all of these will cause increased cardiovascular morbidity and mortality in the form of increased coronary heart disease, increased incidence of heart failure, and increased incidence of atherosclerosis. So we have a solid basis to say that we should treat, but whom to treat and whom not to. There are two subsets of patient. In one subset, you have to be very vigilant. Observation is the best mode of treatment. So if you see a report of TSH 7 or 8, just straight away don't jump to treatment. There are many patients where observation is more important. In fact, observation is to be done, not the treatment. So these are the patient. Absence of thyroid peroxidase antibodies. Here we are discussing those cases whose TSH value is between 4.5 to 10. You have already seen that those having TSH value above 10, they need to be treated. So these are the patients who fall in the category of TSH 4.5 to 10. So absence of thyroid peroxidase These need observation, no symptoms of hypothyroidism, no progression of TSH elevation, TSH concentration less than 7, not of childbearing age, absence of metabolic syndrome, no heart disease, age above 70 years, normal lipid profile. These subset of patients will need observation. So you treat the patient, you don't treat the value. Now just opposite this, these are the subset of patients with value of TSH value of 4.5 to 10 where treatment will be needed in most of the time. Positive thyroid peroxidase antibody, TSH concentration between 7 to 10, metabolic syndrome, pregnancy, heart disease, attempting conception or infertility, hyperlipidemia, neuropsychiatric symptoms, symptoms of hypothyroidism, and age below 65 years. So these type of patients will mostly need treatment. Now few guidelines when to treat and how to treat. So these on the left hand side we have two European guidelines, American guidelines, and on right hand side this is European guidelines. You will see that in both the guidelines when TSH is markedly increased, that is above 10, American guideline says levothyroxine should be considered because of an increased risk of heart failure and death from cardiovascular disease, evidence grade B. Whereas European guideline says that younger patient treatment with LT4 is recommended even in absence of symptoms, but in older patient, just mark here, in the European guideline they are very particular. If the age is above 70, you have to be careful. Treatment with LT4 should be considered if clear symptoms of hypothyroidism are present or if the risk of vascular event is high. And when the TSH is between 4.5 to 10, American guideline treatment should be considered on the basis of individual factors. That is symptoms of hypothyroidism already we have discussed. And in European guidelines, again they say that trial period of treatment should be considered with symptoms suggestive of hypothyroidism when level is between 4.5 to 10. And in older patient, they say it should be avoided. If possible, it should be avoided. Now once you have decided that this patient has to be treated, now how to treat? So that all of you know, treatment of choice is oral levothyroxine administered daily on empty stomach. Now dose, coming to the dose, in patients without cardiac disease, elderly patient, we prefer levothyroxine 1.5 microgram per kg body weight per day. In patients with cardiac disease, definitely we go with low dose. We start with either 12.5 or 25. Similarly, in elderly patient, we start with low dose 25. And once you have started the treatment, in the follow-up, you have to recheck TSH every 2 months after starting. Goal is to stabilize TSH in lower half the reference range. In elderly, treatment should be individualized. In 70 to 75 years, target serum should be bit higher, that is between 1 to 5. Now, if you decide not to treat the patient, you have to follow up and observe the patient. It's this subset of patient, if thyroid function has normalized following an initial abnormal TSH result, we have already said 60% normalized. No further testing is required if in those who are asymptomatic, have negative thyroid antibodies and do not have goiter. And in those who have persistent subclinical hypothyroid, thyroid function should be tested every 6 monthly for first 2 years and then yearly thereafter. Now we come to few clinical scenarios we have already discussed. Now we will see, this is the first case of subclinical hypothyroidism, TSH 7.2 FT4 normal, 26 years old asymptomatic female with 40 years of pregnancy. So that is first trimester of pregnancy. So if you see a female in pregnancy, particularly in early pregnancy, first trimester, you have to be very aggressive in the treatment. So you have to start with high dose, and instead of 8 weeks, you have to repeat TSH every 6 weeks. And in first trimester, the target TSH should be below 2.5, and in second and third trimester, it should be below 3.5. So you have to treat aggressively. Now second case, 76-year-old male with heart failure, ejection fraction 40%. This hypothyroid case will definitely need treatment because patient has got heart failure, but you have to start with low dose because he is above 70. This 40-year-old asymptomatic female, TSH normal, high, FT4 normal, she won't need treatment. Observation. 56 years old, asymptomatic male, TSH 11.5, FT4 normal. So according to guidelines, since TSH is above 10, this will need treatment. 54-year-old diabetic female with LDL cholesterol 150, strong family history, TSH 8, FT4 normal. Yes, definitely she'll also need treatment. And 42-year-old female with easy fatigability and goiter, anti-TPO positive, hypothyroid, yes, definitely she'll also need treatment. So take-home message is thyroid hormone regulates the cardiovascular system to meet the body energy consumption. Subclinical hypothyroidism leads to alteration in cardiac function, vascular function and lipid metabolism. L-thyroxine therapy reverts several of these alterations and may benefit patients with subclinical hypothyroidism. Treatment should be individualized. This is most important. Treatment should be individualized. Treatment of subclinical hypothyroidism improves CV risk factors and symptoms and may improve CV risk in younger individuals. So that take-home message, first you have to decide whether it is a true thyroid disease or not. Then secondly, you have to decide whether it is persistent or transient. Once you are sure that is subclinical hypothyroidism, you have to see TSH level. If TSH is above 10, you have to treat, and if TSH is below 10, you have to treat, but you have to personalize the cases. Thank you for patient hearing.
Thank you, Dr. Mundhara, for such a nice presentation to treat about the subclinical hypothyroidism. Is there any question from the audience? Dr.
Yes.
Nandwani.
I know Dr. Nandwani gives bouncers, so I am ready to duck.
Hello. This is not a bouncer. This bouncer comes from the anesthetists to us. Can I sit down? Yeah. See, patients waiting for a planned operation, it comes from the anesthetist actually. Asymptomatic, no comorbidities, going in for surgery, TSH 6, 7, 8. So do we or do we not give the LT4? Their argument is the LT4 should be given because it hastens weaning off or recovery from anesthesia. What's your take?
I'll just share one of my experience. I was working in ICU, TMH, and Dr. Samadar was there. So one of the cases, as said by you, patient was not recovering from anesthesia, and I don't know, at that time probably TSH was not a routine test, so it was not done, and I just asked for a TSH level, and it was patient was a hypothyroid case. So definitely that is what my personal experience is there. So I will say that if it is below, if it is above 8 or something, you should wait, you should start the treatment. But if it is below 8 and clinically patient is fine and clinically there is no signs of hypothyroidism and anti-TPO is negative, you can subject the patient to anesthesia, but then you have to tell the anesthetist that it might take a bit longer. So
yeah, but they insist that we give, so I don't have a clue to it.
I think Dr. Nandwani has raised an excellent question. Now, anesthetist will make him unfit, as simple as that. The premise is that people who have patients who have raised TSH, their recovery from anesthesia is very poor. So it is better to treat these patients temporarily till the operation is over. Get the TSH to less than 4 or 5, then only he can be fit for surgery.
Unless it's an emergency.
No, emergency is different. Emergency is different. But for planned surgery, always try to keep the TSH below 5, before you make him fit for surgery as a physician?
So simply because the hypothyroidism patients are very poor in tolerance of any sedative. They are very, they usually don't tolerate. So any sedative should be avoided as such. But if it is surgery requiring sedative or whatever may be the drug, so you can give temporary, what Dr. Bidmani has rightly said, you can give a small dose of thyroxine for short periods. About a week, that's enough. But take care of any arrhythmia if patient is susceptible. That's all.
Can I?
Yes, yes,
Yeah.
yes.
Sorry, this is ignorance here now. Hypothyroid, and you've decided not to give treatment. Is there any study about such patients undergoing echo, serial echos, with patient under observation with a high TSH? Just my query, it's an ignorance also.
You mean to say after observation, how many patients they go on to develop overt hypothyroidism?
No, serial echo में कोई change आता है?
Echo?
हाँ.
No, I don't know.
No, you don't know. That's okay.
But pericardial effusion is one of the findings, very
That's
common
what
finding of.
I was asking.
Yeah, that is a very common finding.
Cardiomyopathy.
In fact, if you see a case of pericardial effusion and you are unable to diagnose what cause it may be, you should always ask for thyroid function test. Many a times it causes pericardial effusion.
Thank you.
Thank you, Dr. Mundra, for such a nice presentation on clinical approach to subclinical hypothyroidism. Thank you. Our next speaker is Dr. Gagan Gunjan from Ranchi, and he will be speaking on clinical approach to palpitation.
Good afternoon to one and all. As I proceed with my topic, a very simple and basic topic, but we see these patients in our daily practice. So I will make you go through the slides with the following contents as I proceed forward. To introduce with the term palpitation, these are an unpleasant perception of heartbeat described by patients as a disagreeable sensation of throbbing or movement in the chest or adjacent areas. One of the very most common presentations to the general practice, accounting for almost 16% of the general practice presentations to the general physician and also to the cardiologist, just next to the ischemic pain or chest pain. Although majority of them are benign, some clinical and ECG signs determine when further investigations are necessary and patients should be investigated further. Rarely, these palpitations prevent any serious cardiac events, or mortality and morbidity is also rare but very disturbing to the patient if present on daily basis or frequent symptoms. So if we go to the epidemiology, the palpitations are yet little known. Nevertheless, there is evidence to suggest it's very frequent symptom in general population, especially in patients of hypertension or heart disease. Few people would claim never to have felt palpitations at some time in their lives. It accounts for almost 16% of the symptoms that prompt investigations or further evaluation. Coming to the pathophysiology part, if we look at the pathophysiological mechanism, there are two things. Either it could be a physiological palpitation or it could be a pathological palpitation. If the patient has in normal resting condition, the activity of heart is not generally perceived by the individual. But during intense physical activity or emotional stress, it's quite normal to become aware of one's own cardiac activity for a very brief or a short period. And this is termed as physiological palpitation. And anything outside this are to be considered as pathological. Little is known about the events responsible for it, but still, there are afferent sensory pathways or higher order cognitive processing that filters, modulates, and amplifies these stimuli and brings some to the conscious attention of the patient. There are possible sensory receptors located at various organs, along with possible brain centers involved in elaboration of these stimuli, probably subcortical areas or loss of frontal lobes or base of frontal lobes. If we look at the mechanisms that underlying palpitation are basically heterogeneous. It could be either due to contractions of the heart that are too rapid, irregular, or slow, as in cardiac rhythm disorders like sinus tachycardia, secondary to mental disturbance, systemic disease, or use of drugs. Or it could be very intense contractions and anomalous movements of heart in the chest, as in case of some structural heart disease. Or it could be due to anomalies in the subjective perception of heartbeat, whereby a sinus rhythm, sinus tachycardia, or minimal irregularities in cardiac rhythm is felt by the patient. And if any of these above are missing, probably it could be a centrally mediated fright reaction initiating a series of responses that include perception of the heartbeat. If we look at the etiology of palpitations, there was an article published in European Heart Rhythm Association in 2011, and also by the famous Weber and Kapoor, published in the journal 96 also. The most of the etiology range from cardiac itself accounts for 41%, followed by psychosomatic disorders 31%, and there is miscellaneous 10%, and the cause is unknown in 16%. If we look at the cardiac etiology, probably it is arrhythmias, anomalies in the functioning of the heart, cardiomegaly or heart failure of various etiologies. Psychiatric disorders range from a series of psychosomatic disorders like depression, somatization disorders, or anxiety or panic attacks. Systemic causes are very broad range, ranging from hyperthyroidism, hypoglycemia, postmenopausal syndrome, fever, anemia, pregnancy, hypovolemia, orthostatic hypotension, postural orthostatic tachycardia syndrome, pheochromocytoma, AV fistula. There are certain drugs like sympathomimetic agents in pump inhalers, vasodilators, anticholinergics, hydralazine, or withdrawal of certain beta blockers, alcohol, cocaine, heroin, amphetamines, all can cause palpitation. If we look at the classification of palpitation, this was published in the article Cardiac Electrophysiology Clinics in June 2018. They have grouped it into 4 major: extrasystolic, tachycardic, anxiety-related, and throbbing. Now, if a patient has a type of palpitation called extrasystolic, the subjective description by the patient is skipping a beat or the heart is sinking. The heartbeat is irregular, interspersed with periods of normal heartbeat, onset is gradual, and trigger situations could be a resting cause. In tachycardic patients, the subjective description is beating wings in the chest, regular or irregular heartbeat, sudden onset, trigger situation can be physical effort or cooling down, or there may be associated hemodynamic impairment. If it is anxiety related, the subjective description is mainly anxiety or agitation, heartbeat is regular, slightly accelerated, onset is gradual, trigger situations could be anything like stress, anxiety attacks, and the symptoms are often unspecific. Throbbing sensation, subjective description is with heart pounding, heartbeat is regular, and normal frequency. So when a patient of palpitation comes to you, what should be the key questions that you should consider asking the patient is important. If we take a careful history, we should always inquire for these questions like onset and offset, whether it was sudden or gradual, what is the frequency, daily, intermittent, weekly, monthly, or non-specific anything. Any triggering factor known to the patient, any associated symptoms like pre-syncope, syncope, breathlessness, or chest pain, or is there any underlying known existing cardiac condition. This is the very important slide in which I have given the key clinical findings on one side and the suggested diagnosis. This slide is entirely based on clinical practice and medically associated symptoms from the clinics and is not totally data-based. This slide has been taken from evidence-based approach to palpitations published in medical clinics in January 2021. If a patient presents to you With single skip beats, the suggested diagnosis could be benign ectopy, feeling of being unable to catch one's breath, likely VPCs, single pounding sensation, likely VPCs, rapid regular pounding in neck or palpitations, supraventricular arrhythmias, palpitations terminated by vagal maneuvers, supraventricular tachycardia that are worse than palpitations worse at night, most probably benign ectopy or atrial fibrillation, rapid irregular rhythm, we all know atrial fibrillation or tachycardia with variable block, palpitation associated with emotional stress, psychiatric cause, general anxiety, panic attacks, palpitation associated with activity, CHD or exertion, anything, CHD or IHD, rapid palpitation with exercise, supraventricular arrhythmia, medication or recreational drug use, drug-induced palpitations, positional palpitations point towards the AVNRT or pericarditis, friction rub, pericarditis, heat intolerance, tremor, thyromegaly, hyperthyroidism, heart murmur, heart valve disease, mid-diastolic mitral valve, mid-systolic click, mitral valve prolapse. So this is the diagnostic flow chart of patient coming to you with palpitation. All patients that present to you in the clinic with a symptom of palpitation should be done with baseline investigations like history, physical examination, and ECG. This itself will give you a clue in 33% of the patients your further approach to the patient. Further, if it is confirmed, definitive or suspected diagnosis is confirmed, plan for treatment, and if it is still unexplained palpitation, then we need to move on to the next level investigation, which is echo, ambulatory ECG, MRI, stress test, or electrophysiological study. Further treatment is required. If the palpitation is rare or infrequent and well tolerated by the patient, you need not do anything, let him go. So coming to the ECG, this is the gold standard. It enables physician to definitely determine whether palpitations are of arrhythmic origin or non-arrhythmic origin. If we do not get any clue from the ECG, because most often the patient who comes to you are asymptomatic, and at that time the ECG appears to be normal. In that case, move on to the next level, that is ambulatory ECG, which can be done for 24 to 48 hours. Prolonged ECG monitoring documents cardiac rhythm. The devices currently used for ambulatory ECG monitoring are grouped into two categories: external devices and implantable devices. External devices include halters, hospital telemetry, event recorders, or implantable like ILD or ICD. So this is the choice of ambulatory ECG monitor which we should consider depending on the symptom frequency. If the patient has a symptom frequency of daily to every second day, go for 24 to 48 hour Holter monitor. If it is weekly or monthly, plan for loop or event recorder. And if it is months to years, then go for implantable loop recorders. The advantage is that ECG and 24-hour Holter monitor can be done easily nowadays. But with this event loop recorders, these are implantable, cost, invasive procedure, and currently not, and also causes patient discomfort. So these are the disadvantages of the invasive procedures. So what are the indications for ambulatory ECG? When history, physical examination, and 12-lead ECG suggest a possibility of arrhythmia. In the setting of diagnosed structural heart disease or family history of sudden cardiac death, when patient needs reassurance and specific explanation of their symptoms, when symptoms warrant therapy and specifics of treatment depend on a formal arrhythmic diagnosis. These are the indications for planning an AECG. EPS study. Unlike ACG, EPS is a provocative test. It positively reveals only the presence of a pathological substrate or may not be responsible for clinical symptoms. Few studies used ACG monitoring to confirm results of EPS in diagnostic evaluation of patients with palpitations of unknown origin. It is regarded as diagnostic when induction of arrhythmias is accompanied by reproduction of spontaneous symptoms. When no arrhythmias with above characteristics are induced, it's regarded as negative. Now, approach to a patient with palpitation. Take a history, do a echo. If your diagnosis is confirmed, normal heart, normal ECG, manage. If not, then do not hesitate to refer. This diagnostic approach is for all primary care physicians or those who are working at grassroots level like PSCs. Now, management of patients with palpitations. The management depends on arrhythmia mechanism and implicated prognosis. Many patients can be treated with reassurance and support. Patients with certain occupations like pilots or commercial drivers need specialist referral for occupational implication. Patients with suspected or documented SVT should be educated regarding Valsalva maneuver, which can be often terminate the arrhythmia. So when we should consider for referral? Especially referral should be considered when there is a substrate for significant arrhythmia, atrial fibrillation or ventricular arrhythmia. This may be suggested by a history of structural heart disease, palpitation associated with syncope or pre-syncope or chest pain, family history of sudden cardiac death, high clinical suspicion, or specific referral often required after initial diagnostic workup completed for consideration. Red flag signs, which patients to refer and when to worry. Patients with frequent or persistent palpitations, sustained rapid palpitations, significant associated symptoms, pre-syncope or syncope, breathlessness, chest pain associated symptoms, family history of recurrent syncope or sudden death, significant resting 12-lead ECG, WPW syndrome, or signs of structural or electrical abnormalities. General recommendations for treatment of palpitation. Therapy should be directed towards etiological cause. Patients should be reassured in case of a benign cause. Use of adrenergic substances like caffeine, alcohol, containing beverages should be restrained. Good control of cardiovascular risk factors, specifically of hypertension, should be ensured. If there is recent stressful life, psychiatric counseling should be done. In patients with symptoms of anxiety or depression, a specific therapy is warranted. In a specific arrhythmia found, appropriate therapy may be antiarrhythmic drugs, ablation, or even an implantable defibrillator. In case arrhythmia is related to systemic disease, the use of proarrhythmic drugs therapy must be aimed to remove the underlying etiology. These are some of the criteria for hospitalization of patients with palpitations, diagnostic purpose and therapeutic purpose, severe structural heart disease, primary electrical heart disease, family history or sudden death, need to perform EPS. Therapeutic purpose can be bradyarrhythmias requiring implantable pacemaker, pacemaker ICD malfunction, ventricular tachyarrhythmias, supraventricular tachycardias, presence of heart failure or other symptoms, severe structural heart disease, severe systemic causes, severe psychotic decompensation. Management in a nutshell. First, management reassurance. Second, lifestyle modification, correction of comorbid disease, anxiolytics and beta blockers, antiarrhythmic drugs or electrical cardioconversion. Recurrent life-threatening ventricular arrhythmias are currently being treated with ICD devices. Thank you.
Thank you, Dr. Gagan Gunjan. You have presented such a nice case
Thank you, sir.
Palpitation.
Thank you,
which
sir.
may be due to normal physiological condition or due to cardiac or non-cardiac cause. Depending upon the cause, you treat the patient. Is there any question from the audience?
Yes, sir. Yeah, Dr. Gunjan, it was a good presentation, I would say.
Thanks, sir.
But I would like to know, in this post-COVID era, many patients are coming who have suffered from COVID-19 and they had no complaints of palpitation in the pre-COVID period, but they are coming to us with complaining of palpitation. And we are diagnosing it as postural tachycardia syndrome or different kind of arrhythmias which we come across. But they had no, this kind of symptoms pre-COVID. Have you come across such cases? And
Yes, sir, I do have come across such cases, but the origin is not of pre-COVID or post-COVID year. We are dealing with palpitation and we need to look for the etiology or the underlying cause. There is no direct association that COVID is producing this. There were some instances like vaccine-induced cardiomyopathies and other things, but there has been no documentation and no paper to date which says that it was exactly due to this. So all palpitations should be dealt with either cardiac origin, non-cardiac origin, basically grouping two things. Go for further investigations and treat it as a normal palpitation or normal arrhythmia cases.
This is a common complaint of those who were suffering from COVID. So they come and tell us that they are having palpitation, but on examination we find it normal. So it is a very normal presentation about the COVID patients. They experience palpitation, but they are not having palpitation. So thank you, Dr. Gunjan.
Thank you. Thank you, sir.
Okay. May I request Dr. Mundra sir to please come on the dais? Time for felicitation. May I request the chairpersons to please felicitate both the speakers. Both of them have done a wonderful job. And ऐसा लग रहा है कि हॉल में मैं अकेला हूँ. Thank you so much. मुझे सिर्फ मेरा ही आवाज सुनाई दे रहा है यार. Thank you so much. So memento from chairperson to speaker Dr. Mundra sir. Okay, पहले Dr. Gagan. Thank you. And memento to Dr. V.K. Mundra. And finally, memento for our chairperson, Dr. Agarwal, from both the speakers. Thank you. Moving ahead to the last but one session, our last session is very interesting, that is ECG. May I request the chairperson for this session, Dr. Sunil Nandwani and Dr. Wahid Khan. Is Dr. Wahid Khan here? So, Dr. Wahid Khan is not here. So Dr. Nandwani will have to manage alone, and I am sure अकेला 4 के बराबर हैं ये. May I request, okay, Dr. Nandwani to invite the speakers. Here we have got 3 speakers. Dr. Deepak, Dr. Nivedita Mishra and our Dr. Ram Kumar. Thank you.
Can the speakers please come up? Dr. Deepak, Dr. Nivedita and Dr. Ram Kumar. Nahin, ek, okay. Okay, sorry. Dr. Deepak from Jamshedpur. He'll be talking about how do we retard CTD progression and what's the evidence as of now. Dr. Deepak.
Good afternoon, everyone. As we all know, because of rising prevalence of diabetes, hypertension, obesity, other lifestyle diseases, and even global warming and pollution, there is a steep rise in prevalence of CKD. And many of the patients with CKD progress to ESRD, and we have got a very increasing pool of patients with ESRD that puts a huge burden on healthcare. So it's a very pertinent task upon us to try to retard the progression of CKD, and I will see what are the updates. Sorry, it's not moving. Can somebody help? This. Yes. Is it from that?
ये स्लाइड का क्या हुआ? इससे नहीं होगा?
हो जाएगा सर.
तो होना चाहिए ना.
So I have lost very valuable time. So this slide already has been shown by previous speaker. I would like to just add that whenever we come across a patient with CKD, there is a CGA system of classification. First we have to ascertain the cause, and then GFR category and persistent albuminuria category. That helps us in treating the primary cause and identifying the risk of progression to ESRD and guides us regarding the frequency of monitoring. So every patient comes with a different trajectory of progression. No two patients can be same. Some patients have stable GFR, some patients have linear decline, some patients have non-linear decline. So we have some equations to assess the risk of progression of a particular person to ASRD, and this also has been shown by a previous speaker. I would like to add just one thing, that there is 8 variable equation which includes 4 more parameters, albumin, bicarbonate, calcium and phosphorus, which are easily available in our practice, and this can add to more accuracy of the equation. This is a well-validated equation across many ethnic groups and populations around the world, and this helps in risk-based care. So what is the mechanism of CKD progression? Why it progresses? The first is underlying cause. If underlying disease is active, then naturally CKD will progress because of loss of nephrons, loss of renal tissue, and after some time, like after critical loss of nephrons, like when GFR level goes below 40 ml per minute, the remaining nephron has to work more to maintain the homeostasis of the body, and that adaptive mechanism gradually become maladaptive because glomerular hyperfiltration develops, and hyperfiltration related injury leads to further loss of nephrons. So once a patient enters into this vicious cycle, the CKD becomes naturally progressive. So this is natural progression of CKD. And apart from that, age-related decline after 40 years of age also adds to the decline in eGFR. So these are the drivers of CKD progression in type 2 diabetes mellitus: hemodynamic factors, metabolic factors, inflammation and fibrosis. So all these 4 drivers lead to tubulointerstitial damage and inflammation, glomerulosclerosis, mesangial expansion and glomerular hypertrophy, which ultimately leads to kidney fibrosis and CKD progression. So what do we have to retard the CKD progression of CKD? There is a paradigm shift in management of patients with CKD, with diabetes or without diabetes. Blood pressure control, RAS blockade, glycemic control, SGLT2 inhibitors, GLP-1 receptor agonist, non-steroidal MRA are the latest addition. And apart from this, these all have very robust data evidence backup to support their use. Lifestyle modification, smoking cessation, avoidance of nephrotoxins, adjustment of medication dosage, treatment of metabolic acidosis, all these are very important. Keto analog, gut probiotic, all these are not supported by sound evidence. So first, regarding blood pressure control. This meta-analysis includes major blood pressure control trials which have tested intensive versus standard blood pressure control. As you can see, Accord, Sprint and STEP trial is the latest one. And as you can see, the risk reduction is 17% when it comes to major adverse cardiovascular outcome. Stroke risk reduction is in the tunes of 30% if you combine all the data. But all-cause mortality not significantly reduced if you combine the data. But if you individually go by a sprint trial results, then there is significant reduction in all-cause mortality. So, but my area of concern right now in the presentation is reduction of renal risk. There is no renal risk reduction when it comes to intensive versus standard blood pressure control. But as we all know that CKD is a risk multiplier for cardiovascular disease. So we have to take care of cardiovascular disease to decrease the mortality. So intensive blood pressure control is supported because of that. These are some of the BP targets provided by some of the guidelines. KDIGO 2012, the target was based on albuminuria category, less than 140 by 90 in A1, less than 130/80 in A2, A3. ACC-AHA guideline, which was, the change was driven by sprint trial results. The target advised is less than 130/80, ISS2 2020, less than 130/80, 140/80 in elderly. KDIGO 2021 has become a little bit more over-ambitious. This is mostly based on the results of a sprint trial, which has shown mortality benefit. But the target of 120 is can be very hazardous, so it has to be tried in selected cases like patients who are young age and who have CKD3, because they are going to die of cardiovascular disease rather than going to ASRD. So, and one more thing I would like to add, that all these large trials have taken a standardized office blood pressure measurement, which we many times fail to take in our office. So a casual office blood pressure measurement and this target should not be taken together. So individualization is the key. We all practice in our patients' lifestyle interventions for lowering BP in CKD. I would like to just highlight the sodium intake. In patients of CKD, there is risk of hyperkalemia, so potassium containing salt substitutes should be avoided, and salt waste in patients with salt wasting nephropathy, we can't go for sodium restriction. Physical activity is very helpful in CKD, in decreasing blood pressure also, but in patients with advanced CKD, frailty and comorbidity may limit the feasibility of this intervention, but any exercise is better than nothing. Weight loss, reducing alcohol, healthy diet, all help in reducing blood pressure. Now the next question about the use of antihypertensive. Which antihypertensive is of choice? So RAS blockade represents cornerstone in the management of patients with CKD. This is the first drug which has been found to be very helpful in retarding the progression of CKD. So we should always try to include these drugs. If we go by level of albuminuria in this non-diabetic, this is a chart of non-diabetic G1 to G4 patients. If you go by albuminuria, in patients with A3, there is a strong recommendation 1B to use RAS blockade. This is based on the RAIN and AIPRI trials. In patients with A2, again RAS blockade is recommended, suggested. The grade of recommendation is 2C, and in patients with A1, even it's a practice point, it's expert opinion, you should try to utilize RAS blockade. This slide again in patients with diabetic CKD, the evidence here is very robust in patients with A3 category and in A2 category also. Micro-Hope trial provided very robust evidence to support the use of RAS blockade in A2 category. So overall, RAS blockade is very important. We should add it as early as possible. The next question, which is very important and debatable, should we continue or not to continue RAS inhibitor in patients with advanced CKD? Because stopping RAS will decrease the risk of hyperkalemia, and there is questionable improvement in renal function in long term. So, but it can buy some time for dialysis excess creation or preemptive transplant. But continuing RAS has advantage of improved cardiovascular mortality, a better BP control, fewer need of other antihypertensive medications. So let's see the studies. This is a STOP ACE trial. The question was, does the discontinuation of RAS inhibitors improve eGFR in patients with advanced CKD? As you can see in the upper panel, those who continued the RAS, the decline in GFR in long term was more, and their chances of getting into ESRD was rather less, and their major adverse cardiovascular events were less in those who continued RAS inhibitor, but those who discontinued had more chances. So the answer is clear that RAS inhibitor doesn't improve, discontinuation of RAS inhibitor doesn't improve eGFR in patients with advanced CKD. Now another big trial, more than 10,000 participants, and what they found that continuation of RAS decreases mortality by 13.6%, decreases mass events by 11.9% at the cost of more patients going into renal replacement therapy, 8.3%. So this study says that keep calm and carry on inhibiting the RAS till you have compelling indication to stop it, like very rapid decline in GFR or patients who develop refractory hyperkalemia. Now after BP and RAS blockade, glycemic targets in CKD, this has also been a very debatable topic. So KDIGO 2022 says that individualized HbA1c target ranging from 6.5 to 8.8%. So how you decide which will be 6.5%, in which patient will have less than 8% target? Severity of CKD, macrovascular complications, comorbidities, life expectancy, hypoglycemia awareness, resources for hypoglycemia management, and propensity of treatment to cause hypoglycemia. All this has to be considered, and this again should be individualized. So this is another meta-analysis, and this forest plot shows that the landmark trials Accord, Advance, and UKPDS, VAT in type 2 diabetes mellitus, the risk reduction of developing nephropathy was 20% with intensive glycemic control. Even in type 1 diabetes, DCCT and ADIC have shown that there is good risk reduction of developing all the microvascular complications, and in type 1 diabetes even macrovascular complications. So next is SGLT2 inhibitor. There is a paradigm shift, and this shift is because of SGLT2 inhibitors. After the results of empiric trial were published, that was followed in quick succession by publication of Canvas, then declared TIMI, Vertis CV, DAPA, then heart failure trials came, and kidney dedicated trials came like EMPA kidney, DAPA CKD, recent trials like Emperor preserved, Emperor reduced, deliver. So all have shown that there is risk reduction, significant risk reduction when it comes to cardiovascular outcome. Along with that, they have shown that there is significant renal risk reduction. So that's why, because of this robust evidence, KDIGO has given this recommendation that patients with type 2 diabetes, CKD, and an eGFR greater than or equal to 20 ml per minute, SGLT2 inhibitor should be given, and it should be continued till the patient goes on renal replacement therapy like dialysis or transplant. So this is the indication now, and you can see the grade of recommendation 1A, which is a very rare thing because of a stringent review system is there to review the guidelines. So 1A recommendation is very rare in KDIGO guideline. Now I can't discuss all the studies one by one. So a meta-analysis I have taken, that is by SMART C group, to see the impact of diabetes on the effects of SGLT2 inhibitors on kidney outcomes. The meta-analysis has taken data from 13 trials, including more than 90,000 patients with 15,000 patients without diabetes. Heart failure trials, many of the EMPA kidney trial patients were non-diabetic. So we have a good pool of patients without diabetes. And what they have seen, that the benefit of SGLT2 inhibitor in CKD is almost equal in patients with diabetes and without diabetes. And there was no significant heterogeneity about this. And the risk reduction overall is in the tunes of 37%. So this is quite significant. Now, what they have tried, kidney disease progression by diagnosis. So across all the spectrum of diagnosis in the patients who were participants of these studies, they have seen that advantage risk reduction is across all the subgroups: diabetic kidney disease, ischemic and hypertensive kidney disease, glomerular disease, other diseases. So across the group, the advantage extends across the group. Now the kidney disease progression by glomerulonephritis. And the very interesting data came out that patients with IgA nephropathy, the risk reduction of CKD progression was in the tunes of 51%. So this is something very interesting and useful. In FSGS, because of heterogeneity of the patients who come with different FSGS, it was not very impressive. Overall, it was very good risk reduction. And there was less chances of acute kidney injury, 33% to 23% risk reduction in acute kidney injury. Regarding the risk of amputation, it was very rare in the 90,000 patient, and it was not significant to even analyze the data. And there is higher risk of euglycemic ketoacidosis that we all know. Now next comes GLP-1 receptor agonist. KDIGO recommends that when a patient who is on metformin and SGLT2 inhibitors, or those who can't take it, and if glycemic targets are not achieved, then the next addition should be GLP-1 receptor agonist. So there is another meta-analysis of GLP-1 receptor agonist, particularly about this renal endpoints, and all these trials are CVOTs. So renal endpoints were analyzed secondarily, and you can see that there is 17% reduction of renal endpoints. Apart from that, macroalbuminuria reduced to the tunes of 26%, and in leader trial, liraglutide, semaglutide, and dulaglutide. These are the three molecules which has been shown to be particularly renoprotective. We don't have trial dedicated to primary renal endpoints in terms of GLP-1 receptor agonist. Flow and remodel trial are coming up with their results in 2024. Then we will see how they fare in renal outcomes. Then the newest addition is non-steroidal mineralocorticoid receptor antagonist. After Fidelio-DKD and Figaro-DKD results, this is the KDIGO recommendation regarding the use of non-steroidal MRA, Finrenone, and what is their recommendation? That those patients who are on type 2 diabetes mellitus and are on maximum tolerated dose of RAS blockade and have GFR greater than or equal to 25, if they continue to have proteinuria greater than 30 milligram per gram of creatinine, then we can consider adding non-mineralocorticoid receptor antagonist Finrenone. So this is the fidelity pooled analysis of these two trials, Fidelio-DKD and Figaro-DKD. You can see the reduction of risk is across all the groups. Endpoint cardiovascular event reduced by 14%, hospitalization from heart failure reduced by 22%, kidney composite outcome reduced by 23%, and dialysis by 20% during study period. So this is a very impressive data, and we can consider using it in patients who are on maximum RAS blockade. And FIND-DKD study is going to tell us about the use of Finrenone in non-diabetic CKD patients. So the paradigm shift is because now we have sealed most of the pathways through which CKD progresses. We can see that this hemodynamic dysregulation is being sealed by RAS blockade. Now SGLT2 endothelin receptor antagonists are still not being utilized clinically. Non-steroidal MRAs, inflammation is being taken care by SGLT2 inhibitors, GLP-1 receptor agonists, and non-steroidal MRA and RAS blockade. Hyperglycemia, we all know there are a lot of anti-hyperglycemic agents. So this is another slide regarding use of correction of metabolic acidosis in CKD. There are no very large RCTs and robust evidence to support the use of this sodium bicarbonate in CKD, but we use it because there are small studies which have shown the benefit. Apart from that, correction of metabolic acidosis leads to decreased bone resorption and increased muscle mass in CKD patient. So prevalence of sarcopenia is reduced. So because of all these benefits, sodium bicarbonate is utilized to target the bicarbonate or TCO2 level more than 22. Modifiable lifestyle factors from primary prevention of chronic kidney disease. This is a systematic review and meta-analysis. Of course, potassium intake, vegetable intake, physical activity, all these have potential to prevent CKD and can be utilized in early CKD to prevent progression of CKD, while tobacco, smoking, and salt intake has been found to be harmful in patients with CKD. Low protein diet, as studied in MDRD study, has been found to useful in retarding the progression of CKD, but there is no very sound data, and low protein 0.8 gram per kg body weight per day. If we go beyond that, then there is high risk of malnutrition, so we should avoid further further strengthening of this low protein diet. So this was the core curriculum summary in 2021 regarding the retardation of blood pressure, retardation of CKD in patients. Blood pressure control, RAS blockade, glycemic control, SGLT2 inhibitor, GLP-1 receptor agonists, all are very important. Correction of metabolic acidosis, dietary protein restriction, weight loss, and bariatric surgery. And the one drug which was not added because it has been added recently, that was non-steroidal MRA, Finrenone. Thank you all for patient listening.
Hello. So, yeah. A very, very daily problem. It's and Dr. Deepak, very focused, very targeted, and to the point talk. Very impressive. Very nice.
Thank you, sir.
And I think we should not also forget that progression of CKD parallels deterioration in retinopathy, in the retina. That we often forget. And I think there's a difference in protein recommendation for CKD patients who are on dialysis and not on dialysis.
Yes, yes, definitely, sir.
Yeah.
Yes. Actually, those who are on dialysis, they need more protein because of many reasons. Because of advanced CKD, their protein intake is compromised. With every dialysis, they lose 8 grams of protein. 4 hours of dialysis session means loss of 8 grams of protein. So they are always in a catabolic state. So they need more protein, like 1.2 gram per kg body weight per day is recommended in those patients. Regarding protein restriction, I would like to add one more thing, that vegetable source of protein are alkaline in nature, and the animal source of protein like meat, these are very acidic in nature. They have amino acid which release acid. So vegetable source of protein are not that harmful. We should always tell the patient to quit animal protein. I'm not talking about milk. I'm not talking about paneer. These are, you can take it as vegetable source.
Yeah. It's open to the house, please.
Yeah. I have two queries. Very good presentation. One is I would like to know about what is the status of dialysis. And another question is what is the
what dialysis, sir?
dialysis. And what is the status of artificial kidney transplant?
Yes, first I would like to add about artificial kidney. Implantable renal assist device that is being developed, but I think it's getting development since last 10 years, and it will be a revolutionary thing. It may take some time, but we don't have it's not available for human use. It's still in research phase, but definitely when it comes, it will be something revolutionary. And regarding your first question, I could not get it.
Dialysis.
Allo,
Yeah.
I'm not aware of that. I'm sorry.
I think what I have read is someone donates his kidney, his or her kidney for a temporary period, and then again takes it back to his or her body, something of that kind. So you do not need dialysis machine. It's
Yes,
a temporary
Sir,
donation.
these things are not in clinical use, and second, there is not enough evidence to support these kind of things. And earlier there was a lot of hype about gut dialysis. So probiotics came, but ultimately this was not found to be very useful. Some patients, so you have to individualize, but I don't have any idea of any other mode of dialysis.
One practical question. When we are starting ACE or ARB in case of CKD, then what to monitor, and
Yes.
how to monitor, and when to stop this ACE?
Yes. Whenever we are starting a RAS blockade, we should have baseline serum creatinine and eGFR. We should have serum potassium level, and within 2 to 4 weeks, we have to recheck. Apart from that, we should see other things also. If patient is on high doses of diuretics, if patient is dehydrated or hypovolemic. So before starting, better we should correct all these things. Once we start, then we have to call the patient within 2 to 4 weeks, and we have to repeat serum potassium level and serum creatinine and eGFR. If there is a decline in eGFR more than 30% after starting RAS blockade within 1 month, then we have to recheck what we have missed. And then if patient is not dehydrated, patient is not on other drugs which can cause loss of GFR, then we should consider decreasing the dose or stop. And regarding hyperkalemia, RAS blockade is such an important thing that we should always think of other sources of hyperkalemia like food, other drugs, and we have to correct that. We can decrease RAS blockade little bit, but we have to correct, and we should again restart it. In only cases of refractory hyperkalemia which are not responding to all these measures, then only we should consider stopping RAS.
Dr. Deepak,
yes,
I think it was an excellent presentation.
Thank you, sir.
And you have very nicely covered the whole subject. One comment and two questions.
Yes, sir.
The comment is that Findranon, the non-steroidal MRI, is the first and the only drug that is acting on the fibrosis of the kidney, preventing the fibrosis
Yes,
of the kidney.
very much
For
correct,
the
sir.
first time, we have a drug which is now acting at the basic pathophysiology. The two questions are, number one, we are talking about RAS blockers. Which one is superior, AC inhibitor or ARB? And
Yes.
second question, is there any role of beta analogues? Because I'm seeing a lot of prescriptions from the nephrologists writing NephroSafe and NephroGuard and all
Yes,
that.
yes, sir. First question regarding RAS blockade. If you go by evidence, sir, there is no difference between AC inhibitor and ARB. Only thing is that ARB are associated with less cases of angioedema, less problem with cough. But evidence-wise, there is no very robust data to suggest one against the other. So both are equal. Regarding your second question, sir, regarding the use of keto analog. The problem with keto analog is that the earlier studies which tried to find out the role of keto analog were done on very high dosage of keto analog. And I don't think most of our patients will be able to buy even that dosage of keto analog, forget about the tolerance. So we are prescribing in the hope that maybe the smaller dose will do a smaller thing, but we don't have data to suggest the same. Thank you, sir.
Achha, is there any cutoff mark for serum creatinine? Earlier it was teaching that if your serum creatinine is not more than 2.4, then we should not add RAS or ARBs. Earlier
Sir,
it was saying.
yes, sir. We have also gone through the same kind of cutoffs, but sir, there is no cutoff. Just keep monitoring and keep, like I have shown more than 10,000 participants from all over the country and what they found. So just we have to keep monitoring. There is one problem in our setup that many of the patients are lost to follow up. So monitoring part gets neglected. So that is one problem. But otherwise, there is no such cutoff. Even in patients with patients on dialysis, in some patients we have to use RAS blockade because they have very overactive sympathetic nervous system, and RAS activation is very high, and their blood pressure can't get controlled with anything except RAS blockade. So in exceptional cases, even in patients on hemodialysis or peritoneal dialysis, we use RAS blockade. So no cutoff, sir. There is no cutoff
One
for
more
now.
thing I would like to know. Earlier it was, what we are saying that nowadays.
Mic, please.
Many nephrologists, they are adding sodium bicarbonate.
Yes, sir.
Trial is very limited trial.
Yes, sir.
Basic pathology, as it is concerned, it is the hypertension and the diabetes.
Yes.
Hypertension is the number one which you have to reduce.
Yes.
You have to keep
Yes.
as less as possible, say preferably 134 by 82.
Yes.
But if we are adding sodium bicarbonate, most of the time what I am seeing in practical life, that their blood pressure becomes uncontrolled.
Yes.
Then, and again I remove as soon as I will remove the patient, again some nephrologist will add sodium bicarbonate.
Yes.
How will you justify it?
Sir, first I will go regarding pathophysiology. Hypertension, diabetic, all have clear pathophysiology. But once a person loses critical number of nephrons, the remaining nephrons have to work more to maintain the acid-base balance of the body. And more ammonium is getting excreted. So this leads to overload to the nephrons. So correction of metabolic, regarding the pathophysiology, correction of metabolic acidosis puts the nephrons on rest regarding the this homeostatic adaptation. And yes, there is problem of using sodium bicarbonate, that there is more chances of hypertension, volume overload, but there are benefits. Hyperkalemia, patients with bicarbonate are generally, their potassium levels are lesser, so that is the benefit. And we have to manage with RAS blockade and other drugs. But sodium, apart from that, as I told you, that sodium bicarbonate is not just for retarding the progression. It has a further role. It has been seen that sarcopenia, like patients lose muscle mass because of metabolic acidosis, chronic metabolic acidosis. So correction of metabolic acidosis has been shown to reduce chances of sarcopenia, and the patients have better muscle mass. There was a Creek study in which they have found that in patients who are in CKD stage 4, there is chronic metabolic acidosis in more than 60% patients. So prevalence of chronic metabolic acidosis is very common. Yes, we can get the bicarbonates, and if the bicarbonate is more than 22, there is no need of sodium bicarbonate. If bicarbonate is consistently below 19, then definitely there is role of correction of this metabolic acidosis. The adverse effect is hypertension and volume overload, but it is advantageous overall. And regarding the data, no studies, larger studies has been conducted, because you can take the home soda available and any sodium bicarbonate. It's a very cheap thing. So no pharma company or no other sponsor is interested in bigger trials. Thank you, sir.
Hello.
in lot of diabetic patients who are on metformin, we have found that there is gradual increase in serum creatinine in few patients. I want to know what is the cutoff of that serum creatinine where we will decide to stop metformin or to change or to lower the dose.
Yes, very good question, sir. Sir, metformin is cardioprotective. Metformin decreases. Metformin is very good for glycemic control, significant reduction in HbA1c. But metformin is not renoprotective. This data doesn't suggest that it's renoprotective. But metformin is very foundation stone because of its glycemic control and because of cardioprotective effect. And now there is GFR cutoff, not serum creatinine. GFR cutoff is 30. If GFR is less than 30, you have to stop metformin if being utilized earlier, or if you should not use if it is not in use. And if GFR is between 45 to 30, better half the dose of metformin. That is what is recommended. And of course, if patient is on metformin for more than 4 years, then get the vitamin B12 level done. That is what is recommended.
Dr. Deepak, marvelous talk, very impressive. बहुत अच्छा लगा.
Thank you, sir.
Big round of applause for him, please.
Thank you.
Yeah, we'll
and
have
thank you, Birmani sir, Ramkumar boss, and everyone to give me opportunity to talk here. Thank you.
You have to give thanks to me also.
Sure. Thank you, sir.
Yeah. Next speaker is Dr. Nivedita Mishra. LPA, yeah.
ये next और pointer अलग से Good afternoon, Chairman sir. Good afternoon, Chairperson sir, and good afternoon, everyone. So, after listening to 2 days of listening to speakers of national and international repute, I decided to give my biodata a skip. So when Dr. Virmani gave me this topic, I was slightly confused in the beginning, and it took me some time to understand. So we'll see what it means. I have no financial disclosures to make. So starting from a broader perspective, atherosclerotic cardiovascular diseases have a huge burden. In the last maybe 30 years, the numbers have almost doubled, coming to 523, last counted in 2019. And deaths also have increased from 12 million to around 18.6 million. And among the risk factors for atherosclerotic cardiovascular diseases, after hypertension and diabetes, lipid disorders have been in the 3rd place for so many years now. Famous trials like PROVI trial and TIMI-22 trial have shown that lower LDL levels only can provide greater clinical benefits. And the primary goal of all lipid lowering treatment is to adequately reduce the serum concentration of LDL. This serum lipoprotein A, this was initially earlier pronounced as lipoprotein little a. Its concentration is also a very important but not fully appreciated risk factor for ASCVD. The trials like Jupiter studies have shown that LPA is also an important determinant of residual risk for cardiovascular events. It was discovered about 60 years ago and as an independent risk factor for cardiovascular diseases like CAD, peripheral vascular disease, and calcified aortic valve disease. It was thrust into limelight in 2009 when significant evidence from Mendelian randomization studies and large cohort studies showed its association with ASCVD. Although it was first identified in the 1960s, it's only recently that its structure and function has been fully understood. Most clinicians do not check LPA in daily practice with an explanation that there is no effective drug treatment. But universally, it may be the most predominant monogenetic lipid disorder with an approximate prevalence of a level more than 50 mg% among an estimated of 1.4 billion people. Its serum concentrations are in 90% of cases genetically determined, and lifestyle changes do not have much effect on its concentrations. And so far there have been controversies about the exact values because of various isoforms of the molecule. The concentration, still the agreement has been reached that the concentration both in fasted and fed state should be lower than 30 mg/cent. And epidemiological studies have confirmed that 20% of subjects throughout the world have a genetically determined increase of more than 50 mg/cent. And in families who have familial hypercholesterolemia or people with acute coronary syndrome, even 30% of people may have elevated levels of this LPA. So the risks has been classified into 3 groups according to the levels: 30 to 50 mg/cent of moderate risk, more than 50 mg/cent high risk, and more than 180 mg has been considered very high cardiovascular risk. The latest European Atherosclerotic Society guidelines still suggest a cutoff point of more than 50 nanomole per liter, which comes to around 10 mg/cent. But it has been said that we should strive to determine in nanomoles per liter because it determines not the mass of the particles but their number, which is more important. This graph shows the average distribution of high LPA in around 20% of population in Europeans. 20% they have more than 50 mg/cent, and even 30% having more than 30 mg/cent. And the relative risk according to the level has been found of 1.28 in those with 10 to 50, then 50 to 100 is 1.44, and more than 100 is 2.14. So that makes it quite a significant factor as a risk factor. So this diagram shows us briefly the structure and the properties and relation to various factors. It consists of a lipid-rich domain, primarily forming of cholesterol esters, and a apolipoprotein A. This is the molecule. The apolipoprotein A binds to apolipoprotein B100. This is the one. Through a single disulfide bond, which is A, which is nearby the LDL receptor binding site of apoprotein B, which is B. And the apoprotein A contains repeated Kringle structures. It is called Kringle, whatever that means, K4 and K5, comparable with those in a plasminogen molecule. And other factors such as ethnicity, genetics, medical and environmental conditions also play roles in LPA regulation. And it has been traditionally associated with increased risk of atherosclerosis, thrombosis, and aortic valve calcification. So coming to the influence of genetics and ethnicity, it is predominantly determined more than 90% by genetics. The K4, which we heard, the repeat polymorphism explains the variability in LPA concentration. There are various short nucleotide polymorphisms. They are responsible for the inverse correlation between the isoform size and the LPA concentration. And its level varies with ethnicity in increasing order: Chinese, white, then South Asian, then black individuals. And this is a long list of conditions, non-genetic influences, where the lifestyles do not have much influence. The various hormonal conditions have little influence. Chronic kidney disease have some little influence, and hepatic impairment and other inflammatory conditions, all of them have various mild decrease or increase in influences on its concentration. And this shows the summary of all epidemiological and genetic evidences for association of LPA concentrations with clinical outcomes. Myocardial infarction and ischemic stroke both have meta-analysis of prospective observational studies, but outcomes like angina, ischemic stroke, peripheral arterial disease, aortic valve stenosis, they all have cross-sectional studies, prospective observational studies, genome-wide studies, and large Mendelian randomization studies in their support. Venous thromboembolism do not have any evidence, and all-cause mortality also have few lacking in data lacking in this group. And the clinical trials are all ongoing. So it has, LPA has been found to have a pro-inflammatory and pro-atherosclerotic properties, which may partly relate to the oxidized phospholipids carried by the LPA molecule, and a potential role in prothrombosis and antifibrinolytic has only in vitro data, but not proven in vivo. So high LPA, it will induce the expression of inflammatory and calcification genes in vascular and valvular cells. That is why it is associated with increased incidence and progression of aortic valve sclerosis. In primary prevention settings, it is associated with several ASCVD outcomes as well as AVS and cardiovascular and also all-cause mortality, as we have seen. And the evidence comes that above 75th percentile, it is associated with AVS, aortic valve sclerosis and MI, but still more higher levels, more than 90th percentile were associated with increased risk of heart failure. And for cardiovascular mortality and ischemic stroke, still higher percentile has been associated. And this shows the absolute risk of 10,000 person years in the various disease clinical outcomes, aortic valve stenosis, stroke, MI and heart failure according to the various levels. And this was taken from a huge study of white individuals in the Copenhagen General Population Study, which shows that the correlation, the relative risk of various conditions with LPA concentration, which is most marked for aortic valve stenosis and MI and little less correlated with ischemic stroke and heart failure. In secondary prevention studies, people who already have documented cardiovascular events, it is also associated, but still there is some heterogeneity among the studies. In one meta-analysis, LPA levels of more than 80th percentile were significantly predictive of recurrent events in already statin treated patients. In them, when the relative risk is 1.4, but the baseline LDL level was less than 130 mg/cent. Coming to individual conditions like aortic valve stenosis, it was known since as long as 2013 that the LPA locus is a major contributor to aortic valve sclerosis. It is associated with both microcalcification and macrocalcification, especially in relatively young healthy individuals. It may also promote faster progression of aortic stenosis, culminating in earlier aortic valve replacement or death. Coming to other cardiovascular outcomes like stroke, it is depending on the etiology. In the ARIC study, it said that LPA concentration and LPA genotype are associated with the risk for non-cardioembolic stroke. Another biosignal study where the LPA levels more than 100 nanomole per liter were associated with recurrent stroke. And the gene locus is also a strongest genetic predictor of peripheral arterial disease. So with a low level of LDL or VLDL, is this a risk factor? So in a large primary prevention study, this association was abrogated at a lower level of LDL cholesterol of less than 100. But there are other studies like Jupiter trial, it shows that the baseline LPA level and the first incident cardiovascular event was similar both above and below the LDL concentration of 110. Even as low as 54 mg/cent, it had a linear correlation. But for thromboembolic events, the data is not so conclusive, it is controversial and it is based on in vitro data. And in humans, however, there is a slightly increased risk of venous thromboembolism at a very high LPA, more than 95th percentile. But even again, it was not supported by Mendelian randomization studies. So ultimately, I could get hold of one reliable consensus statement, European Atherosclerotic Society, published in as late as October 22. So I would like to go through in details on its consensus statements. So epidemiologic and genetic studies strongly support a causal and continuous association between LPA concentration and cardiovascular outcomes. It is a risk factor even at very low levels of LDL cholesterol, and high LPA is associated with both microcalcification and macrocalcification of the aortic valve. Current findings do not support it as a risk factor for venous thrombotic events and impaired fibrinolysis. Very low LPA levels may associate with increased risk of diabetes mellitus. Of course, it merits further studies. It has a pro-inflammatory and pro-atherosclerotic property which may partly relate to the oxidized phospholipids carried by LPA. And they recommend testing of LPA concentration at least once in the lifetime of an adult. And cascade testing has a potential value. It means testing in people all who are genetically related to the patient in diseases, people who have familial hypercholesterolemia or with families or personal history of very high LPA or premature atherosclerotic cardiovascular disease, which we are seeing nowadays not very infrequent. Without specific therapy, early intensive risk factor management is recommended. Lipoprotein apheresis is an option for very high LPA with progressive cardiovascular disease despite optimal management of risk factor. So this briefly summarizes all the points of the cardiovascular society, the atherosclerotic society. This is the molecule, this shows the causal association, risk factor for AVS, not risk factor for thrombosis, very low, may be associated with type 2 diabetes. So for LPA testing, it recommends should be measured at least once. Screening is also recommended in youth with a history of ischemic stroke or family history of premature CVD. Cascade testing in the setting of familial hypercholesterolemia, as I said, and this shows that the LDL cholesterol reduction needed to reduce the global cardiovascular risk. If we cannot control the LPA level, the level has to be, LDL cholesterol has to be reduced. And if the risk factor, if the modification started at age 30 years, the required reduction in LDL level is lesser, that is 0.8 millimole per liter. But if we start at age 60 years, it has to be even more aggressive to reduce by 1.5 millimole per liter. So what to do if we have a patient in front of us? In the absence of approved specific LPA lowering drugs, this panel recommended early intensive management of other risk factors for individuals with elevated LPA levels. And personalized management of LDL cholesterol, BP, glucose and lifestyle factors is recommended to reduce the ASCVD risk sufficiently to mitigate the increased risk caused by elevated LPA. And lipoprotein apheresis can be considered in patients with very high LPA and progressive ASCVD despite optimal treatment, as some uncontrolled data shows that there is some benefit. And with PCSK9 protein convertase and all that, monoclonal antibodies, the absolute CV reduction was higher for higher baseline levels. 4-year study showed that the risk reduction was 2.41 versus 1.41 with LPA of more than 50 versus less than 50. In Odyssey outcome trial, it was 3.7% with a LPA level of more than 60, but 0.5% when the LPA is the lowest quartile. However, PCSK9 has still not registered for LPA lowering. Niacin is also not recommended because of its lack of clinical benefit in true outcome studies, and also the data do not support targeting aspirin use. So that leaves us with little therapies, but there are emerging therapies which are showing very good percent reduction and very good outcome, though the long-term outcome studies have not been done. These are known as antisense and small interfering RNA treatments. They target the apolipoprotein A production in the hepatocytes, and thus they lower the LPA concentration. In early trials, it decreases from 80 to 72% were reported. Then there are antisense oligonucleotide molecule called pelacarsen, which was tried in 2 doses, 20 milligram weekly, sorry. This is the one. Yes. So 20 milligram weekly and 60 milligram every 4 weeks, and it showed 98% and 81% attaining a LPA level of more than 125 nanomole at the end of the studies. And molecules olpasiran and N-acetyl galactosamine, these are all conjugated small interfering RNA which interferes with the production of lipoprotein A. It showed reduction ranging between 71% to 97%, which were sustained over 6 months. Both treatments showed a favorable safety profile. So that brings us to the end of this topic.
This little molecule that got lost in the sound level of managing cholesterol levels Dr. Nivedita, thanks for collating all the data of this rarely studied thing and bringing it to this audience. Very well, very scientific and to the point. Open to the House.
Sir.
I must congratulate you for doing full justice to this topic. Your
Thank
talk
you,
was fantastic. Thank you.
Thank you, sir.
Dr. Virmani, that was a good topic to give. Yeah. Any questions, any comments? Thank you, Dr. Nivedita. Wonderful job, as usual.
I'll take this opportunity to also thank Dr. Birmani to give me this opportunity. Dr. Birmani, Dr. Mundra, Dr. Umesh Khan sir, and the whole team, Dr. Arya, for really having the vision to have such a great conference. I was really feeling as if I am sitting in one hall of the National API conference. Really very happy. And our days, all the physicians working for 12 hours, we hardly get time to catch up with the fresh guidelines. So this is the best way. I took one day leave and listened to all guidelines. Now I don't have to go to Google or books. Thank you, everyone.
Thank you. जब सब कुछ खत्म होता है तो हम तो राम कृपा पर जाते हैं ना. So we'll call Dr. Ram now. Yeah. And Dr. Ram, the floor. Super specialists.
Good afternoon. My topic is a little bit different, has no relevance to science and no relevance to data. So, बहुत सारा डेटा और साइंस आप लोगों ने पढ़ लिया. So, Dr. Birmani is giving me, you have to speak on this topic. Have super specialist made internist redundant? I will rather call have sub-specialist made internist redundant. So I will go start with that. So this is the Sir William Osler, and this is the statement given by him. Okay. The good physician treats the disease. The great physician treats the patient who has the disease. The great physician understands the patient and the context of the patient illness. So, we as an internal medicine, we treat ourselves as a great physician for this time now. Don't take it otherwise. So, coming to now with the current status in the era of super specialty in India, what is the current scenario of treatment of the patient where you are lacking? Why we need internal medicine? Few days back, my patient from Delhi called me, Ram, I have left Hajipur and I have joined Delhi in Noida. There is a huge scarcity of internal medicines. There is no internal medicine doctor in Delhi. All are going for super specialty. So this is the one of the findings taken from Lancet, and this says that this is a percentage shortfall to the extra percent of personnel required as a portion of current availability. So in the case of doctor, current availability is 50% per 1 lakh, and there's 49% more are required to meet the target of 85%. So similar are there with the other specialty also. The Ayush doctor, the dentist, pharmacist, nurses, midwifery, and auxiliary nurses, midwives. Then I was searching the net where we could find some relevance to put this. So this is one of the Sachinta Sharma is the great journalist of Hindustan Times, and he says that the hospital requires advanced care are needed for media emergencies such as accidents, heart attack, stroke, and cancer. But for minor symptoms like fever, it's best to go to family physicians. So super tech does not always means a better care. So this is for the statement given by the Sanchita Sharma. She takes care of the healthcare journalist from Hindustan Times. So this is the overview of healthcare providers in India. You see that 70% care is taken by the private care. Outpatient 70%, 60% inpatient care. And the public healthcare system is lacking. They are taking care only of 30%. And they are the planner who advocates super specialty program in our curriculum. They are informing the curriculum to go for the super specialty. So this is the current challenges in healthcare system. There is privatized, expensive, and urban-oriented system. Tertiary care hospitals even for the minor illness. Demand of specialization are higher. Then there is acute shortage of rural family doctors, and there is lack of primary care approach. There is many factors for that. So now you have to understand what is the role of internist and what are the role of a specialist. So an internist is a fully trained specialist. An internist is a fully trained specialist who practices internal medicines. They provide high quality specialist services across spectrum of health and illness, not limited by the boundary of medical subspecialties. Physicians adopt scientific approach to patient as a whole person, that is holistic approach, to take care. And so the physician can provide cost-effective care, whole patient. They treat patient as a whole patients with a human touch. So care of the complex comorbidity provide much needed cost-effective care with minimal cross-referral to subspecialties. Although their role are complementary rather than competitive. At the same time, I will highlight only that there is compartmentalization of the care in the when you go to the super specialty, and they need a collaboration with other healthcare workers. Only then a better care can be given to the patient. So internists provide preventive care such as routine checkups, the immunization, health screening, etc. By identifying potential health problems early on, primary care physician can help to prevent serious illness from developing and reduce the need for cost intervention later on. Ensure that patients receive appropriate care and avoid unnecessary treatment. They develop long-term relationship with the patients, which allow them to provide more personalized care and better understand the patient health history and individual needs. Then if you see a specialist care, there is a multi-system medical problem lead to multiple subspecialty opinion and not always in best interest of patient or delivery of cost. So effective care is lacking. Even the higher cost, effective care is lacking there. So in nutshell, what is the wrong with the specialization? With the growing sophistication of technology, the super specialists have become increasingly dependent on technology and instrument to make a diagnosis. This has unfortunately led to clinical medicine taking a backseat. This has also made therapy more expensive, more tedious, and more inhuman. So, example is given here. When a middle-aged male comes with a chest pain, he undergoes a hemogram, full biochemical profile, renal and liver functions, ECG, TMT, X-ray, echo, angiography, CT scan, and then they are still the diagnosis of dry pylorus is missed by only auscultation with the stethoscope. So, and then there is a gatekeeper mechanism developed in USA nowadays. The cost issues have come under increased pressure in recent years with the emergence of managed care in USA and institution of gatekeeper mechanism for limiting access to a specialist. Even for us in India, the time has now come to analyze the role of an internist in the era of super specializations. So, an internist is not an intern. Internist is a fully trained specialist who practices internal medicine, I tell you. He is a master clinician, a diagnostician, the doctor trained on the basis of super specialty of medicine, someone totally familiar with the heart, the lung, the bowel, and the kidney, someone trained to decide if a skin problem is the result of joint disease, if the murmur might represent a cancer, someone who understands the age, know when to welcome death and when to fight, knows both the hold a hand and pound the chest, someone able to step beyond the boundaries of organ system or a technique into the realm of diagnosis. His or her gift or diagnosis flow from the sound of knowledge of science of super specialty and from the art of the medicine also. So some physicians need to be able to handle the wide spectrum of emergency medical admissions. It has been shown that many acutely ill patients are managed well by the general physicians. Patients representing vague symptoms benefit from the skills and knowledge of physicians who have retained a general approach, and there is no proof that super specialization always results in better outcome of the patient. So data from the literature do not support the idea that centralization of treatment of patients with solid cancer per se lead to improved result. So problems such as boredom, poor undergraduate teaching, high physicians-patient ratio, high cost, and insufficient coverage for emergency may arise with the super specializations. Now question comes, who manages emergency better, a super specialist or an internist? The super specialist care is not only more costly than generalists, but also less satisfying for the patient due to compartmentalization I told you earlier. Moreover, when patient comes to the casualty, it is not always possible to identify the relevant specialty straight away. So at that point of time, it needs clinician who understand a wide range of specialty, but at the same time, another strategy should be to make available all the super specialty in the emergency to decide where to go that patient. So a patient look for the wrong super specialty is likely to be poorly managed. So with a greater degree of specialization within the system, the staff will see fewer patients from aligned specialties and thus runs the risk of atrophied general expertise. So this is an example of tunneling of vision. Don't take it otherwise. Patients come to us with a diagnosis of chronic fatigue syndrome with a complaint of increased breathlessness. First he went to consultant pulmonologist. He suggests CT thorax, pulse oximetry and sputum test. And he included that this is not my case, go to cardiologist. He says echo, treadmill and angiography. And endocrinologist suggested it is a hyperactive thyroid, which means more tests. So finally came to physician and he was diagnosed a case of chronic fatigue syndrome. So why this is happening? This leading to despairing specialty. We are older than the subspecialists. The number are reduced, declining numbers in teaching hospital, significant shortage in metropolitan. I quoted example my friends. The reason for that is expansion of exploration, advances in technology-driven specialization care, historical inequality in remunerations between proceduralists and non-proceduralists, and increasing full-time specialists in teaching hospitals. This has a huge impact on healthcare. First one is patient inconvenience, increased visit to multiple specialists and longer hospital stay, coordinating care and opinions from the multiple referrals, concerns of rehospitalisms, and super specialty increased cost with commensurate return in improved outcomes. Without, there is a problem in India also, you can see that the poor referral system is there. So we need more generalists than specialists. Generalists of special interest rather than super specialists and more super specialists. Researchers and policy makers who focus their attention mainly on developed West often forget this aspect in India. So what should Indians do? They should have 5 attributes: sensitivity in response to human suffering and vulnerability, scientific approach, realizing that priority of state and society must flow from priority of concern for the individual rather than reverse. Ideas of equity and fairness should be tempered by the knowledge of variation in health status. Dear audience, each person represents a different story. That story includes their disease, their new problem, their social situation, their belief. How we understand the story, you must develop excellent communication skill and gather the history in appropriate depth. Only then we will be able to know the exact situation, and accordingly we can treat those patients. This is a word for the health planners. Doctors are asking to become super specialist because later is perceived to have better market value. After MBBS, doctors go rotatory internship followed by MD, 3-year course, then rushes to become a super specialist, that is under 3-year course. So between the MD and the DM, he has no clinical expertise, they has no clinical experience of managing the patient. This is a real scenario. I have worked in the AIMS. The MD doctor do not treat the patients. Patients are treated by the senior resident over there. They only read and they prepare for the DM exams. So most senior physicians feel that thorough grooming internal medicine is very essential to become a super specialist also. So this is also a word for super specialist to accordingly follow their plans. So their internist here is to stay. Instead of pushing him away, he should be made the indispensable pivot around which the patient care should revolve. His status should be enhanced. He should be primary care physician of a given patient, and he should choose when and whom to refer the patient, and should the need for super specialty consultation crop up. So the conclusion is that a more general approach of internally is optimal in identification of newly presenting disorders and poorly defined symptomatic syndrome. As the Indian population ages, an increased proportion of individuals will have disease in multiple organ systems that will require simultaneous medical management. There will be a greater need for coherence in clinical care and someone to make nuanced judgment concerning the clinical priorities, including when to exercise tranquil distance in clinical management. Even in the future, it appears unlikely that the team of a specialist can be on the day all the time and will learn to collaborate effectively in sharing individual patients' care. So often a question is asked, is general medicine too broad a discipline, too hard to master? So this is best answered by saying, is life? So with that I have left you a picture to decide, and this picture tells everything. So thank you for listening.
Dr. Ramkumar.
Thank you, sir.
And the best part are the last two lines. Beautiful. And my usual, when I discuss it in the family about super specialists and internal medicine, I've come to realize that each family needs a doctor, and he should be an internal medicine man. Because across the board, within the core family, extended family, friend circle, social, it's the internal medicine man who provides the best guidance. Brilliant.
Thank you, Bhimani, sir. Initially I was very much hesitant. I thought that I should change my topic.
Oh, last two lines were brilliant, sir. Anything, any comments? Okay.
Thank you so much. Final, put your hands together. We have come to the end of the session and only ECG is left now. May I request our chairperson to please hand over the memento to our speaker, Dr. Ramkumar. And madam, please, I will invite all the speakers on the dais, please. Dr. Nivedita, Dr. Deepak. So the first memento would go to Madam Dr. Nivedita by our chairperson, Dr. Sunil Nandwani. All the speakers to join, please, for the photograph. सब आ जाइए, पास में आ जाइए. Thank you. Next to Dr. Deepak. Thank you. Next to Dr. Ramkumar. Thank you so much. And finally, memento for our only one speaker, Dr. Nandwani, by all the 3, 1 chairperson by all the 3 speakers. Dr. Nandwani sir, privileged. Thank you so much. Now I think we will move to the last session. May I request Dr. Pal sir to please take over the session on ECG. I am very happy that he is coming with his measurement tool. Yes. Thank you.
अच्छा एक Thank you. At the onset, I must thanks to the organizers of the Japicon 23, especially Dr. Virmani and his team, to give me another opportunity to discuss the ECG. And I don't know why he is keeping me at the last. And only request is that, please don't cut short my time. And request to the audience that, if you feel I am doing any injustice to the subject, you just raise your hand, I will stop. So, with these few words, I will discuss the ECG quiz, and it will be very fruitful and very interesting if you participate with this. And quick participation should be there. There should be no wastage of time also. कैसे इसको करते हैं? Up and down कैसे करें? इस स्लाइड के लिए और ये कोई पॉइंटर नहीं, हम इससे करेंगे, इससे करेंगे, इसे नेक्स्ट करो. कहाँ नेक्स्ट हो रहा है? So my first slide is इसे. How it is? It's not operating. इससे करेंगे. हाँ? कैसे करते हो? हाँ, ठीक. So this is my first slide. This is a very simple slide. You just focus on the rhythm strip. There is no doubt there is a left bundle branch block is there, and there is normal PR interval. I am interested in what is happening in the rhythm strip. Pardon please? Tachycardia, yes. What? Give mic please. Anyone?
Coming to abrupt stop after this third lead.
Third lead there is a
third lead is my chest lead.
Okay.
V4, V5, V6. That has come to abruptly stop. The rate becomes becomes 60 per minute.
No,
Before that it was 100 per minute.
Don't leave the ECG. Yes.
And there is one extra systole also.
Yes.
After AVF, AVL, whatever you say. After that there is one extra systole. Lead was
I am talking about the rhythm strip. Don't go for the above strips. The rhythm strip, what is happening? So there is an extra systole is there. I do agree with that. Anybody? Pardon, please. Give the mic, please.
Is it aberrant conduction is going on?
Aberrant conduction, yes. So there is aberrant conduction in the one. Yeah. This is aberrant conduction. Now I will explain what is happening in this ECG. In the third bit you see, in the third bit you see there is a premature extra systoles. If you can see the T wave, this T wave is deformed. So there must be the P wave which is followed by a normal QRS. So this is a APC, which is a premature. Second, in the interval there is a wide complex is there. This P is also slightly deformed.
and so this is aberrantly conducted. The APC which is normally conducted, this is aberrantly conducted. If we come to the fourth one, this T is slightly deformed than all this normal T wave. So there is another P wave is falling on the T wave which is non-conducted. And if you see, this is the disturbance, the interval between the RR interval is not being disturbed by this P. So this is an interpolated APC bit. And because it is interpolated, the PR interval following the QRS is slightly higher than that because of the concealed conduction. So there is a interpolated bit is there. And last one is there is another APC which is not being followed by a QRS. This is a non-conducted APC. So there are 4 things are happening in this ECG in the rhythm strip. There is a premature atrial contraction. There is aberrantly conducted. This is an interpolated APC, and this P is not being conducted. This is blocked. So these are 4 things are happening in the APC. We don't find these things in normal APC. Why this is happening in this case? Pardon please? Sinus? Sinus is sick. Sinus node disease. So he is telling there is some defect in the formation, the P wave and the sinus node. Okay. Anybody has got any explanation of this? Pardon please? Electrolyte imbalance. What kind of electrolyte imbalance do you think? Low potassium. Low potassium usually gives rise to positive U waves.
It may be because of heavy nodal disease.
Heavy nodal disease, another one is the heavy nodal disease. But I will try to explain this one. But why this is happening? Because there is a 3 mechanism of formation of APC. 3 mechanism. First mechanism is a re-entry phenomena. And second mechanism is increased automaticity. And third wave is the triggered activity, which is usually the toxicity of the digital is. So whenever there is a re-entry mechanism, the coupling interval means this QRS and the P wave is always fixed when there is a re-entry mechanism. But here it is not fixed. There is slight difference is there. So this is an increased automaticity. And because of the increased automaticity, the rate of firing is not always constant. First. Second, there is some form of sinus arrhythmia must be going on the sinus node, which is disturbing the cycle. And that's why it is normally conducted, aberrantly conducted, interpolated, and there is a non-conducted beats. Are you agreed with this? Thank you very much. So I will go for the next one. Now this is a rhythm strip. What is happening in this rhythm strip? What is your diagnosis? Pardon please? Previous one. Sinus arrhythmia is not a disease of the sinus node, it is a normal phenomena for the sinus node to change during respirations. And sinus arrhythmia may be phasic, non-phasic and ventriculophasic sinus arrhythmia. Phasic, this is a variation with the respiration. Non-phasic, there is no variation, and ventriculophasic which occurs during the complete heart block. So what is happening in this case? Be quick. Anybody? Sir, madam, please. Madam, mic. Thank you.
It is Venke.
Venke back. Very good, madam. Thank you. This is a Venke back phenomena is there. There is a PR interval is increased. There is a progressive increment. There is a drop bit. But what is happening here in this case? There should be a normal PR with PQRS conducted. But this is not happening. There is a I won't say this is a fusion beat, because fusion beats always the P wave comes before the QRS. Here there is a QRS is coming, after that the P wave is formed. So this is a escape nodal beat with a block P wave. Escape nodal beat with a block P wave. Why this is happening? Because a very prolonged PR interval in the Venke back. The escape bit is coming and the P wave which is coming after that is blocked. So there are in this Wenkeback is a typical form of Wenkeback where there is a 2 blocked P waves are there with a escape bit. This is the explanation. Are you agreed? Next, what is happening? What is your diagnosis in this ECG? 2:1 block. Okay. So, do you think that in case of 2:1 block, there should be the equal interval of the PP interval? Here the PP interval, this P and this P and this P and this P, the intervals are same or not? It's not same. If 2:1 block, this P should come in the middle. It's not coming. So what is this? Sinus bradycardia, very good. This is a sinus bradycardia. And what is very obvious is a low voltage. These are the two things which are very common. Sinus bradycardia is low voltage.
Hypothyroid.
Hypothyroidism. So, low voltage. What is the definition of low voltage? In case of limb leads, it should be less than 5 millimeter. In case of 10 millivolt standardization. And in the chest leads, it should be less than 10. And another definition is if you add 1, 2, 3 of the limb leads, if it is less than 15, and if you add the V1, V2, V3, and the total voltage is less than 30, then it is called a low voltage. There are two types of, the second one is very sensitive. So first, second is that why the low voltage occurs. There are low voltage occurs because of the 4-5 reasons. If there is a air, if there is a very fatty lady, fatty man, then you will get a low voltage. If there is a fluid, you will get the low voltage. If there is a air, emphysema or the COPD, you will get the low voltage. Besides this, if the battery is low, if the battery mechanical or the hypothyroidism where the battery is very low, battery is not getting supply because the BMR is low. That's why in case of hypothyroidism it is low. So this is a low voltage ECG. This is a low voltage ECG with sinus bradycardia. But if you see, I'm interested with this P wave. Can this P wave be occur in this way? Usually P wave has got a very good contour, rounded contour, but these P waves are very peaked. So this is atrial premature beat which is blocked. This is not 2:1 block. In case of 2:1 block, the PP interval should be same. But in this case, this is a atrial premature beat which is not being conducted. So this is the atrial premature beat is not being conducted in the bigeminal form. What is the commonest cause of sinus bradycardia? This is the commonest cause of sinus bradycardia, not myxedema or not any other disease. Blocked atrial premature beat is the commonest cause of sinus bradycardia. Agreed? Pardon please? Just a minute. काम नहीं करता ये. This is not what. This is P wave is there. And this is the P falling on the T wave. That's why it is.
But T wave configuration is same almost in all this.
Yes, P wave is always same. Where? This one? This one? This one is the QRS. This is a low voltage QRS. This is the T wave which is the peaked one is because of the blocked P waves.
Sir, P is not very much appreciable in this case. That's why.
P wave is not?
Very much appreciable, sir.
Hi, because of the low voltage it is not being appreciable.
Maybe.
So next. This patient has got this type of problem. The carotid sinus massage is done and the
Mobius type 2, I think.
What is happening and why this is happening and how serious is this is?
It is like Mobius type 2, no?
Mobius type 2 block. So where it is Mobius type 2 block? This way or this way? In that way is a Mobius type 2. Dr. Saab has told this is a Mobius type 2 block. This is a AV nodal block where there is a PP interval, the PR interval is fixed and suddenly there is a drop bit is there. Suddenly there is a drop bit there. So this is a PR intervals are the fixed and there is a drop bit. This is 3:2 Mobius type 2 block. This is 3:2 Mobius type. This is 4:3 Mobius type 2 block is there in this case. and the carotid sinus massage is given, and then there is a block improves. Block has improved with the carotid sinus massage. This also indicates this is a Mobich type 2 block. Now, the QRS interval is more. So, if this is happening during block, if it is happening during block, it is not previously. So, the block is in the bundle. If it is V1 lead, it is the left bundle, the focus is arising. If it is a right bundle, it is the left, right one, it's arising. So, because in 1:1 conduction, the block is persisting. So, this block is not in the bundle, but it is in the infrahis or intrahis. I will say infranodal intrahis. Infranodal intrahis. Why this is happening? Why carotid sinus improves the infranodal block? And this is a vomiting. This is a normal case. And there is a vomiting. After vomiting, the patient has got 2:1 AV block is there. This is the just reverse of the previous one. The vomiting means there is an increased carotid sinus pressure. So, this is improved with carotid sinus pressure, that one, and that one deteriorates with the carotid sinus pressure. So, why this happens in the AV node and intrahis? What is that? Because the AV node has got a very peculiar character. It is rest of the myocardium, it is different. In a myocardium, we know that with a decreased heart rate, the refractive period increases. The example of that you have seen in case of atrial fibrillation with Asman phenomena. You have seen when there is a long gap, there is a aberrantly conducted. This is a because of the decreased heart rate, the refractory period increases. This is physiological. This is physiological. But whenever there is a rate-dependent bundle branch block is there, this is not physiological. This is pathological. Although rate-dependent bundle branch block is more common than that of the Asman phenomena, but this is a pathological. That patient must have got some form of abnormality, either ischemic, localized, whatever may be, that is happening. So, in this case, in the previous one, because this is the block is in the infranodal. Second property of the AV node is the vagus nerve supplies only the AV node. It does not supply SA node and AV node. No other part of the heart is being supplied by that. So, when you do the vagus stimulation, that there is a rate decreases, the AV node gets more time to conduct. So, the infranodal tissue gets more time to receive the impulses. That's why the infranodal tissue block is improved with the carotid sinus massage. But the opposite happens with the AV nodal block, and they deteriorates with the carotid sinus massage. So, what treatment is needed for this and that one? What treatment is needed for this and this one? Anybody? Who needs pacemaker?
Previous one.
Previous one. Previous one needs pacemaker. How urgent this is, you think?
Should be done.
Huh?
It should be done, must.
Now, how early? Should we wait? The
No,
patient
we
has
should
to
not
manage money and all those things. Why?
Because you told I said infrahisian block.
Infrahisian block means this is a different thing, by carotid sinus and sympathetic starch. But why this is? This block is very important. If you see 2:1 block in the infrahis or intrahis, intrahis means narrow complex. Infrahis means wide complex. So, definitely that's why. Why they will go to the complete heart block? Why? Because if you go to the physiology, the SA node and AV node depolarize through the calcium channel. They have got the very slow P2 but the rest of the myocardial conduction tissue, they depolarize through the sodium channel. You have seen sodium channel, they follow the all or none law. From the membrane potential, it goes to the threshold potential, and then suddenly, either it will stimulate or it will not stimulate. So, if you don't stimulate, what will happen? It will go. So, that is the reason the intrahis or infrahis block should be immediately asked for the TPI followed by PPI. Otherwise, the patient may not respond. The one single attack may be the last attack. So that's why this is done. Sir, all are non-law, depolarization is followed by them. So this is wrongly printed. This is a narrow QRS. I am sorry. This is a narrow QRS. This is a tachycardia is there, and there is a normal sinus rhythm. P wave, QRS, P wave, QRS, P wave. But here there is a no P, the QRS. Only tachycardia is narrow QRS tachycardia. That is very simple and very important and very common. What is this tachycardia? Any PG student, any junior should? Huh? PSBT is a big term. It will include atrial tachycardia, sinus tachycardia, sinonotrial atrial tachycardia, AV and RT. Dr. Deepak has told that is AV and RT. What is the full form of AV and RT? It is AV nodal re-entry tachycardia. I told there are three form mechanism: re-entry mechanism, automaticity, and triggered activity. Forget about triggered activity. That is only digitalis is responsible for. The rest of the tachycardia, it is a re-entry phenomena is the most common, and that is sudden onset and sudden offset. At automaticity, gradually warming up, gradually off. And third thing is that automaticity, the mechanism which the automaticity is the tachycardia, they don't respond to the DC shock. Because always the DC shock blocks the one arm. But here it is, DC shock does not work in case of automaticity. The example of automatic tachycardia is, one example very common, atrial tachycardia. Atrial tachycardias are usually automatic tachycardia. They respond to pharmacological therapy or radiofrequency ablation. Now, what is happening in this case? This is a AV nodal re-entry tachycardia. In the AV node, there are two pathways are there, slow pathway and the fast pathway. If the re-entry can occur from the slow pathway, antegrade conduction, and retrograde conduction, the fast pathway. This is normally, this is called typical AV nodal re-entry tachycardia. As it is coming to the slow pathway and going back through the fast pathway to the atrium, so the ventricle and atria both are activated simultaneously. So P wave will be visible or not visible? When they are simultaneously conducted, the P waves usually not visible. But if it is at all visible, it will be visible in the terminal part of the QRS. You can see the V1. If you see the V1, there is a small notch is there. There is small notch is there. So this is the P wave. This is the P wave. So this is a typical AV nodal re-entry tachycardia, and that is slow fast pathway is there. Why the P wave is small in this case? Why the sinus P waves are the large, but this P wave is small? No, that should be either visible, no RP tachycardia or RP tachycardia. No, the P wave is being formed by the atrial activation. Why? There is also atrial activation, but why this P wave is small? Because it is coming from the AV node to the septum, and from septum it is spreading and activating both the atrium. So mid-septal activation of the atrium. In case of the SA nodal, what happens? First from the right atrium, then left atrium, so there is an addition. That's why the P waves are large in case of sinus node, but not in case of the AV nodal reentrant tachycardia. They are small. If it is typical or atypical, they are usually small. What is the treatment in this case? Very simple, vagal stimulation or the AV nodal blockers should be given, and if it is permanently, if it is repeatedly occurring, then radiofrequency ablation. Very simple. This is the bread and butter of the electrophysiologists. Now what is, this is another tachycardia. There is a wide and narrow QRS tachycardia. What is the mechanism and diagnosis? This is a wide complex tachycardia, this is a narrow complex tachycardia. What is the mechanism of this? I will show first. I will see what is happening in this case. If you see the rate, suppose 1, 2, 3, 4, 1 to 3 I am seeing. These are the wide complex tachycardia I am seeing. Okay, 1, 2, 3. Now in the narrow QRS tachycardia I will see the rate. What is happening? 1, 2, 3. faster, which one is slower? This one is slower. This is the ventricular tachycardia. Madam is saying this is ventricular tachycardia, but ventricular tachycardia never follows a typical form. This is a V1 has got the LBB. V6 so is from the LBB. Ventricular tachycardia never forms any typical bundle branch block pattern. So this is not ventricular tachycardia, but this is must be some aberrant conduction is there. Tachycardia. Why? So these are the two different tachycardia, same tachycardia. So in case of aberrancy, why the rate will be slow? The complexes will be wide. If the cycle is same, AV nodal re-entry or whatever atrial tachycardia with bundle branch block, why the rate will be slow?
Huh? Maybe passing through normal conduction it is.
Pardon me, please?
This is passing through normal conduction. This one is
normal,
passing through muscle.
This is, you mean to say this is sinus rhythm? This sinus tachycardia?
This is not sinus tachycardia. This is SBT only.
Ah.
This is passing
Which
through
form
maybe
of SBT I am talking? Which form of SBT?
AVRT maybe. AVRT.
AVRT. Atrioventricular reentrant tachycardia.
Right.
You mean to say atrioventricular reentrant tachycardia?
Yes.
Follow, you all have followed this one, what he is saying? He is absolutely correct. That is also known as accessory pathway mediated tachycardia. So, AVRT, atrioventricular reentrant tachycardia. What happens? There are two forms of atrioventricular reentrant tachycardia occurs. One form is that orthodomic tachycardia, where the impulse comes antegradely through the AV node and goes back to the atrium through the accessory pathway. So that is usually narrow complex. And second one is antidromic, where it is coming from the accessory pathway first and go back to the AV node. So in that case, the QRS tachycardia is wide, and in the initial part of the QRS, there is a pre-excitation because it is coming through the accessory pathway. So this is not pre-excitation is there. Anywhere there is no pre-excitation is there. But if we see, this is the orthodomic tachycardia, and there is a coming from the AV node and going back to the atria, and this is orthodomic tachycardia. I do agree, absolutely correct. Second thing is why this is widening. Because suppose in the right side, on the left side, the bundle is blocked. Left bundle is blocked. Now what will happen? That it will come to the antegrade conduction AV node, it will go to the right bundle branch and will trouble through the ventricular wall and will go back to the atria. So the cycle will be narrow or wide? It will be wide, it will be more. So the rate will be slow or fast? Rate will be slow. So this is the cycle becomes wider, and that's why it becomes the wide complex tachycardia with a slower cycle. When the block improves, in that condition the narrow complex tachycardia occurs and the same pathway happens. So if there is a left bundle branch block during the block in tachycardia, it means the accessory pathway is in which form, which side? In the left side. In the left side. So this is a AV nodal reentrant tachycardia, orthodomic tachycardia developing initially. There was a left bundle branch block pattern, and then the left sided accessory pathway, and then the block improves and the tachycardia cycle becomes shortened and the rate improves. So this is orthodomic tachycardia. Now what is happening in this tachycardia? What is happening? This is two narrow complex tachycardia. One or two? There is a two narrow complex tachycardia. There is you can see this is one type of narrow complex. Here the P waves are positive. So after this complex there is another tachycardia starts, and before this complex there is another tachycardia is there. So what kind of arrhythmia is going on in this case? Deepak, you told initially, typical AV nodal re-entry. So what comes the DD in the typical AV nodal re-entry, and if that cycle is reversed, what will happen? It will be fast, initially it was a fast slow. So there is no P wave is seen. P wave is seen anywhere. So it is no RP tachycardia. But second part, it is a P wave is seen. And it is a P wave is, if you see in the lead 2, it is inverted. And it is the long RP tachycardia. It's a long RP tachycardia. If it is coming from the fast pathway and going back to the atria through the slow pathway, so it will take more time and then it will go to the atrium. So it is a long RP tachycardia. So there will be, initially there is a slow, fast, typical AV nodal re-entry tachycardia. Later there will be a fast, slow pathway. Now how to confirm this is the same? It may not be. For that, the tachycardia cycle in both cases will be same or different. Rate will be same or different. Suppose the typical AV nodal re-entry, the cycle is same. If there is atypical AV nodal re-entry, same cycle is same. So the rate should be same or different. Same. It should be same. Now let me see.
No.
So the typical AV nodal re-entry tachycardia is not being converted into the atypical re-entry tachycardia. Then what is that? Then it comes the DD of the long RP tachycardia. What are the DD of long RP tachycardia? First is the atypical nodal re-entry tachycardia. Second is atrial tachycardia. Second is the atrial tachycardia, most common. So this is atrial tachycardia. So typical AV nodal re-entry tachycardia is converted into atrial tachycardia. And where is the site of the atrial focus? We have to see the P waves. The P waves are in the 2, 3 AVF, they are the negative, 2 negative. So this is from the lower part of the atrium it is going and is stimulating. So it is a low focus atrial tachycardia in the second half. In the first half it is no RP tachycardia, and that is the reason. Am I correct? Oh, sorry. Yes. This is another narrow complex tachycardia, and there is a one P is not being conducted. And again, after the blocked P wave, the tachycardia resumes. So what is this tachycardia? Acute atrial tachycardia, atrial tachycardia, atrial flutter, AV nodal re-entry tachycardia, AVRT tachycardia. First is that whether this is atrial flutter or not. 10 minutes, sir. So what is that? Flutter or not? This is not flutter because in the flutter there will be isoelectric line should be there. But here you see that there is no isoelectric line. There should not be isoelectric line. But here it is isoelectric line is present. So this is not atrial flutter. Whether this is the AV re-entrant tachycardia. AV re-entrant tachycardia, why not? You are correct. Why not?
Pre-excitation is not there.
Huh?
Pre-excitation point is not there.
No, orthotomic tachycardia will not show the PSA. The antidomic will show.
P wave is clearly visible.
No, AV nodal re-entry tachycardia, AV nodal re-entry tachycardia can never be persist after AV nodal block. Because the pathway is coming from the AV node. If you terminate that block, the tachycardia will terminate. So that cannot be. So AV node re-entrant tachycardia will not there, atrial tachycardia is not there. AV nodal re-entrant tachycardia can occur. The P wave is clearly visible. And this is coming So this is not AV nodal reentry. What is left? Atrial tachycardia. So this is atrial tachycardia. So I have been asked to finish within 10 minutes. So I will just see which one should be. This is another very good example. I will go fast, and 4 ECG I will cover. So this is on arrival, the patient has got, sorry. On arrival, there was a broad complex tachycardia was there, and the rate was 170 per minute. And then the patient was given adenosine, and the rate becomes 195 and narrow complex tachycardia. So what is happening in this case? A broad complex tachycardia, adenosine is giving, it becomes a narrow complex tachycardia. It is not being terminated. What is the usual dose of adenosine you give? It is 12 milligram, 6 milligram, 12 milligram. But it is 3 milligram is given. So insufficient dose of the adenosine is given. And the tachycardia becomes faster and narrower. I have already told. A wide complex tachycardia becoming faster with narrower is a reentrant tachycardia. Reentrant tachycardia. I will discuss this ECG. This is a ischemic heart disease. Where is the site of block in this case? My question is not in case of where is the site of block and all those things. I am interested in showing that in case of anteroseptal MI, what are the conditions where the inferior leads will show the ST elevation? First, if it is a distal LAD lesion, if it is a distal LAD, proximal LAD, mid LAD will show the inferior lead ST depression, but the distal LAD will show the either ST flattening or the ST elevation. Second, if it is a wrap-round LAD in that condition, it will also show the inferior lead ST elevation, because in this case, there is a ST elevation in V1, V2, V3, and also in the inferior lead. Both the artery cannot be blocked. LAD and RCA cannot be blocked. The patient cannot survive. So this must be the either distal LAD or distal LAD, or there is a wrap-round LAD. Now if it is a distal LAD, V1 will not show the ST elevation. V1, V2 should not show. This is V1, V2 is showing the LAD. So this is a proximal LAD lesion, wrap-round lesion. Now whether this is serious or non-serious, suppose it is proximal to the S1, so there will be proximal to S1 as well as the inferior lead has gone. So the inferior lead will not show Q wave. Inferior lead will not show Q wave if there is a proximal LAD proximal to S1. Here you can see the inferior leads are showing Q waves. Inferior leads are showing Q waves. So this lesion is safer. If would not be shown the inferior lead Q waves, that will be more dangerous. So in a LAD lesion, if the inferior leads, the message is that LAD lesion, inferior leads, wrap round LAD, if Q wave is present, it is distal LAD. If it is proximal LAD, proximal to S1, it is always very dangerous, because the basal infarction and inferior infarction polarity cancels each other. The P wave does not exist. Q wave does not exist. Just one ECG. These two. What is this one? Alternate QRS is changing. Alternate QRS is changing, but they have got the previous P wave is there. Always there is a P wave is there. P wave is there. So this is alternate right and left bundle branch block. So it's a very serious condition. Immediately the patient should be sent for the angiography. But in this case, there is also the QRS voltage is changing. QRS voltage is changing. This is known as bidirectional ventricular tachycardia. Bidirectional ventricular tachycardia. What is the commonest cause of this bidirectional ventricular tachycardia? This is the digitalis toxicity. And what is the new entity which is most important to giving rise to bidirectional ventricular tachycardia? That is known as CPVT. Catecholaminergic polymorphic VT. During the exercise, the patient develops polymorphic VPC. Ultimately, they will develop the CPVT, polymorphic ventricular tachycardia. This is very sinistrous condition. And this is because of the defect in the calcium ion resorption in the ryanodine receptors of the sarcoplasmic reticulum. Normally, calcium ion inhibits the troponin and actin ions come in contact. And then it is being taken up by the sarcoplasmic reticulum, the ryanodine receptors. If there is a genetic mutation of the ryanodine receptors, it cannot take. So calcium overloading is there and they cannot inhibit the contraction. So actin myosin contraction continues for a long time, and this leads to ischemia and all those problems. And besides this, there is acute coronary syndrome, aconite poisoning, and many other things but they are very, very, very rare. Now the last ECG I am telling, this is the last one I will. This is. This ECG I am showing only because if you analyze the ECG, you can interpret in different way also. In this ECG, when I was analyzing, and there are two explanations. There is a, what is happening, there is no P wave. There is also, before QRS, there is no P wave, there is no P wave. So there is a sinus arrest with a nodal rhythm. So this is sinus arrest with the nodal rhythm, and this is like that. But, second way, if you see, there is a peculiar pattern is going on in the second term. There is a nodal P wave and there is a notch. So this is nodal P and there is a notch. The alternate beat has got the nodal P and notch is there. And on the another one, there is the sinus conducted beat is there. And this P wave is slightly different than the P wave. So there must be a P wave and conducting the QRS. So what is happening? This P is retrogradely conducted from the nodal rhythm, and this is very close. And after some time it is slightly prolonged, and this prolonged P wave retrogradely conducted, also antigradely conducted, giving rise to this reciprocal beat. So you can explain any ECG in any ways. So there is no sinus node disease is there. There is no sinus node disease. No AV nodal block is there. But this is because of the sinus node rate has been decreased. So there is the appearance of the AV node focus. And if you give atropine to this patient, sinus node will activated and the patient will, everything will vanish. So you can explain ECG in your own ways, in a different way, in all ECGs. So this is one example of ECG where two explanations you can give. The sinus nodal disease is nodal rhythm, and there is AV dissociation. Second is not, it is not that. The AV nodal disease is retrograde conduction, and this P wave is very close, this P wave is little bit. So there is a Wenckebach retrograde conduction. Wenckebach retrograde conduction giving rise to a retrograde reciprocal beat. So thank you very much. Thank you. Thank you very much.
Thank you, sir. May I request Dr. Umesh Khan, sir, to hand over the memento? Sir, please. Loud round of applause for Dr. S.K. Pal, sir, ECG king, not only of Jharkhand and Bihar, of the country, I should say, at least of East India. Very learning and very thank you. So we come to the end and Dr. Virmani will do the needful.
Thank you. Excellent. Excellent. I know time was a bit short for you, but next time I'll see that you'll get sufficient time. We are at the end, and it's just, I know everybody is hungry for lunch, but we'll have 5 minutes of validatory function, which is traditional. And before I start the validatory, Dr. Umesh Khan, please stand here. We would like to felicitate 3 persons. Is Dr. Veena Mundra there? Dr. Veena? Yeah, please come. See, yesterday, all of you know, she was anchoring the inaugural program and it was wonderful. And then she sang wonderful songs. Can I have that plaque and shawl? Hello. Plaque and shawl, please. Parpreet. Please come to the center now. A big round of applause for her. Then there were two other people from the pharma industry who helped us a lot. I would like to invite them and felicitate them. Shashi from USV, please come. And Deepak from Velix. Is Deepak there? Deepak from Velix. Deepak is not here? बुलाइए बुलाइए जल्दी जल्दी. Deepak is not here. अच्छा, anyway, Deepak को दे देंगे. Can you, Arpreet, वो उनका ले आओ तो जरा Dr. Tamal Dev वाला. Dr. Tamal Dev could not be attended yesterday because out of station. We had felicitated some senior doctors. So I'll request Dr. Nandwani to please take this and give it to him from our side. And हाँ नहीं अभी खत्म नहीं हुआ जस्ट कुछ बोलना था क्या क्या पहले आप खत्म कीजिए अच्छा ठीक है आप देख लेंगे I'll request Dr. D.K. Singh to come and say a few words regarding the conference.
Thank you, sir. Indeed, it's my great pleasure to stand in front of you as newly elected API President of Jharkhand, Chairman. And I am really thankful to my mentor and the person who guided me, and none other than the most young, still in my sense, most person who is the really bubbling and most energetic person, Dr. Anil Kumar Birmani. And I would like to thank also Professor Dr. J.K. Mitra and Dr. S.K. Pal, who has been guiding me always. And I think that they will give support in the coming future to me also. And as so far regarding this conference is not less than any national conference, in my opinion. I have been attending API since 1988, attended so many RSDI, CSI, but this is the first zonal conference, I would like to say, or a state conference, which is best I have ever attended. Secondly, if I had to say that because it is customary to say in validity session, that you have to praise the things, you have to say something about the conference. And here I would like to say in simple one line, एक कश्मीर कली का गाना था, तारीफ करूं क्या मैं तेरी, जिसने तुझे बनाया. So this conference was organized by all the team of the Jharkhand, and it was so well organized that it's very difficult to explain or praise anything. And these words, I just give thanks to Dr. Anil Birmani, Dr. Umesh Khan, our secretary, Dr. Ram Kumar, Dr. A.K. Arya, Dr. Satish Kumar, Dr. Vijay Mudra, who is my, who has been talking to me in between the conferences also, and all other pharmaceutical house, they have also exerted a lot. And once again, I hope that they will support me in the coming year also when I will organize the conference. Thank you, sir.
I can assure you, Dr. D.K. Singh, that Jamshedpur will support you fully, but you have to garner support from Ranchi and Dhanbad. You see that they are activated and motivated, and we are always there with you. Please don't worry. Dr. Jaiswal, would you like to say something very short? Anybody else who wants to say, please come over. Anybody from outside or from Jamshedpur? Dr. Dilip? Acha, Dr. Jaiswal, Dr. Dilip. Just last two, I think.
All good things should come to an end, but I don't see an end to this. It is just a comma. The full stop will never be there because the baton has been transferred to one of the dynamic doctors of Ranchi, Dr. D.K. Singh. Things will be much better, I suppose, sir, and that's a challenge for you. And I think with our mentor around and all the good doctors, Dr. Umesh Khan, Dr. Arya, Dr. Palda, Dr. Mundra Sahab, all taking such keen, and of course, the young and budding Dr. Ram. I'm not able to see him here. Yes. You are the future of this sort of activities which will be happening maybe 20 years hence. And that time you have to take the lead, and you are under good mentorship of Dr. Virmani, Dr. Dilip. Everybody is a stalwart here. Just I will fail if I commit for more names. An outstanding program in which we had the privilege to learn many things. Thank you for everything, sir.
I am hearing from all quarters of the gathering, from my friends, my outsiders, doctors, and all pharma leaders, that this is one of the best conference, and we feel proud. I myself, because one of the team member, and the credit goes to all my team members who has done everything for making this event successful. Total sum of all influence is the personality, and it's the Birmani who has chosen the team, who has exerted a lot day and night since last 2 months, and Dr. Umesh Khan, Dr. Mundra, Dr. Arya, and all my friends, Dr. Nirmal, everybody has exerted a lot, and we feel proud that you have made us felt successful. We are feeling successful only because everybody is praising that, yes, it is a feast in all ways, feast of food, feast of academics, and feast of everything. That's why I am very, very pleased. Thank you, everybody. Thank you very much.
I think the entire Jamshedpur team deserves full congratulations. API Jharkhand had unfortunately gone into suspended animation in the previous 4 or 5 years. But the last 1 or 2, I think 2 or 3 years, It has really become very active. And I think it is only two persons I would like to give credit. The dynamic chairman, ex-chairman now, Dr. Umesh Khan, and the dynamic secretary, Dr. Mundra. Dr. Mundra, please come here. And I'll request all of you to please give a standing ovation to these two stalwarts who has taken API Jharkhand to great heights. Umesh, please. Thank you. And as usual, I will hand it over to Dr. Umesh Khan to have the last word.
Now the conference is going to be end, but emotionally this will not end ever, forever. Now I request all my core members of the API Committee Association for API Jharkhand State Chapter to felicitate our senior member, our senior colleague, and the person behind the game, Dr. A.K. Birmani sir. Please come. कल डॉक्टर बिरमानी से मैंने कहा कि आप कभी कभी सिगरेट पी लेते हैं, तो काहे नहीं बंद करते हैं? बोले हाँ, कहाँ पीते हैं, कभी कभी पीते हैं। बोले आपको अपना जरूरत हो चाहे नहीं हो, हमको आपको हम लोगों का बहुत जरूरत है। सो प्लीज टेक केयर ऑफ योर हेल्थ एंड एवरीथिंग। थैंक यू एवरीबॉडी, थैंक यू।
लंच आप लोगों का इंतजार कर रहा है. You can join for the lunch at Alcor 1. Thank you. And this is lunch for all, including the pharma people. Also praise the team of Dravesh Jha. Very much thank you for excellent. Deepak, Harpreet and his team. So everybody can please join the lunch at Alcor at this point of time. Yes, first for Alcor.